Please welcome Foreign Policy's publisher and CEO, Andrew Solinger.
Hi, everyone. Please keep eating. Applause to me. Applause to you for joining us at our first hybrid event that we're doing. We've done some live programming since the world started opening back up slightly, but we're so happy to have you here joining us on a very timely and important topic on health and pandemic preparedness. We're so happy to have you here. An action-packed program with fantastic guests, as I'm sure you will agree, and we're going to kick that off right now in just a moment, but I wanted to give you just a quick couple of housekeeping items. First of all, we want you to participate in this discussion. We want you to ask questions, and the way you can do that is by scanning your QR code or going to foreignpolicy.com/program, and there will be a spot for you to ask questions. That's how we're going to field questions from both our in-person audience and the many, many more people who are dialing in and zooming in online right now to watch our program. Our team will be monitoring those questions real time, so have no fear. We will get those and get those to the speakers right as they are talking to their guests. Masking. You are all trained health professionals of some sort or another. You have attested that you're vaccinated, that you're healthy, and we trust you in that. So thank you for that attestation. But we also recommend masking. There are some folks here who feel more comfortable that way. We're not going to police or in any way reprimand to your comfort level. But of course, when you're eating, drinking, speaking from the podium, it's perfectly fine not to wear a mask. And very importantly, I was just chatting with a few of them. I want to thank our sponsors for supporting this program. First of all, Guarding Against Pandemics for sponsoring this lunch. Thank you very much. Gabe Bankman-Fried, really great lunch that we're enjoying right now in this discussion. Also partnering with us are AstraZeneca, thank you very much, the Global Fund, Securus, and IntraHealth. And lastly, I want to give a special thanks to Pharma. They are sponsoring our cocktails, it's actually a VIP reception, which will take place tonight at 6 o'clock. So please stick around. It's a long day of programming. We've got a lot to talk about, but we're going to kick that off right now. I'd like to introduce our first discussion, a one-on-one with Peggy Hamburg, former FDA administrator. Very happy to have her here, commissioner of the FDA and chair of NTI Bioadvisory Group. She will be in conversation with my colleague, Allison Carlson, who is the managing director of FP Analytics, our in-house research division, and also leads our events team. Over to you, Allison.
Great, thank you, Andrew. Thank you all for coming today, and thank you for joining us live online as well. And a special thank you to Dr. Hamburg for being with us here today to kick off our first hybrid event, and one that is so critically important at this juncture. What we're really focused on today, and what the conversations later today will really kind of outline and explore, are what are the lessons learned over the last few years, looking at what has transpired and evolved over the COVID pandemic, and what can we do differently, how can we invest better, more efficiently, so that we're greater prepared going forward. Now, I know you have had a long career in preparedness, and so I'd like to kick off the conversation by asking you, going back to your New York City Health Commissioner days, what were some of the early lessons learned in outbreaks pre-COVID? What were some of the priorities then and investments that you were making then that can inform outbreaks going forward and that we can carry on coming from here?
Sure. Well, thank you very much. And there were important lessons learned back in those days that I think really matter today. One was to take the threat of infectious diseases very, very seriously, to try to respond as rapidly and as comprehensively as possible, the importance of having programs in place on a daily basis that matter for health in terms of the ability to recognize potential emerging threats, but also to respond with appropriate care and support. The important recognition that public health is a form of public safety, and that it really needs to be invested in a sustained an adequate way, just like we invest in our fire department and in our police. Public health really needs that kind of commitment from political leadership down to support in communities. One of the things that was really an eye-opener for me in New York City was realizing that not only did we have to deal with issues of emerging and resurging diseases. HIV/AIDS was a major issue when I was health commissioner in New York City in the 1990s, as well as the resurgence of tuberculosis in new and more dangerous forms in terms of drug resistance. So addressing those concerns, but also recognizing that as a major urban hub for travel and trade, but also people living in close proximity, that we had to think about diseases that might be unexpected, but might be brought in from travelers and people coming from other countries. The other area in terms of public health threats and preparedness that I had not thought about before, but I did when I was in New York City, was the threat of domestic terrorism and biological agents potentially as deliberate threats to human health and safety. I was health commissioner the first time the World Trade Center was bombed. And people forget about that, but it was a very significant event for the city and for all of us in charge of protecting health in the city, certainly. And that was when I really began to think about deliberate use of biological agents to do harm. And all of these things come together, though, in thinking about the need for a comprehensive, robust public health system that is adequately supported in terms of sustainable dollars, in terms of trained workforce, in terms of engagement with communities and with the healthcare system and with the support of the leadership of the city and the government more broadly.
Absolutely, and when you talk about that, you talk about investment and investment over time and sustainability. And so when you think about the last few years, where have some of those systems failed and where do investments need to be more targeted to enable that sustainability and that continuity over time?
Well, I think COVID sadly has shown a very harsh light on some of the gaps and dislocations in important systems for public health on a domestic and on an international level. I think that, starting with our country, we really have to ensure that we have a robust national system for public health. I think that we have a system right now that is both under-resourced and has been for a very long time and underappreciated, but it's also very fragmented by its very design, because it involves state and local health departments as well as federal government health activities. And we saw during COVID how that fragmentation really undermined the ability to have a strong, coherent, consistent response. And the other sad truth is that some of those failures undermined public trust and confidence in public health institutions and public health leaders. That, of course, was all, also unfolding in the context of extraordinary political divisiveness and suspicion of expertise and a failure to really align public health expertise, evidence, and science with some of our important policy decisions. So we really have to take a strong look at that. We also, of course, have to think about the fact that no nation is an island, and if we're going to be successful at addressing pandemic threats, we need to really be internationally engaged.
Absolutely. I'd love to tap into that a little bit more about a whole of government approach, which I know you've spoken about in the past. And if there were to be a whole of government approach and greater coherence and continuity, what entities or who would ultimately guide that? Would there be a pandemic czar, or what would you recommend in that respect in terms of the US? But then also, what are the recommendations for greater engagement internationally and the partnerships that are critically important for that collaboration cross borders?
Well, actually, I just finished chairing a commission on building a strong national public health system that was sponsored by the Commonwealth Fund. It was launched, I think, last week. I urge you to take a look at it and its recommendations on the Commonwealth Fund website. But we really did try to very quickly put together a framework to think about this set of issues and a set of actions that can be taken now and over the longer term, and hopefully take advantage of the fact that there are some new investments in public health, and let's use those dollars wisely. And there's some bills pending in Congress, although we seem to be at a bit of an impasse, sadly, but where we might be able to further advance a strong public health agenda. But we have to really, I think, address a stronger federal role for public health. We have to recognize that we do need the Department of Health and Human Services to really have a strong focus on public health, to be able to bring together the different components of the department that are working on public health issues that aren't always adequately aligned. We're not always leveraging all of the resources of different components of the department, including CMS, which funds a lot of state and local activities in the healthcare system. And we really need to have a system that has both a strategic vision, an action plan, and accountability. And HHS, I think, does need to have a stronger role. And we recommended the creation of an undersecretary for public health, not an entity that everyone would be reporting through, but an entity that would have this charge for collaboration, oversight, accountability, and ensuring adequate support and funding for these critical public health activities, as well as the opportunity to mobilize. We also talked about the importance of state and local health departments and the need to really enhance standards and achieve a sort of baseline level of capabilities and create more coordination. We also think it's critically important, we saw this with COVID, that the healthcare delivery system and public health really work together on a daily basis and in a crisis, as they did during COVID, because it matters for health. Health is a continuum, and not everything that's important for health happens in a clinical care setting, but not everything that's important for public health can happen without that engagement of the healthcare system. And for too long, they have been separated. And then the last area that we focused on was really how do we rebuild trust and confidence in the public health system and its leaders? How do we ensure appropriate engagement and understanding of the public? And how can we, really make sure that communities are committed to public health and are well served? Everyone living everywhere in this country should be benefiting from public health.
Absolutely, and that's an issue that we'll explore later today as well in terms of access and equity. You talked about mobilization, and I'd like to dig into that a little bit more, and speed to respond. I think, yes, there have been failures and points of failures through the system, and it has been stressed, but it has also been remarkable, the speed that with which there was a response and the ability to develop and deploy vaccines around the world. And so, thinking back to your role at the FDA, could you talk a little bit more about that and how you think about the balance between speed and safety as everyone is combating these challenges and thinking through and wanting to deliver medical solutions as rapidly as possible? How do you think about that?
Yeah.
And also then what is the role of the regulator now as we go forward and continuing to deal with and grapple with variants of the COVID-19 pandemic?
Well, there's so many important issues embedded in your question. First, let me just say that we moved extremely quickly in terms of advancing science and technology and the actual production of vaccines, and that has made a huge difference in saving lives and reducing the burden of disease. We're not done yet. We still have parts of the world that have had very limited access to vaccines, and we need to think about this from an equity perspective and also a disease control perspective, that no country or region will be safe until really we make sure that we have been able to provide access for all. But I think it's also important to recognize that while it was extraordinary how quickly the mRNA vaccines were developed and made available, never before in our experience with vaccine research and development have we seen that kind of a timeline. But it wasn't just 10 months from the initial development of the vaccine to its introduction into human populations. That possibility built on years of investment in fundamental science and research addressing other coronaviruses and efforts to advance vaccinology and infectious disease research. So, I think that is important, because one lesson learned is that we have to, continue to invest in science, basic science, applied science, and ultimately regulatory science as well. And that leads me to the FDA. And when I was at the FDA, actually, one of my top 3 priorities was, quote unquote, globalization of the agency. And people were surprised by that. But it was very clear that even though FDA was the largest and the most well-funded and I think the most respected regulatory agency in the world, we could not do our job to protect the American people and provide them with the safe and effective products that they needed unless we engaged with the broader world. Supply chains, complex, with important components of products coming from other parts of the world or products being made in other countries for use in the US. So we had to ensure that regulatory capacity and oversight was as mature and responsible in other places in the world, because we couldn't really inspect everything as it came over our borders and as it was used by people. And also we recognized that effective regulation of products really requires alignment of regulators around the world, and that we could be really more judicious and more swift if we were working with other regulatory agencies in terms of both the science of regulatory oversight, how do you assess safety and efficacy, but also how do you process administratively applications so that companies weren't having to do one application that was very different in one country from another, but really looking at alignment. And I think the value of that really was demonstrated during COVID, when part of the reason that the vaccines and other medical products were able to move more swiftly was because regulatory authorities were working together with the vaccine, had sat down very early to sort of help define what are the critical questions to ask and answer, how can we have enough confidence to move something forward in a crisis even though we won't have all of the information that we need. And that kind of working together, I think, will benefit medical product research and development and access to critical products, whether it's in an emergency or to address the very real unmet medical and public health needs in this country and around the world.
And in terms of the partnerships and working together, what ways do you see the public and private sectors working together effectively as we continue to combat the coronavirus, but other potential outbreaks that are in the future?
It's absolutely crucial. I mean, I think that if you didn't know it before, COVID-19 really brought home the fact that we cannot work in isolation. If we were going to solve big problems like COVID, but many of the other major challenges facing us in our modern and complex world, we'd have to work across disciplines, we have to work across sectors, we have to work across borders. I think that this notion that we can sort of hunker down and do everything ourselves as a nation is going to actually undermine our best efforts to address the important challenges before us, whether it's infectious disease and pandemic threats or addressing, huge looming problems such as climate change.
Great. And our time is short, so I have one last question for you. I know you represent the National Academies of Science, Engineering, and Medicine on their steering committee for the Inter-Academy Partnership for Science, Health, and Policy. And when we think about mobilizing expertise and the workforce that will be necessary, how should we prioritize that, and where are the critical investments needed to galvanize and mobilize the expertise for the challenges ahead?
Well, the Inter-Academy Partnership you mentioned is an umbrella organization of academies of science and health around the world. And I think, it is a very important and underutilized resource in that academies of science and medicine, very often are credible, respected sources of scientific information and evidence to inform governmental decision-making and policies. And one of the things that I think was brought home during COVID in this country and in other countries was that countries that fared better were ones that really sought out scientific expertise and used data and evidence to inform their policy making. So I think, academies have a critical role to play. But I think we need to think about all of this in a very multifaceted way. There is, I think, a critical need to recognize that first and foremost, we have to take these issues seriously, and that involves both public understanding and a certain, health and science literacy. It also involves real political will, and we need political leadership at every level, local, state, national, and through international collaboration for a real commitment to address these issues in a sustained way. Then we have to, make sure that we are bringing in the scientific expertise, investing in the science that's needed, that we are creating an environment that also reflects the very real concerns around equity and the notion that we cannot thrive, we cannot fully mobilize the responses needed if we have haves and have-nots. So I think we really need to think very broadly. I think this is truly a foreign policy issue, and that meaningful, enduring solutions are going to require it to be health and security to be very much a part of the foreign policy agenda, to be part of how all countries think about the investments they need to make domestically and their commitments to other nations, and to ultimately making the world a better, safer place.
Absolutely, very well put. And thank you for framing the conversation today, and many more discussions ahead. Unfortunately, we are out of time, but grateful for your insights today and spending the time with us. Thank you, we really appreciate it. Dr. Hamburg, thank you again.
Thank you.
Distinguished guests, please make your way to the main program room. The program will begin shortly. If you've joined us in person, please submit your questions at foreignpolicy.com/program. Be sure to include your name and organization with your question. Again, the URL is foreignpolicy.com/program. To those joining us online, please submit your questions using the box on your screen. Distinguished guests, please take your seat. The program will begin shortly. If you've joined us in person, please submit your questions at foreignpolicy.com/program. Again, the URL is foreignpolicy.com/program. To those joining us online, please submit your questions using the box on your screen. Distinguished guests, please take your seats. The program is about to begin. For a conversation on ending the HIV/AIDS pandemic by 2030, please welcome Ambassador John N. Kengasong, U.S. Global AIDS Coordinator and Special Representative for Global Health leading PEPFAR, and Foreign Policy's Vice President of Research, Dr. Maisha Alom.
Thank you, Ambassador Nkengasong, for joining us today. We're honored to have you. As the newly appointed U.S. Ambassador for combating HIV/AIDS globally, can you tell us what are your first priorities and how will you leverage diplomacy to advance those priorities?
Thank you so much for the opportunity to contribute to this very, very important conversation. I must say this is my first outing as an ambassador. And it is my week 2 plus 1 day. But very hectic. There's I think we have a common vision and a common goal to end HIV/AIDS as a public health threat by the year 2030. I think that should always remain our goal. In public health, they say if you count things that you can measure, then you can work hard to achieve them. So how do we get there? I think is your question. I think, first of all, I would just lay a disclaimer here that what I'm going to tell you is not what necessarily a direction or a vision, but it's what I call a stranger view of the program. I used to work in PEPFAR for so many years, left 5 years and a half, and went to the African Union to set up the Africa CDC. So I'm back now with a fresh eye. But there are 4 areas of things that I would like to listen and get views on. One is the equity in population that are underserved, the children, adolescents, and the key populations. What does sustainability looks like? We are almost 20 years into PEPFAR. Going forward, what do we do to sustain the gains that we have achieved, which are remarkable? The program PEPFAR has saved about 21 million lives and contributed in the overall lifting of the health systems in the country. But where do we go from here? How do we reimagine partnerships? Okay, new partnerships that will focus us on certain things that we have not done in the past, or elevate things that we have done in the past to a different level. And what do we do with the interface between COVID and HIV, or HIV and health security as a whole? I used to say that in 2020, when I had a meeting with Winnie, the executive director of UNAIDS, COVID was just beginning to hit Africa.
Yes.
Exactly. And at that meeting, I said to her that for 20, 25 years, HIV has defined global health. But we are now at a period where emerging infectious diseases will begin to define HIV. The attention that you pay to HIV. That was in February, and we've seen that in the last 2 years and a half, where because of the COVID, what I call a disruptive pandemic, the emphasis on HIV/AIDS has been taken to, about 2 notches below. We have to work hard to bring it back to where it has to be.
There's so much to unpack in there, and I'd love to pick up on a few different points. You mentioned partnerships, you mentioned equity, and one of the things I wanted to ask you about, here at Foreign Policy, we are interested in global health challenges, and of course, global health, in global challenges, including global health. And what is the role of the United States in the world? So let me ask you this. How do you see the US's role in mobilizing resources and fostering partnerships? What is the US's responsibility to the world when it comes to combating HIV and AIDS globally? And how do we succeed in meeting that responsibility?
I think I say this from, again, my elevated newcomer perspective. The United States has exercised remarkable leadership in the fight against HIV/AIDS. Unique leadership by supporting the largest bilateral program, which is PEPFAR, for the last close to 20 years, and also contributing significantly to a multilateral program like the Global Fund there. So that combination of the unique focus with the bilateral and the multilateral demonstrates the United States' overall leadership. And the world in global health has always been a good place when the United States has led, whether it is in the area of HIV, tuberculosis, or respond to Ebola like they did in West Africa. So that leadership, that unique leadership role of the United States in global health, and by implication, global health security is just something that, a commodity that we need going forward.
You mentioned earlier the intersection of COVID and HIV and better understanding that. And so much of the discourse around COVID has been about how do we deal with an ongoing pandemic. But of course, HIV/AIDS has been around for decades. So what are some of the lessons learned that public health experts can draw on and apply from HIV to address COVID and where we go from here?
There's, when you look at HIV, which is a pandemic, and as you rightly said, a pandemic we've lived with for 40 years, and you also look at COVID and Ebola. Ebola is not a pandemic, but it was a serious threat a few years ago. You ask yourself the question, what are the commonalities of what characterizes a successful fight against a pandemic? There are 5 of them. Understanding the pathogen. You understand the population. You understand good policies. You have the right politics, and you have the right partnerships. I call them the 5 P of managing a pandemic effectively. If you understand these two, how they all interplay each other, then you can apply that to tackling any pandemic. If you focus on the population, it's always about the trust that the community has with the public health community. If there's no trust there, no intervention works, right? We all are very appreciative of the fact that the availability of vaccines just 1 year after a new pathogen was characterized was remarkable. And it's victory that we must celebrate. But if you look at the value of death that has gone through in certain populations, it speaks to that trust capital that we must always try to build with the population. If you erode that trust capital, no matter how good your interventions are, they don't go anywhere. So I always remind the students that I give a lecture to memorize your 5 Ps of a pandemic there.
You know, the 5 Ps, I love this. It's something that I think even if you're not working in public health, people can understand. And it's such an example of your remarkable career as a virologist and now as the US's senior most diplomat on issues of HIV/AIDS. And you mentioned Ebola earlier, another disease that I know you've worked on. So let me ask you this. Epidemics like Ebola and pandemics like COVID or HIV are stark reminders of global health inequity. And in your role as the US ambassador at large and in heading PEPFAR, how are you planning to advance equity, and what strategies will you look to implement in order to ensure that communities in need have access to treatment and services around the world?
So that's a very important question. First of all, let me step back and say this, and I've said that previously, that COVID has made global health global. Global health used to be that thing that we go to the developing world to provide health, right? And to solve a malaria problem, a TB problem, or an HIV problem. But COVID united us. COVID taught us 3 lessons: that we are more connected than we thought we were, that we're more vulnerable than we thought we were, and that the inequities that exist in global health, which is the foundation for our interventions, are even more profound within a country, between regions, and between systems than we ever imagined. So HIV continues to shed lights on the inequities that exist in the response. And that is why the populations, the 3 categories of population that I mentioned, i.e. key populations, children, and young girls or adolescents, are very important. What I hope to do is to build partnerships across those categories of vulnerable populations there. And if you all remember that the LIFE initiative that the United States initiated was the precursor to PEPFAR. And it was all mainly focused on pediatric HIV. So if somebody will come from the mass today and say, what happened with the children? Did you eliminate pediatric HIV/AIDS? And the answer is no. It will be terribly difficult to understand. So at this point, I'd like to congratulate those countries like Botswana that had taken off pediatric HIV/AIDS, tick the box. If Botswana can do it, I believe that many more countries should be able to do it. Botswana is unique, that many years ago, when I started engaging and doing work in Botswana, the HIV burden was such that if people did their test and they came out negative, they didn't believe their results. They thought it was a false negative there. But here we are with political commitment, determination, and focus on that. In that population, they were able to declare pediatric HIV closed. That is remarkable, and it is possible. It speaks to the power of purpose of the ability to focus and stay with a purpose. So driving PEPFAR program with a purpose is what I'm going to do. I mean, the purpose of what we are doing, okay? Not necessarily that vision, but the purpose of what we are trying to do. And the spirit behind that purpose is what I think we should be all rallying around to address the inequities.
Thank you for bringing in the example of Botswana. I think it's so important, even when there are such enormous challenges in front of us, to think about the success stories and where's their innovation and what have we learned and where can we learn from around the world. And you were mentioning, PEPFAR and the purpose, right, that's driving you. I'd love to bring in a question from our audience. Dr. Nida Ali, who's from the Task Force for Global Health in Atlanta. And Dr. Ali asks, COVID-19 pandemic highlighted that fragmented systems prevent us from a coordinated response. Over the years, how has PEPFAR managed the diplomacy for working across the country with each state as having a separate health system? What does the future look like to overcome that fragmentation?
If you look at the evolution of PEPFAR from the first authorization to the subsequent reauthorizations, there have been language embedded in that speaks to strengthening health systems, right? So if you recall, the first authorization was around putting 2 million people on treatment, prevent 7 million new infections, and care for 10 million individuals. Subsequently, health system strengthening became part of that. I've always said that health systems that do not deliver services are meaningless. And you cannot have your health service delivery also meaningless if they don't have strong health systems. So it should never be a fight between delivering health systems or strengthening health systems and providing health services. It should be how do we bring the two together. And what are those? They are workforce. We have to begin to look at workforce, health workforce strengthening as a cross-cutting tool. The same systems that you use for providing information, gathering information in HIV/AIDS and supporting patients living with HIV/AIDS, those same systems can be used across the board. So I think we should step back and look at that horizontality of what is it that we can do, and actually say and be very deliberate in doing that. I'll give you an example. We all came out from the fight, the Ebola fight in West Africa, saying never again. And we wrote all kinds of nice reviews published in very top journals. But I didn't see a target. A target said, well, we're going to collectively train 7,000 health workers in that region in the next couple of years there. Then COVID hit, and we are saying the same thing, never again. I think just a few weeks ago, the Secretary of State, Secretary Blinken, came back from the meeting in the Americas and said something that was remarkable. He said, at the meeting, they agreed to train 500,000 healthcare workers in the region. That is remarkable. That is what we need to see more and more, where we set targets and we strive to get to those targets there. I use the word strive purposefully because we may not get to the 500,000 healthcare workers by a certain number, but at least we are trying to get there. That is where you rally the partnerships from the private sector, foundations, and governments, because governments cannot do this alone. We have to bring in the private sector and foundations to get us to where we have to be.
We're almost out of time, but I want to bring in one more audience question. Thomas, who's a student in New York and joining us virtually, asks, how do medical professionals quell the doubts of the public towards global health initiatives and vaccines? Maybe you could briefly talk about that. How do we overcome vaccine hesitancy and build trust, something you brought up earlier?
So I'll say this and it will surprise you that at first we have to try to decentralize vaccine manufacturing and see that as a security issue. And maybe I'll push the discussion further and see that as a national security issue. And I say that deliberately because when people see that the health security commodities are produced in their backyards and whatever, there's limited room for misinformation. What we've seen when I was leading the COVID response in Africa is that, oh, these vaccines are produced in Europe or in North America, and they are designed to sterilize us in Africa. So you stay away from it. And through social media, it gets completely out of control. I remember issuing several communiques just to clarify that those things were not true, that the vaccines are safe, that the vaccines are effective there. So let's democratize vaccine manufacturing and other health security commodities, bring it closer to the communities as much as possible. That is one. Second is that we have to make sure that we take social media seriously, okay, in public health practice, that it can be very disruptive, okay, and you tend to go ahead of your public health messaging there. I think that is something that we've neglected, but we have to design strategies to make sure that you put in the right information before social media takes over.
Well, Ambassador Nkengasong, thank you again for choosing us and this forum to do your first public event. It's been a rich conversation. I could ask you many more questions, but we're out of time. So thank you, and we hope to have you back. So
thank you.
For a conversation on post-pandemic priorities to strengthen health systems, please welcome Dr. Atul Gawande, Assistant Administrator for Global Health at USAID, and Foreign Policies Publisher and CEO, Andrew Salinger.
Hello again and welcome, Dr. Gawande. So happy to have you here with us.
Atul.
Dr. Atul.
Am I sitting in the right place?
You're sitting in the right place.
Okay.
You're perfect.
Okay.
We are very pleased to have you here, and thank you for taking the time. You have had an august career in all sorts of different aspects of healthcare, in public service, your role now, and even working in private operations as CEO of Haven, the JP Morgan, Berkshire Hathaway, Amazon health practice for a few years. I would love to go back into your Wayback Machine and hear from you a little bit about what you were thinking in late 2019 when you started hearing about some incidents in Wuhan, China, and how people were getting sick and very sick, and what you thought was happening, and tell us a little bit about what went through your mind at the time.
Well, I am not one of those people who said, I knew this was coming. I'm never the first one to recognize all of these things. But by January of 2020, my colleagues at my hospital up in Boston, where I practiced surgery, were actively developing tests for to be able to test for COVID. It was now going, by that point, this is early January, it was a common line of discussion, how far could this spread and how dangerous this could really be. And yet it was still a couple of months until we really were getting our response in gear. And so by late January, I was quite alarmed, and I was hardly alone in that place.
And what were your thoughts when this started to dawn on you, how bad this could actually be? What were your reactions to that?
Yeah, so my work in public health, so I'm a surgeon, but I've also led work where my fundamental goal has been around health equity and making sure that we have this capability to make people's lives you can live an 80-plus life, your average life expectancy, if you can get the discoveries we've made in the 20th century and beginning of the 21st deployed, but only part of our population in America gets it, let alone around the world. And so my thoughts always go to, first, how dangerous can this be? Who are the most vulnerable? And this is emerging in China, so of course the concern is as it spreads across the east, coming west, everywhere in its path along the way. But then at home in Boston, are we remotely prepared? As it would turn out, Boston and New York were among the first that were severely hit. And so by late February, when that was starting to happen, we did not have the tests. And in late January, I was pretty sure we'd have the tests. And we still weren't in agreement about what you could even begin to do. I began writing for The New Yorker, where I was on staff as a writer and a journalist on medical issues. And in mid-March, at our hospital, I began pushing for, in Asia, this moved first through the hospitals. In Wuhan, it was the doctors, the nurses, who became the vectors of spread as well as getting really sick. And then the same in South Korea, and then in Italy, and then in Spain. But it didn't happen in Taiwan, didn't happen in Hong Kong. And so what I began writing and pushing for was, we ultimately became the first major hospital in the United States that said, everybody's gonna wear a mask in our hospital. So I put a mask on and was part of taking care of COVID patients, doing surgery, other things, and I still haven't gotten COVID yet, still wear my mask. We'll see. We now have the tools that we didn't have at that time, but the really difficult things around that time was watching the public health apparatus not only fail to provide basic tests, fail to get out the basic messages, not have the president come in behind the basic messages, but actively sabotage. At that time, our team up in Boston were told to stop developing tests because the FDA was going to do it. And there was a series of, CDC was going to do it. There was a series of mistakes from lack of coherent leadership. John Nkengasong was just saying what the 5 Ps that he described of, being able to have among the Ps, consistent public messaging and a consistent sense of public communication about where the priorities were going to be. And that goes right into your own organizations and making clear, like, this is going to hit, it could hit big, and everybody has to be part of making tests.
So that's a great perspective. Thank you from a very local level on what you were experiencing and dealing with. How did you think the world would respond based on what you were seeing? And as Peggy mentioned earlier, this is a classic foreign policy issue. Lots of different state operators looking after their own interests, but needing to act together. How did you think the world would respond?
So there's 2 things about it. Number one was we already saw how the world was responding, with many countries developing good policies internally and managing to get it under control. There were the countries that immediately did the effective things, settings like Taiwan, Hong Kong, ones that were devastated early and then quickly rebounded to correct course. South Korea was an example. The second part is that the role of the United States has been to rally people around what the best places in the world were doing, to be the place that gathered that information and pushed that information out, and was the organizer of the operations to make the best avenues become real for everybody. Think about Ebola. I mean, we acted still not early enough, but to push WHO to declare that Ebola was a pandemic, to deploy the US military and non-military capabilities, USAID and CDC being core operations to get it contained before it spread around the world. And we still got cases here, but managed to have the approach under control. And the global story of Ebola was what I thought we would do, and just do it faster and better, where we would rally around what the core response needed to be and have the basic tools in place and deploy them. That was not what happened.
No, it was not. And if you were 2020 hindsight, if you were health administrator for the entire world, this would have been the approach that you have taken, similar to the way we in the US and globally handled Ebola?
Yeah, what I would have said, yes. It would have been, first of all, to recognize that people in the healthcare systems around the world had found ways to not get COVID, and that involved wearing masks. And the WHO was slow to embrace and to say everybody should be in a mask, and the US, we should have been part of pushing that change to happen much faster. And then the second would have made sure the world had tests, not just that we had tests. And when we didn't develop tests, I founded a public benefit corporation to expand the capacity of national test availability, but we weren't doing that in enabling the rest of the world to have that, and we would have been out front driving that. When President Biden came in, the very first thing he did was enable the capacity, get a bipartisan, large-scale supplemental that got testing moving around the world, got oxygen moving around the world. When India was hit in devastating ways in the summer of that year, we were coming in with support to enable those things. And then we had vaccines, thanks to the prior administration and many administrations before that investing in that research and development capability. But now we committed to rolling it out, saying, we'll push out 1 billion vaccines from the United States if that's what it takes to make it happen, and we'll ask the rest of the world to come in behind it. And look at where we are today. This is the beginning of 2022. 1 year later, we have an abundance now of vaccines because of that leadership that said everybody needs to bring the vaccines to the table. We needed to push it forward. And second, that it's not enough to just have the vaccines. You have to follow through with the delivery. And that meant whether it's West Virginia and the remote parts of Alaska needing to get it, or it's where I was just 2 weeks ago in northern Ghana, where they had been at under 10% vaccination, a full year after the vaccines were deploying, and we were supporting and enabling capacity that in a matter of weeks, I was in regions that had been under 10%, and 10 weeks later, the region I was in was closing in on 50% full vaccination.
Excellent. You're talking about Global Vax, of course.
Yes.
Incredible achievement. You recently testified before the Senate Appropriations Committee, though, about funding. You were just talking about resources. And in addition, you are an excellent writer, man after my own heart, former journalist, and wrote a fantastic piece, I thought, earlier this year in the Washington Post about the need for continued funding. This thing is not over. If you could tell us a little bit about your thinking behind that. Why is that so important that we continue to fund? Because we are seeing fatalities on the wane. It is easy to let our guard down. What's your thinking behind that importance?
Yeah, the goal is to turn COVID. We are no longer going to eliminate COVID. It's in animal population. So our goal is to turn COVID into a manageable respiratory endemic illness. And what that means is disconnect the fact of circulating cases from hospitalization and deaths. In the United States, we now have the tools to do that. Vaccination is probably the single most effective way you can protect yourself. And we have widespread availability and have reached most of the population. But for those who are not vaccinated or are very high risk, we have rapid tests and oral antivirals that can be oral antiviral pills that can be up to 80% or 90% effective in preventing hospitalization and death. The low-income world, so we have successfully deployed the tools of vaccination to the high-income world, the upper middle-income world, and now the low-middle-income world. But the lower income, the lowest-income world, the low-income population of the world, it received less than 1% of the world's vaccines, even though they're a large part of the population. And so they needed to get access. Africa is still under 20% fully vaccinated. But the second problem is they have almost no rapid diagnostic tests. They have almost no oral antiviral medications. And so equity means that the discoveries we've made that help people live that full life expectancy could be available to the world. And they're simply, once again, we've replicated what happened earlier, which is that the high-income parts of the world took up all of the stock of what there is of these critical life-saving tools. And then Congress right now is saying, we're done. But that part of the world is not protected. And that part of the world happens to be where the variants are coming from that will hit us. You cannot fight a global pandemic with domestic-only policy. And yes, we are now protected. Deaths are low and hospitalizations are low, even as we have our surges up and down. Could be a bit better. 300 deaths a day doesn't feel that low to me. But That said, we are able to have society functioning and moving forward. That is not the case as surges will hit the low-income parts of the world, and we will pay the price for it. It still affects supply chains. The world is deeply connected, and it affects our jobs, it affects health, it affects global security, and not to mention our political standing in the world. So this is vital.
Indeed.
It's a mistake of historic proportions for Congress to have shut off funding for further work in COVID.
So very poignant. We have a question from Carmen Pawn at Politico. So if you'd like to see a headline on answer to this question, are we ever going to get lower income countries up to a full COVID vax rate of 70%? If so, when? And how will we get there given the handicap you were just talking about politically?
Yeah, so number one, so the short answer is yes, but I think it's going to take a long time. First of all, to understand the countries that are left, for example, Sub-Saharan Africa, is 50% under the age of 18. So the goal of 70% is necessary for equity reasons that across our age spans, we have COVID is lethal at every age span, and the risks are protective with vaccines. That said, our most important populations we have to get to are high priority populations, and those are health workers, those are the elderly, and extend that further to at least people over age 40. We want to get to 100% if we can, and we need to get to the high risk populations such as those with chronic and serious illnesses, including HIV/AIDS, as John and Kengasaw works on for PEPFAR.
Right, of course. And that's one thing I wanted to turn to right now, of course, and you've written about this extensively. When we focus on a pandemic like this, we take our eye off the ball on other issues and other ongoing problems, like malaria, HIV, and I know USAID has done great work there, but I wanted to turn to another issue that's on top of a lot of minds right now and ask you about it. Obviously, on Friday, there was a big decision from the Supreme Court on Roe v. Wade. It's created a firestorm not only in the US, and that's because it has impacts globally. FP published an analysis on Friday of 59 countries that have expanded abortion access and 11 countries that have restricted it. And the US now falls into that latter category along with such august company as Russia, North Korea, and Iran. How does Friday's decision impact USAID's efforts on reproductive rights access?
So I want to make super clear. The Biden administration, after the Dobbs decision, remains just as committed as we ever were to sexual rights and health and to reproductive rights and health. That protection is a critical part of advancing women's health around the world. We at USAID function under restrictions that do not allow us to fund abortion access. And that is not going to change. That's been in place for a long time, and that is still the law of the land, and it was not affected by the Dobbs decision. So at one basic level, our work around the world stays unchanged. We are the world's leader in supporting voluntary family planning and reproductive services, and we're going to continue to do that work and it's been supported by decades of bipartisan support to advance that work. But the second thing I'd say is that the Supreme Court decision made especially Clarence Thomas's opinion, suggesting that this could extend to dialing back access to privacy rights that have enabled contraception and protection of same-sex marriage, or even simply same-sex sexual activity from being criminalized. And there is a lot of fear around the world that the prospect of those moves endangers the safety of people in the LGBTQ community around the world, and the reproductive rights of women in critical ways that we could see significant backsliding. And we are going to be committed to continuing to advocate for the well-being of those populations and protection of those rights.
Well, that was very clear. Thank you for sharing your insights on that, Dr. Atul Gawande. I think that's all we have time for. You have a hard stop, but we really appreciate your answering that tough one.
Delighted to be here. Not a tough one at all.
Thank you.
Joining Andrew on stage to discuss global finance for global health security, please welcome Lois Pace, the Assistant Secretary for Global Affairs at the Department of Health and Human Services, John Frank, Chief Public Affairs Officer at Illumina, and Catherine E. Bliss, Senior Fellow and Director of Immunizations and Health System Resilience at the Center for Strategic and International Studies.
How's our seating? Great. Well, thank you so much for joining us. We really appreciate it. And we have Catherine, who's joining us virtually. So I'm happy to have you here for this talk right now. We are going to be talking about funding the global COVID-19 pandemic and how it has been a question at the forefront of conversations among all stakeholders, from countries to the private sector to NGOs and all in between. We've encountered new funding models in order to deal with pandemics effectively, and today we're going to talk to our panelists a little bit about how we can help reinforce those funding pathways or innovate new pathways. So let's get started. And Lois, it'd be great to start with you, if we could. And with, I hope, what is an easy question, it might be a difficult one. What has worked so far? There's a lot that hasn't worked, but what has worked?
Well, I appreciate this question. At least we can start with a bit of optimism. I think what has worked is, look, there were already some systems, some coalitions and collaborations in place before COVID-19. There were people, and I heard a tool before me saying, he wasn't one of the folks who knew this was coming, but there were a lot of people out there who saw this coming, and they had been organizing themselves. You think about the Global Health Security Agenda. You think about the Private Sector Roundtable. I mean, there were convenings that were really helpful in, once this came along, helping governments and other stakeholders say, okay, how do we mobilize our resources? How do we align our activities? I think also we saw that in play with the ACT Accelerator. So that was the coming together of groups like World Health Organization, Global Fund, Gavi, these speakers that you'll have today, and Gates Foundation and others, because we had an existing global health ecosystem that we could leverage for this moment. We can talk about where maybe we could make some improvements, but I think those are good things.
Great. And what were the key factors in there that you think enabled that to work, maybe globally as well?
Well, we've made a lot of investments in those areas, I think the U.S. included, but not exclusive to the U.S. government. And so those investments really came to bear, given we have made these decades of investment in global health and other issues and other epidemics, frankly, like AIDS, TB, and malaria. We were able to build on these efforts in really important ways.
Great. Catherine, I'd love to bring you into the conversation with a slightly tougher question. And it is the opposite of what I just asked Lois. What hasn't worked? What were some of the issues with financing and funding for pandemic preparedness where we really did fail?
Well, I mean, let's start by looking at some of the assets that countries had. That we know that countries that had strong primary healthcare systems in place were able to better deliver services at the community level, maintain all the other health services that people need, whether or not there was a pandemic, than countries that did not have an existing PHC program in place. So, that vacuum for countries that didn't have strong health systems, I think really felt a particular challenge as the pandemic had its full effect in 2020. A related issue is, the challenge around immunization services. One of the great challenges that we've seen over the past couple of years, or really as COVID vaccines have been able to roll out, is that even when there are vaccines available, here's this wonderful resource that can really help prevent infections. But some countries just have not had the strong immunization systems in place to be able to deliver those across the board. As Lois pointed out, we really did see that there was significant ability on the part of countries that were receiving support from Gavi and the Global Fund to redirect some of that health system financing to outbreak response. But by the same token, what we've seen is that the ability to mobilize that funding in a timely manner, as for the vaccines available through COVAX, the vaccine pillar of the ACT Accelerator, was at various moments kind of delayed in the ability to get that moving till September and until late 2020. so that we saw the wealthy countries, really able to snap up and make deals for the vaccines in a way that, delayed the ability of COVAX and others to mobilize those resources. And so I think, in the future, we need to do a better job of ensuring that countries, are able to continue to invest in that primary care, in those routine immunization systems, so that they have that surge capacity when there's a pandemic, but also to mobilize financing more flexibly in the earlier period.
And to learn to share, perhaps, as well as part of that dynamic. Thank you for sharing, both of you. So there's been a lot of talk over the past 2 years about public-private partnerships and how this is the key to the future of pandemic financing and funding. And it would be great, John, to look to you and to talk a little bit about your view on this. Do you agree? How can we expand these partnerships to ensure there is multilateral cooperation? And Illumina, of course, is involved in partnerships just as this. Maybe you could tell us a little bit about what Illumina is doing.
Sure. Peter Sands of the Global Fund wrote an article in 2019 asking, why is it that companies are so involved in climate but not involved in public health? And if you went to COP in Scotland last year, it was largely a corporate effort. Governments were there, but the main work was getting done by companies. On public health, we have a long ways to go. I think there is a sense that we don't necessarily have a place to connect, right? There's a little harder ways to try to find ways to come together. I think a very good example, though, is the African Pathogen Genomics Initiative, which initiated by the Gates Foundation. It's a $100 million project over 4 years. It was actually in planning before COVID, but COVID certainly accelerated it. And the goal was to bring genomic sequencing capabilities across Africa so they could follow COVID and COVID variants as well as other diseases. Illumina contributed $20 million to the project. And also Microsoft came in and was providing data analytics and data infrastructure. And Oxford Nanopore was also providing genomic sequencing from the private sector. And it really worked. And we helped, I think, it really helped. There was strong leadership at the African CDC, under the African Union's umbrella. But working with governments, there's a lot more work to be done, but it is an example of where private sector foundations and governments can cooperate to advance things. And hopefully we need to continue the progress of the initial thing. Everybody knows that South Africa famously was the first to detect a new variant and was greeted with travel bans, not because it was actually emanating from there, but they just had the most advanced systems to detect it. But that was part of this genomics analysis across Africa that is really advanced, and there's great capabilities to further advance this. Our CEO called for something he called bioforce, but not just worrying about natural pathogens, but also antimicrobial resistance and human-engineered pathogens. And we, as a country, and every country has got an interest in monitoring what's going on around the world in a more careful way. And so I think that's kind of the next challenge. And there's lots of proposals to do that, but we can get into that later.
Excellent. And I'm sorry, Lois, for you.
Well, I was going to say, if I may, what I like about what John offered is it points to the importance of not just global PPPs, but also really focusing those at a regional level. There's a lot of work happening among the private sector in region, in country, that I think gets missed in these conversations. And so thank you for bringing that to the table. There's also this element of reaching beyond the non-traditional sort of medical or health sectors, right, into tech, data, Even we discovered the importance of engaging with legal actors during the pandemic, and to your point of vaccine sharing, that was very important in sharing vaccines. And so being creative about public-private partnerships will be really important working into the future. Thanks for letting me chime in.
Oh, of course. And yeah, the next-gen sequencing initiative is fascinating. Learned a lot about it in researching this discussion. So it's really cutting-edge stuff that I think will come in very, very valuable, especially the way that you're able to detect early signs of some of these issues, some of these threats. And it's great that you brought up Peter Sands of the Global Fund, who we will hear from shortly. My excellent colleague Ravi Agrawal had a discussion with him earlier, which we're going to hear in a moment. And he is going to talk a little bit about the Financial Intermediary Fund that's been proposed by the World Bank, and to ensure there's lots of different stakeholders who are being held accountable and getting capital to the countries who need it. This will ostensibly do a few things: drive progress towards preparedness standards, create incentives for greater on-budget domestic investments, because it can't just happen globally, it has to happen at home as well, and a variety of other benefits coming out of it. But it's a little controversial. Let me start with you, Lois. Is this the way we should be thinking about pandemic preparedness, in that we create a separate entity to fund this going forward, or is there other individualized mechanisms that countries should create?
Yeah, we're very excited about the fifth, if only because it's really mobilizing resources, but also energy around this moment, right? And we need that momentum. I'd be careful calling it a separate entity, because that's not necessarily what's being envisioned around the fifth. And so there are different forms that these things take. But in no way have I heard countries, including the US, talking about establishing a separate institution of sorts. So we're not looking towards establishing a global fund for fill in the blank. I see you smiling, but we can pore over the paper, because unfortunately my team has been looking at this for a very long time.
We're going to come back to that for sure.
Sure, let's do that.
I wanted to see if Catherine had any thoughts on that as well, just in terms of as a financing mechanism, not as a separate entity, the fifth, and that has been proposed by the World Bank.
Yeah, I mean, I think the examples of Gavi and the Global Fund show us that these kind of specialized funds that pool resources and then distribute them to eligible countries for specific purposes, whether HIV, AIDS, and malaria, or vaccine distribution, play a very important role in strengthening health systems. The proposed fund for pandemic preparedness and response, I think, can really play an important role both in raising even further the political profile and visibility of pandemic preparedness and response issues, incentivizing countries to really prioritize preparing and developing their systems for responding, and then getting the needed funding to them. But there are a couple of important things that we need to watch for. I mean, of course, it's important to ensure that it's well funded. It's already got a significant series of pledges, but to be sustainable, all countries, wealthy and low income, will need to engage and invest. And that also means that it will be very important to develop a governance mechanism that ensures broad representation and participation by different groups, and that there's strong coordination with the other existing funds, whether Gavi, the Global Fund, and many others as well.
Okay, great.
And Catherine's hitting on these important points, right? This is not an either or, but a both and for us. And so we need to be thinking about the existing global health ecosystem and include those actors in this process. But there are emerging actors here. I mean, Africa CDC, which the US had a hand in funding and supporting since its launch, was not something that was on the radar several years ago, right? And so how do they fit into this mix right now? The Caribbean Public Health Agency. So a lot of times we have this, unfortunately, more of a top-down approach that's really focused on DC, New York, Geneva, and these institutions are great and they're valuable, and we need to keep in mind who really showed up in this response, like your other speakers have been saying.
Yeah.
It wasn't all these traditional actors necessarily. A lot of the leadership came from the region, as it should have been, right? And they really know what they require, and as Catherine is saying, they need to have not just a seat at the table when it comes to when we're ready to dole out the resources, but in planning for those resources and otherwise directing and prioritizing those resources. And so that's our hope with the fund, is that it opens those doors and unlocks those opportunities for a broader spectrum of actors.
Excellent, well said. And the ambassador spoke about, who actually had a very big role in the African CDC, so very, very poignant to bring that up. But let's talk about Geneva for a moment, since you brought that up. WHO's 194 members agreed last month at the World Health Assembly to overhaul its funding model, which one observer called fundamentally rotten, relying on a lot of private earmarked donations, which of course then messes up all of the focus and of that funding. So obligatory fees will rise from 16% up to 50% of the WHO budget by 2030-31 at the latest, provided these reform suggestions are implemented. Just call it like it is. The WHO gets a lot of grief from certain parts of Capitol Hill. Will this fix what ails the WHO?
Everyone is laughing at this question because they know what my role was before I stepped into this one with the WHO. But look, WHO and how WHO is strengthened absolutely needs to be a part of this conversation because they have a central role to play, not only in global health security and pandemics, but in global health. So I'll say that out loud in case people sort of need a refresher as to not just my personal position, but the US government's position. Now, we've been very interested in continuing conversations with WHO about how that improvement happens. A part of that is financing for sure, but that needs to be coupled with other changes to their own governance and accountability. I think the US is excited to be at the table again as a board member to WHO. My boss has been meeting with Dr. Tedros in his capacity as our Minister of Health or Health Secretary to ensure that WHO, from the leadership on down, really understands what we're seeking in terms of some of those changes. And the good news is that they're being responsive. I mean, Dr. Tedros walked in already with a slate of reforms he wanted to see from the institution and has slowly begun to implement those in his first term, and in the second term is committed to ensuring that happens overall. But I think that's important to just keep in mind. It's not just about kind of turning up the dial in this funding, but ensuring that given the phased approach that member states decided, because I was a part of those discussions, as was my team, we need to ensure that we can kind of map milestones along the way regarding these changes the WHO is going to put in place around risk, compliance, transparency, accountability, and the like across the board. And not just in HQ in Geneva, but frankly, in their country and regional offices as well.
Great, thank you for taking that one. We'll move on from there. I could
gonna
keep going
say,
on
'cause
WHO, but I'll let it go at that. But I don't want to push my luck. Let's take a question from the audience. Matthew Shearman from APCO asks, just talking about, you had mentioned, globalizing vaccine R&D and manufacturing, incredibly important. Can you comment, and can our other panelists comment if they like, on how we achieve that role and the role of the US in creating that global system? Anyone want to take that on?
I think it's advancing. Rwanda is building capabilities for vaccine production, but also in genomics. And I think that just the first sequencing of COVID was done on a Illumina machine in China. Biogen never had the virus on their facility. They just used the sequencing. So the research and production process is increasingly data intensive. Developing the capabilities to produce mRNA and other vaccines is happening. And I think that's really important that it's be distributed around the world.
Great. Catherine, I'd love to bring you into the conversation again. TB, tuberculosis, is the #1 infectious disease killer until COVID came on the scene. And TB deaths are once again on the rise for the first time in 10 years. And it may be once again ready to regain the crown as COVID deaths recede. What funding lessons have we learned from COVID that we might apply to TB in this example?
I think there are a number of lessons from this COVID experience that are relevant for TB. I mean, one is that, many of the tools developed for detection of tuberculosis were actually, very early on in the pandemic deployed for detection of COVID for countries that couldn't get access to some of the newer diagnostics right away. So that, pre-existing investment really made the difference in COVID response in a number of places. At the same time, COVID has shown us that we're able to gather data on a pretty rapid basis and analyze that and map it and make that data available to a large group of people. And something the tuberculosis community has been frustrated with for years in terms of really kind of trying to find those pockets where services aren't reaching people, where diagnostics aren't reaching people, is really being able to use data. The data that comes in is often months to years old, and so really harnessing what we've learned from the mobilization of data during COVID to make that available for tuberculosis, to really find those places where people continue to develop infections and really address those, I think is also critically important. And then finally, we can really think about ways to use some of the new technologies developed for using artificial intelligence, or some of the newer computer-assisted diagnostics that have been mobilized again under COVID for advancing, access to tuberculosis services. And so, I think, what we've learned from this process over the past 2 years is that where there is sufficient political will and investment in data and technologies, and really pinpointing how to, extend those services to the harder to reach populations, can really make a difference.
Make some wine out of this lemon. So we have another question. Lorianne Christian that I'd like to elaborate on. Washington Congressional District 3, the U.S. House of Representatives asks, a softball really, what specific policies and initiatives would you like to see supported by Congress? And that's might be an easy one to answer, but I would like to frame it in as thus. Here at Foreign Policy, we know more than most, I think, that in addition to health and the pandemic, there are so many issues we're facing right now. Climate, conflict, there's pressures on budgets, there's economic pressure right now. We are one of the largest funders of global health security, but are in the midst of a massive economic crisis, geopolitical and internal political firestorm. What can Congress do? What should Congress do reasonably, considering everything going on in the world right now?
Well, there's been great leadership in Congress on this issue. As you said, the longstanding investments in global health aside, there's been real leadership on global health security and an understanding that this issue is urgent and important. The president put forth his own budget, sort of looking into the future as to what we need, not just for the current response, but for this financial intermediary fund and other preparedness mechanisms. And so I'm glad you mentioned budgets, and I think Congress has an opportunity to take additional steps there as well. But there's also this important focus on health beyond health security. I think that's really a critical issue, because what has happened over time is we've gotten so great at focusing on specific issues like HIV, like maternal, newborn, and child health, like Ebola or COVID, and I think we have forgotten about the spectrum and the systems in which all of that work happens. And so the degree to which Congress can continue to think about and even focus on or invest in health workforce, health systems, and data and surveillance, and other really important components that take us towards universal health coverage, I think that'll be really key, because then we won't find ourselves playing this game of whack-a-mole for each crisis, let alone fall behind in the progress we've made on critical issues like sexual reproductive health and rights, like HIV, TB, and malaria.
Excellent. And let's broaden that question out straight up, John, for you. What would you invest in going forward to prepare for the next pandemic emergency?
There's all sorts of ideas right now.
He's got a book.
I've had lots of books. I've had Ian Bremmer's call for a surveillance system, or Bill Gates' very detailed study on how to create a global response for pandemics. We've got the Council of Strategic Risks has got a great report. The Milken Institute has studies about how to build out even before pathogens get into the human circulation. There's lots of ideas out there contributing from science in the private sector, public sector. We need to fund them. One of Bill Gates' points is we never had a fully paid fire service in the United States until 1853, when Cincinnati created one. Today, we have 311,000 full-time firefighters in the United States, 30,000 departments. We spend $50 billion a year preventing fires. We need to prevent pathogens, and that requires us to be global in our perspective and global in investing a small amount. Bill Gates wants his global epidemic response and mobilization germ, he calls it, $1 billion a year is what he's saying. These are relatively small amounts, and from a private sector, the losses to the private sector, as well as to governments, from this pandemic are enormous. This is a small investment to be making. We're happy to pay for fire departments. We should be paying for pathogen prevention.
Excellent. Catherine, over to you. If you could take us home on this. If it's books you're reading or reports you're writing, if you could tell us what you would invest in if you were able to wave a wand to help prepare for the next crisis.
Well, I really want to reinforce the importance of investing in primary healthcare services and the delivery of care at the community level for several reasons. I mean, first, we've seen that countries that did invest in primary healthcare before the pandemic were better able to maintain other services and mount an effective response, whether through diagnosis or getting patients to treatment rapidly. Routine immunization services have to be seen as an essential element of pandemic or health emergency preparedness. Just as we need to have robust research programs in place for the development of new products, new vaccines, we also need to have strong routine immunization initiatives so that we can deliver those new vaccines for pandemic pathogens when they are available, but so we can also continue to deliver the vaccines to children to prevent outbreaks of deadly diseases like diphtheria, measles, and others. But investing in both of these can also really help strengthen confidence in the health system at the community level and confidence in public systems more broadly. Something that we've really seen in this pandemic is people have just been, sort of shocked and unable in many cases to grapple with all of the shocks and challenges over the past few years. But finally, I think we really need to invest considerably more in the health workforce across the board in terms of recruitment, training, ongoing professional development, pay and benefits, security, both physical security and in crisis and emergency situations, and protection from health threats on the job and their retention, so that the next time we have a crisis, we're not scrambling to find the people we need to address the problem.
Investing in our health workforce is a brilliant idea, and I think many good ideas. Thank you for mentioning that, and I'm glad we didn't leave that on the table. Catherine, thank you so much. John, thank you so much. Lois, please thank our panelists for a really interesting and intriguing discussion.
For a conversation on applying the lessons learned from COVID-19, please welcome Thomas B. Cooney, Director General of IFPMA, and Foreign Policy's Managing Director of Analytics and Events, Allison Carlson.
Thank you to the previous panel and to Andrew for moderating that. I think they left off in a place where I would like to pick up with you, and thank you so much, Director General, for joining us today. As we discussed, we're talking about lessons learned and what can we do better the next time. And in terms of studies, I'd like to recommend one that your organization published last month and pick up there. In that study, and I invite all of you to check that out on our website as well, applying lessons learned from COVID-19, you state, the global healthcare community has collectively failed in a shared commitment to equity and solidarity, in the moral obligation to the most vulnerable, and in the foundational conception of health security. So as we kick off today and think about the lessons learned in this moment, what are some of the key lessons that come to mind for you and what we can be doing better the next time?
Thank you very much, Alison. When I look at it from an industry perspective, it's important on the one hand to admit what didn't work well. We all tempted, whether it's government or industry, to be self-congratulatory and pat ourselves on the back and say we did everything right, and if something didn't work well, it was the others. I do believe we need, in terms of lessons learned, first to make sure that in a future pandemic, we do not compromise what worked well, and then address and tackle what didn't work well. And that's why I'd like to start with what worked well. First, it was just glancingly mentioned before, in a pandemic, the utmost importance is immediate access to pathogens and genetic sequence data. That worked amazingly well because on January 10, 2020, you had the first genomic sequence of SARS-CoV-2 published, and a collaborative data bank of scientists, basically, called GSAID, has been tremendously important for everyone working on tests, treatments, or vaccines. I mentioned that first because when you talk about a global pandemic treaty, there are people who think that you need to make this more complicated. And there are discussions about introducing elements of the Nagoya Protocol, which is for protecting biodiversity and access benefit sharing. Now, for God's sake, who wants to protect pathogens? You want to eradicate them, and the data need to be shared. The second element which worked well was the power of science and the power of innovation, which means, as Peggy Hamburg earlier said, going back to the early 1990s, the fruits of mRNA came through. There weren't that many people expecting that. Many people, including within the USG, thought, you're crazy in Warp Speed to put all that much money on Moderna and the mRNA vaccine. At the end of the day, it was really the game changer. But having said that, what didn't work well is the equitable access, multifaceted as always, because for very good reason, and I'm sure you will hear that from Seth Barkley later, COVAX bet their money early on the easier to transport logistically to use non-mRNA vaccines, the AstraZeneca Oxford, by and large to be manufactured in India, and Novavax. And that didn't quite materialize for political reasons. India stopped exports on April 1. Novavax hasn't come through to more or less to the end of 21. And then you had to improvise. And that really led to a huge challenge in equitable access. And together with that, and John and Kengasang, as well as Lois Pace and others mentioned it, our healthcare systems in our industrialized countries weren't quite as good as we expected. And we still faced the problem of absorption capacity, country readiness, getting the jabs from ports to arms. And if you do not draw the lessons in terms of that importance of primary health care, of strengthening health systems, we will be confronted with the same disaster next time around.
Absolutely, and there are so many points I'd love to dig into a little bit deeper throughout our conversation, but something that you first mentioned about data sharing, I'd like to follow up on. Something that we've been looking into, some of the research that we've been doing more broadly is related to data governance and changing data regimes around the world. So I'm curious how you're thinking about that in terms of what has worked, but also increasing global trends of more nationalization and protection of data, and what are the steps that can be taken for greater data information sharing going forward based on what has worked that you mentioned at the outset?
When it comes to this pandemic, I think one of the elements which I saw in my industry was an early realization, this is business not as usual. Who would have thought that companies such as Novartis or Sanofi would become or MSD Merck & Co. in the US would become contract manufacturers? Because either they had quit vaccine manufacturing or their products didn't come through. And therefore, the collaboration, the exchange was amazing. The information exchange, when I look at in terms of clinical trial and development, I would call out two examples. One is ACTIV, run by the NIH in the US, and the other one is the Recovery in the UK, where Martin Landry and the UK did a remarkable job to, by the way, rescue some repurposed medicines which originally had failed in the ACTIV trial, but then Recovery showed like the anti-inflammatory, toxicilumab, it worked. I must say I've never heard pharma CEOs putting as much praise on regulators. And Peggy Hamburg, in her lunchtime fireside chat, mentioned the importance of global collaboration. ICMRA, the International Conference of Medicine's regulatory agencies, really work together in an unprecedented way. I've seen industry actually being open to collaboration in an unprecedented way. And again, the importance of immediate access to genomic data. And it was said, Omicron was shared by Dr. De Oliveira from South Africa. Next day, South Africa was slammed with a travel ban from the UK as a reward for that. That's probably not quite the way to incentivize data sharing.
So picking up on a few other comments that you made, when we think of global public health and the community that's persevered throughout the pandemic and getting the resources and biopharmaceuticals to those who need it most, how are you looking at that in terms of equitable access and the role of the biopharmaceutical industry in moving that forward?
You mentioned it in quoting, our study at the beginning. At the end of the day, whatever the reasons were, one of our lessons is if we want to do better next time around, we also have to do our part. Now, when I look into the challenges, there were, at the end of the day, more than 80% of the vaccines used by COVAX came from 4 innovative vaccine manufacturers: Pfizer, BioNTech, AstraZeneca, outside India, Moderna, and J&J. But they came later than, for example, Africa had expected it, because they were waiting for the ones coming out of India. Therefore, for me, I agree with John and Kengasong and others that when you look at what happened to Africa, they got their first vaccine shipments on the same day Tokyo got the first vaccine shipments. But then, because of the Indian export bans, nothing came out for 8 months. Irrespective of the laudable vaccine manufacturing initiative, whether it's the collaboration of J&J with Aspen, the BioNTech example in Rwanda, Senegal, and South Africa, the Kenya initiative of Moderna, I think realistically you have to assume that it may take longer for vaccines or treatments to come out of those new plants if they work, and there are challenges to make them work. And that's why, in my opinion, industry can play an important part by committing to put aside part of real-time production of vaccines or treatments in real time for rollout to vulnerable populations. One of the big disappointments in the current pandemic was early on in April 2020, Kate O'Brien, Director of Vaccine Policy in WHO, had come up with a priority allocation principle. 1% of the global population is frontline healthcare workers. 8% of the global population are above 65. More than 30% in Japan, less than 5% in many parts of Africa. Nobody has ever really checked whether we followed up with this kind of prioritization, and therefore I think we do need a kind of social contract where the industry can do its bit, accepting less money than you would make if you just sell to the US, UK, and the EU, putting aside part of production, but that will only work if, on the other hand, you do have funding available for organizations such as Gavi, UNICEF, and COVAX, or Global Fund in the treatment area, and if countries allow open borders. I did mention India critically, but let's face it, not a single dose was allowed to leave the US before July 21. And there was a presidential executive order which said, we want to make sure that every American who wants to get the vaccine has it, and then the excess doses we will allow. If we don't have social contracts that we are willing to share upfront for the vulnerable part of what's available, it will not work, and we will fail again.
In addition to the social contract, when you think of investment that's needed for distributed manufacturing around the world, where would you prioritize and what needs to be done next to help ensure more geographic distribution and manufacturing around the world?
When I look at the mushrooming of initiatives, and it's difficult not to call it mushrooming, I'm not sure that we need more. Because even in order for those who already initiated by the European Union, by USAID, by individual companies, we probably have more than enough. Current COVID vaccine capacity could easily exceed 20 billion this year, Demand may be between 4 and 6 billion. Therefore, if you don't tackle the need for the skilled workforces in the places you invest, you need a strong regulatory system, which means you need an African Medicines Agency, which is not just a declamatory statement of the African Union Summit, and you need sustainable markets. Because I can't imagine that the rich countries are willing just to subsidize ever-warm vaccine manufacturing plants if there's no demand. And we have seen Aspen, for example, did announce earlier this year we have 0 orders. Therefore, if nothing happens, we will have to hold production. Therefore, I think we need a reality check in terms of sound economics, what's needed. Having said that, I violently agree with John and Kengasong. Africa needs to become more self-sufficient in terms of manufacturing of vaccines or treatments. And by the way, we always talk about vaccines. When I look at the rollout of treatments, one of the challenges for companies was that if you do not have the strong medical guidance from a WHO, for example, with the best will you have in terms of access policies, it's difficult to get the medicines to the people who could need them because Global Fund is not allowed to procure anything which is not WHO approved. Lucky those where you have a dual use, where you have an anti-inflammatory like toxicilumab, which is approved for other uses. But if that's not the case, and honestly, that's where WHO was not that strong during this pandemic.
And when you talk about getting biopharmaceuticals and COVID tools and others to the last mile, getting them to the locations of where they need to go and the healthcare workers that need them, which thank you for referencing the workforce. We actually have a panel coming up that's specifically about that. But how are you thinking about trade? I mean, over the last few years too, amid all of this, we've seen incredible disruptions to global trade. What needs to be done to make those supply chains more resilient to help ensure that those medicines get to the last mile?
Open borders are absolutely critical. Now, one of the surprising features of the COVID pandemic was that by and large, pharmaceutical supply chains, including those from China, held up remarkably well. There was an expected shortage of raw materials for vaccine, of the giant plastic bags for single-use bioreactors. That was to be expected when you treble global vaccine capacity pre-pandemic overnight. But overall, with the exception of some painkillers, OTC medicine, with the exception of, for example, some muscle relaxants which you needed for intubation, by and large, the supply chains held up remarkably well. But what I see happening in companies as well as by governments is to think, what do we need to do to become less dependent on single source suppliers? And the term I was in Berlin last week, and the term I've heard there used more than once is friendshoring. And friendshoring means that you will not get away from globalization, but you may see Europe trying to become more independent, and you have seen similar initiatives here in the US, and you see this around the world. I think there's a realization that we need to be well prepared for the next pandemic. The worst supply issues, by the way, were masks and PPEs, and basics where governments had not quite kept up with the storage needs. You would need to be well prepared.
Following up a bit on that, so you're representing the biopharmaceutical industry on the access to COVID-19 tools, the ACT Accelerator, which is a unique global collaboration to accelerate the development, production, and equitable access to tests and treatments and vaccines, as you've been discussing. So when we're moving forward, and I know we only have a few minutes left, I'm wondering, what are you seeing as some of the breakthroughs in that collaboration, and what can be built on going forward?
I think the sense of partnership has been extraordinary. I see it strongest in COVAX, where you have, with Gavi, UNICEF, and CEPI, you have 3 organizations all used to work with the private sector, all, with a common purpose and a common intention. And I think one of the important success factors of COVAX, notwithstanding the challenges, was that everybody felt like one team. And the industry, to be honest, until 3 years ago, few of the big pharma companies were interested in CEPI, the Coalition on Epidemic Preparedness and Innovation. Richard Hatchett and his team over the last couple of years really made themselves known. And I think even big pharma understands the need, for having an organization which may be more relevant for small biotech companies. And one of the big success stories, of course, is Moderna. There's occasionally been talk about how much money did they make, but when you look at the investment by BARDA in Moderna, it's probably one of the best returns of any BARDA investment ever.
And last question for you before we move on to our next panel. I'm just curious, what are your areas that you're focusing on for public-private sector collaboration, and where are the areas that offer the most opportunity as we move forward? And there is an absolute need for private industry and national governments around the world to work together.
When it comes to, for example, the 100-day mission, again mentioned in the G7 statement today, that is an area where you need public-private partnership. When it comes to decision-making on regulatory, it's quite clear that that's where the FDA and EMA and others need to make the calls and the shots. But in terms of actually analyzing where could you make further improvements, the amount of quality regulatory prescriptions on good manufacturing practices, where occasionally you need 500 forms to be filled for single change of variant. I think we can improve in terms of really getting closer from the 326 days to the 100 days. And I think we all need to respect each other's respective competence. We need to be very open in terms of transparency of data sharing. I personally would like to have better vaccines against the variants, longer lasting, maybe new formulations. And I think we need to work together with the regulators, with the decision makers, and we need to work collectively on how can we improve on the last mile. How can we make it possible to get the jabs from ports to arms?
Well said. Thank you very much for your time. We are unfortunately out of it. But would really like to thank you for joining us today in person. And thank you again as we welcome our next panel.
Joining Allison for a conversation on fortifying and globalizing the healthcare workforce, Nidhi Buri, Acting Senior Director for Development, Global Health and Humanitarian Response at the White House's National Security Council, Avril Benoit, Executive Director of Doctors Without Borders, Zipporah Irigi, RN and Nurse Advocate, and Dr. Janet Muriarki, Senior Director of Health Workforce Development at IntraHealth.
Thank you everyone for joining us. And several of the panels that have spoken so far have touched on the workforce, very importantly, because it is the absolute bedrock of our healthcare systems, and healthcare workers have been on the front lines, all of you knowing that much more intimately than most of us in this room. So first of all, thank you for your work, and thank you for being with us today. We're really excited to dig into the policy areas, the investments that are needed to strengthen the workforce, and also what all of you have been experiencing on the front lines around the world. So let's dive in. Nidhi, I'd like to start with you. Thinking about healthcare security and national security, what are the priorities that the administration is having right now, and how is the National Security Council thinking about healthcare in this national security frame?
Thanks for the question. So, one thing that's deeply important to the administration is to think broadly about what it takes to prepare for the next pandemic threat or any health threat. And while we focused a lot, obviously, on lessons from COVID and what that means for new variants and new infections, I think the last 2.5 years have been a strong reminder to us of the importance of having a wide interpretation of what we mean by health and public health. We define health workforce broadly, not strictly to be clinical providers, not just public health providers, but kind of all components of the health system. And I think it's particularly important because what we've had during COVID is a time where almost every country in the world, in their necessary efforts to deal with an acute threat on hand, have had to make trade-offs within their health system, which means a redirection of services to deal with COVID, taking away from something else. And over time, that essentially will contribute, and already is contributing, to significant backsliding and development gains, which means that communities are losing gains that they've had in health, but as they potentially are unhealthier or not able to keep up with the health needs of populations, has ripple effects economically and politically. So when we look and have the long view, health security really, I think, is centered in health systems, and the core of that are the people behind it who deliver the work.
Great, thank you. And thinking about it internationally and across borders, Avril, I'd like to bring you in. From the perspective of your work with Doctors Without Borders, what have you been seeing on the front lines, and where are you prioritizing your work now, understanding that healthcare workers have been and continue to be under significant stress?
Well, we work in more than 70 countries that in general are underserviced when it comes to healthcare, or they are in humanitarian crisis. And so what we were seeing systematically from the beginning and right up until today is a lack of access to all the prevention, treatment, the vaccines, the PPE, even oxygen, to make it possible for workers who are also dealing with war wounded, with malaria, with childbirth, to be able to protect themselves and have a fair chance of really dealing with what was in front of them as the pandemic came through each region from place to place. And so for us, the tragedy of it all is that at a time when health workers were needed more than ever, there was a shortage of them, they weren't well supported, there was such an underinvestment in the health systems that we see that continues to this day, which is demoralizing at a time when it should be a highly motivating moment in time, when we should all be celebrating and feeling good about being part of a health organization, a medical organization. So it's just, it's regrettable that it seems that we have not learned the lessons, and many of the things that I've heard over the course of today's session at this forum have really shown that there are the right things to do, and we know what they are. We just have to do them, and do them especially for next time.
What isn't being done? If we're identifying what those things are, what are the barriers that are inhibiting it from actually getting done?
In short, it's an underinvestment in health systems, in the healthcare sector, in having trained medical workers, in having the supply chain be able to meet the needs, and also just fundamentally for the availability of the resources to be needs-based. What we have seen over the course of this pandemic, of course, is that the wealthier countries have tended to keep things for themselves. And although there are many gestures and commitments that are made, at least statements that are made about we're going to share, we're going to really be all in it together, because when it's when it's not over for some people, it's not over for the rest of us. What we have seen actually is that there's just this incredible inequity. And so the under-resourced places where there is a need have to be addressed, and they have to be prioritized, in short.
Thinking about under-resourced and those on the front lines, I'd like to bring in Dr. Murayuki from IntraHealth. And thank you again for joining us online and for joining us virtually today. When you're thinking about your work and about improving the performance of healthcare workers and strengthening systems for those on the front lines, what are your priorities, and where do those investments need to be made most?
Thank you very much for the question, and good afternoon to our audience. I think for me, I want to look at the needs of the frontline health workers, in that they're grieved, and we need to really respond to them. So I want to give a small story about a health worker called Lydia Kanyoro. She's been a graduate at one of our Kenya referral hospitals, where she's pursuing a course in pediatric medicine. And she goes out there and commits suicide because she's stressed, she's depressed, there's burnout. And she's just one of the examples of the many health workers we are having who, during this period of COVID, have actually suffered a lot of mental health issues. And I think for me, one of the areas of investments really is, can we have safe and well-being programs for our health workers? I think that needs to be a priority right now. We need to look at also areas of decent pay for our health workers, ensuring that they also have conducive working environment that will support them in ensuring delivery of quality health services. And especially as we look at universal health care, responding to primary health care. Out of the recent World Health Organization, World Health Assembly 75, I think there has been a call towards one health system, and one health system being supported by competent health workers. So looking at health professional education and the systems that support them is going to be really critical. One of the areas that I would want to emphasize, and this is in line with what IntraHealth is doing, is really looking at health workforce planning. I think, to me, we need not look at planning as a one-off event. It needs to be systemic. We need to put resources to that. It's all about data, dialogue, the dollar, and the decision-making. And this is really going to be pivotal in terms of getting evidence around our health workforce, whether this is by supporting WHO initiatives like the National Health Workforce Accounts or the health labor market. That evidence needs to be put out there to the decision makers. The other area really is also around elements such as ensuring that our health workers also have a platform to share their grievances. In Kenya, we have something we look at work councils, dialogue between employer and employee. Those are critical because that's another area we need to avert industrial unrest. And this is happening a lot in the sub-Saharan African countries that are really suffering from a shortage of our health workers. The other area for me is mitigating issues of health worker migration. We have seen this during COVID-19 pandemic. We have seen our health workers moving from the low or middle income countries going to the higher income countries. And this is because certain measures were put in place by the high income countries to attract the workforce from the sub-Saharan African countries, which are already suffering from a high shortage of health workforce, moving them to the high income countries. And I think for me, for some of these measures to be, for migration of health workers to be supported, I think really we need to look at how can the developed countries, those high income countries, support infrastructure, especially again around health professional education, ensuring that if you're looking at the faculty, you're supporting curriculum, you're ensuring that the work environment, with the learning environment within the medical training institutions is similar to those of the developed. And as those low-income countries are doing their own, supporting their workforce development, that they are in a position to manage their production and therefore the stock within those countries, then there's extra for, to migrate to the high-income countries. I think that would be a critical area for consideration. Again, it's also looking at areas in which for example, recently, the Africa CDC put in place a fund toward, a support towards elite workforce to support the surge. I think these are critical elements we need to look into. Who are this elite workforce? Is it only the epidemiologists, the lab technologists, No, I think we need to consider the clinical workforce that should be availed, should also be supported for any events of pandemic. And therefore, they need to be able to prevent, detect it, and also provide the treatment, especially for the community. And I think this ties in line with earlier conversations on the financial investment fund for pandemic preparedness and response that is being supported by the World Bank. Such a vehicle is critical to support both the developed and the low-income and middle-income countries, so that all these countries are actually in a better position to respond to any global health threats and a future pandemic, while still responding to current issues on disease trends, as well as primary health care.
Absolutely, and thank you. You outlined so many critical issues related to the workforce, and I want to come back to several of them. One of them that you mentioned at the outset of your comments is the need for platforms to really be able to communicate what frontline workers are experiencing on the ground and what is needed at the time that it's needed to not only deliver resources that are needed in the moment, but also then to better prepare and anticipate. And in terms of those working on the front lines and elevating the experiences, I'd like to turn to you, Zipporah Irege. I know you've been working on the front lines of the pandemic as a nurse in Kenya. And I'd love to hear from you, what have you been experiencing over the last few years? And how would you encapsulate some of the challenges, but also what you've seen as bright spots and really opportunities going forward to strengthen the workforce and in particular nursing where you are?
Thank you very much for that question. I'm pretty new to the nursing field, actually. 3 years in experience since I graduated. And I think by the moment I was starting to work, it was the beginning of the pandemic. And at that moment in my country, we had so many strikes running around in different counties as people are complaining about, or rather lobbying for better pay, PPEs, which were not available at the time, better staffing in the hospitals. And that was my experience as I came in. And I think even for me and a majority of my colleagues coming into the field of nursing and into the field of clinical practice, then that for a moment was very demoralizing, even understanding from those who have gone before us, the kind of conditions they have had to work in, and also having to provide quality healthcare for that. But I think all hope is not lost, because what COVID did for the healthcare worker, especially the nurse, was amplify the kind of work that we do, because, I apologize, because for example, to get the vaccines of COVID to people, you need the healthcare person. And so an investment in the healthcare worker is required to ensure that even we are preparing ourselves better for the pandemics in the future. God forbid that we ever get another one. So I think through that period of COVID, we saw healthcare workers become innovative in their spaces of work, find innovative ways to provide care to patients, with the presence or without the presence of proper PPE, and provide quality healthcare for patients. I saw healthcare workers come together to find solutions of how they can save the use of gloves, or how they can distribute masks in their communities and in their hospitals, just to ensure that they are providing quality healthcare whilst adhering to the COVID measures. So I think even in the situation of understaffing or underpay, we have seen healthcare workers rise to the occasion and provide solutions to implement the quality of care in their spaces. And like Janet said, I think there need to be proper channels for healthcare workers to be able to connect with their leaders, and it could be just leaders of the facilities they work in, leaders in their communities, leaders of their associations, leaders of their unions, and even the governments. In Kenya today, we have what is called quad leadership of nursing, where we have the union, the legislative board, that is the Council of Nurses in Kenya, the professional body, the Association of Nurses, and even our Director of Nursing Services, at the national level in the Ministry of Health. And we saw them having meetings during the period of COVID, just to see how they can help nurses and other healthcare workers during COVID. And I think one of the major things that happened was partnerships, even with leaders in other spaces. We had, for example, the Equity Bank partner with the Association of Nurses in Kenya, just to they were coming in to help establish a psychosocial support for nurses, because of the stresses that were going on during COVID, just to give them a platform where they can call in and just have conversations with professional counselors and other healthcare workers and share their experiences, be able to be counseled through that stress period, even as we look towards dealing with burnout amongst healthcare persons, and as well mental health issues, and just taking care of the healthcare workforce in general. But I think also we also need to think about how to create a better environment for work, and that may look like employing more healthcare workforce, making sure that people are staffed in proper ratios, nurse to patient ratios, for example, and also making sure that we are providing on time and proper remuneration to the healthcare workforce. Yeah, thank you.
Great, thank you. And we'd like to turn over to you, Avril. I know that you were recently in Ukraine. And in addition to everything that frontline workers have been grappling with over the last few years with respect to COVID-19 and dealing with the pandemic, there are compounding pressures and stresses on the healthcare systems that are coming from conflict, are coming from other pressures and dynamics in the local environments, and other demands on nurses and physicians. So can you describe a little bit about what you saw and what you experienced in the context of Ukraine, and again, what's needed for those on the front lines and the partnerships that are able to deliver them in the moment?
Well, Ukraine strikes me as just another example of a place that has its priorities. And the priorities in a war is to treat those who are wounded in the war. And a lot of other things fall by the wayside. So whether it's response to the pandemic and managing intensive care units for people who are coming in great distress, or it's people who are in need of ongoing treatment for their non-communicable diseases, chronic diseases, diseases of older age, these kinds of things really get deprioritized. And with the pandemic, this COVID-19 pandemic, we saw a repetition in many places of what we had seen previously in Ebola outbreaks, which is that all the funding, all the public funding goes into that one thing, and it tends to draw out and draw away many of the health workers, the frontline workers that you actually need for all the other stuff that's killing people and making them sick. And so for me, the Ukraine is just one of many examples like that. And the stress of all of this, we understand that in a place like Ukraine at the moment, or Yemen, or Democratic Republic of Congo, or other places that are in these extremely volatile, tense, violent contexts in the regions like that, you have the mental health burden for the frontline workers, and we heard about the need, and it really is a pressing need for mental health services to be accessible and appropriate to support the health workers in those situations. But also in places like Brazil, where you end up with the kind of burnout that stems from just a complete disillusionment with the lack of evidence-based approaches to public health. And you just say, wait a minute, here I am sticking my neck out trying to work with my community. We're struggling for everything here, including just basic notions of science, to make those clear. And so you can imagine the disconnect and the disheartening experience that must be to be in an environment with such intentional disinformation at the highest levels. And then on top of it, you lack PPE, you lack the testing, you lack all the oxygen concentrators to be able to deal with the situation in front of you. These are the kinds of things that we just need to be constantly aware of, is that a frontline health workers has to be able to treat others by remaining safe. And so that whole notion of protection is not just their physical well-being in the presence of an unknown pathogen. It's also their mental well-being in the face of what could inevitably be burnout and leaving the sector, which is catastrophic.
Absolutely, and we've seen so many healthcare workers, nurses, caregivers leave the industry because of that and because of that burnout. And with that attrition, how can we prepare for what's next? And how can we really strengthen the workforce? And mental health is something that I think historically has not received the attention that it needs and the investment that it needs for support programs as well to continue to support healthcare workers on the front lines. Needy, I'd like to turn over to you in terms of that, and would love to get your reaction to that conversation about investing in mental health as part of a security and workforce strengthening agenda.
Yeah, thanks for that. I think it's an area that many people in this space very much acknowledge and see the need for, and we are still falling short in making targeted and sustained investments in supporting mental health and well-being of the workforce at all levels. And I think there are a few things to consider. So one is when we think of health systems, first and foremost, health systems need to reflect the communities that they serve, and health workers are part of those communities. We, have looked at through the course of COVID the need to address supply chain gaps and delays in getting PPE that impact physical protection. But what we haven't looked at so much until more recently is the cumulative effect of inequity and how that presents and that combination that it has with burnout for those who are really on the front line, regardless of what types of services they're providing. And specifically what I mean is, we have a time where we've had a lot of strain to health systems, but with that, I think we also have a moment of incredible opportunity. We have so many lessons to reflect on, not just from the last 2.5 years, but from specific settings, as Avril noted, with Ukraine or specific countries currently that are reminding us of lessons we've known for a long time, of things that we need to do more of or potentially differently. And when it comes to looking at mental health and well-being, we should not deprioritize or consider mental health and well-being as any different than the physical safety of health workers. They are all components that impact the ability of an individual to provide services, to meet communities where they are, and for the ability of a health system overall to not just stay afloat, but maintain the agility and flexibility needed to withstand shocks to the system. And so in that sense, it doesn't matter, frankly, if it's a disease outbreak or a conflict setting. What we should look at is the services needed for providers on the front line, again, with a wide definition of providers, and see how at the community and national and regional level we can surge in those resources, but also not just look at it as surge, have a baseline capacity that's improved so that providers and health workers get the services that they need.
And so when you think about that and prioritizing investments and the proposal that the White House has put forward in terms of investing in the workforce over the next 5 years, how are you thinking about prioritizing, and how is the administration and the Security Council thinking of prioritizing those investments to strengthen the workforce?
Sure. So if some of you might know, in May, we launched on behalf of President Biden his Global Health Workforce Initiative, which is intended to be a framework to guide our investments in the U.S. government, but also to serve as a way to better coordinate investments that multiple parts of the international community are making in the health workforce. And a core pillar of that is looking at equity, and another one is protection. And I think when you think of mental health and well-being, it can fit very nicely in both. We know that it's not just about prioritizing mental health and well-being. It's also looking at, within the health workforce, those who are in rural areas, women, representative of marginalized groups, who have a harder time accessing services in a range of ways that would eventually support or kind of accumulate to improved well-being overall. And that is a factor of retention. Health workers are human beings. If they're pushed to the limits, understandably, everyone does need a break at some point. What we're looking at in terms of investment specifically is two ways. So one is looking at existing programs, some of which are disease-specific programs that we have as the U.S. government, some of which are health programs at large, both in development and humanitarian contexts, and looking at where we can do more to support mental health and well-being. But then the second is to really do a gap analysis and see what it is that we as an international community are falling short on, and see where the U.S. government can be an added value in helping closing some of those gaps.
Great. And we only have a few minutes left, but I'd like to turn it over to you, Dr. Mariuki, and then to you, Zipporah, in terms of what you need now and in terms of the investments that need to be prioritized to retain workers who are working on the front lines. What would you say are your top 1 or 2 priorities? Dr. Mariuki, and then Zipporah, over to you.
Yeah, thank you very much for that question. I think my top priority has already been mentioned, is really looking at the safety and well-being of our health workers. And the second one for me is really looking at ensuring that we are doing quite a bit around health workforce planning and recruitment. I put this across because the investments that have been done on health workforce are coming to about just 10%. And we have seen this when WHO was the last document they had on Working for Health Action Plan. They required about 70 million US dollars, but they only got funding of about 7 million. So my call is for donors and other agencies to really support our health workforce. And this will go a long way in addressing issues of primary healthcare and in turn responding to universal healthcare. I think just to add on lastly is that we need to really support sub-Saharan Africa in terms of health workforce shortage, and production through health medical education is going to be a game changer to address the dynamics in terms of availability, accessibility, acceptability, and also quality of our health workforce. Thank you.
And Zipporah, over to you.
Thank you very much. I think my 2 priorities, number 1 would be investing in healthcare workforce in terms of leadership and research. Research because data is very important in informing decisions, key decisions, especially in the spaces of policy making, to ensure that the policies that we are setting for healthcare and for the healthcare systems are actually backed up with evidence and data to drive that conversation, and to invest in the healthcare workforce themselves to be leaders in their spaces at whatever level of healthcare they are, to be able to be bold enough to drive change in their communities, whether it's at the hospital level, at the primary healthcare level, in the community, or at the high level at the policy table. And the second thing is investment in the young healthcare workforce. I being one of them, we are the leaders of tomorrow. So I think even as we begin this conversation of future plans for the future, reflecting on the lessons we have learned from COVID, then how do we invest in the young healthcare worker as early from their student moment to their internships, even as they are launching into their careers, how then do we build them up to be leaders for a better tomorrow? Thank you.
Thank you, very well put, and absolutely investing in the leaders of tomorrow. Thank you for the work that you all are doing. Thank you for being here today and sharing your experiences and your insights with us. We really appreciate it. Zipporah Agree, Dr. Mariuki, Avril Benoit, and Nidhi Bori. Thank you again. Really appreciate having you here.
To discuss how to take bold action to finance health security, please stay tuned for a conversation with Peter Sands, Executive Director of the Global Fund, and Foreign Policy's Editor-in-Chief, Ravi Agrawal.
Well, thank you so much for that introduction. I'm delighted to be joining you virtually today for FP's inaugural Global Health Forum. Much of what we've talked about so far relates to lessons learned from the COVID-19 pandemic, but a major point of discussion for world leaders is how to finance pandemic preparedness in the future. To help us understand these new models of investments and how the world can better prepare itself, please allow me to introduce Peter Sands. He's the Executive Director of the Global Fund, one of the supporters for today's program. Peter, welcome.
Very nice to speak to you today.
All right, great. So Peter, the Global Fund was set up, as I understand it, to combat HIV, TB, and malaria. But I know you've transitioned to invest in COVID-19 efforts as well. How does that transition work?
Well, it's worth going back into the history, actually. When the Global Fund was set up 20 years ago, HIV was the big pandemic sweeping the world. And that was the genesis of the Global Fund. And at the time, they decided to pick up the two biggest other infectious diseases, TB and malaria. And since then, we've made huge progress, cut the mortality by about half, saved over 44 million lives. But when COVID struck, we quickly recognized that it would be a disaster for the people most affected by HIV, TB, and malaria. And so we very quickly moved to enable countries to use our capabilities to help respond to COVID-19 itself and mitigate the impact on the other diseases. And since then, we've deployed almost $5 billion on top of what we already were investing on HIV, TB, and malaria to help countries respond to the pandemic. And that has meant that the Global Fund has been the largest provider of grant support to low and middle income countries for everything other than vaccines. So COVAX, as people know, did vaccines. We did tests, treatments, oxygen, PPE, enhancements to health systems, and so on.
And I know we'll get to this in a bit, but I guess one reason why this is so important is it's the last mile sort of response that has been one of the bigger challenges of the pandemic, especially after we had a vaccine, because then it became a game of how do we get these vaccines to the right people in the right places. But before we get into all of that, I just have to ask, and I ask this as someone who's had malaria a couple of times myself, and malaria, of course, still kills, I think upwards of 600,000 people a year. Is the Global Fund still able to do that as well as these new other things you've been taking on?
Absolutely. In fact, we are investing more in HIV, TB, and malaria at the moment than we have ever done, alongside our activity in supporting countries to respond to COVID-19. But we still have a big task. I mean, you mentioned malaria, Ravi, and it's a good example of the impact that COVID-19 has had. In 2020, we saw a 13% increase in deaths due to malaria, which basically meant we went back to where we were in 2012. So we lost 8 years of progress in 1 year of a pandemic. So we've had very significant reversals as a result of the pandemic on HIV, TB, and malaria.
Indeed, and of course, in many other sectors and diseases that, of course, your fund doesn't deal with specifically, but we hear this from people who deal with other sectors as well. So let's come back to the pandemic. When you try to think about how to prevent the next pandemic, or at least if there is a next pandemic, how do you mitigate it quickly in a better way than we did in 2020? What are the big ticket items that come to mind?
Well, the first thing is that new infectious disease outbreaks are not a kind of possibility. They're a certainty that we will have new types of pathogen threatening us. The question is whether or not we allow them to become pandemics. So the things you need to have are the capacities to prevent, to detect, and respond. Now, there isn't one single item there. It's a combination of diagnostics, infection prevention and control systems, primary health care, community health workers, supply chains, and so on. The good thing is that these are not something different. They are the things that you actually need to fight the existing infectious diseases. So, in fact, most countries' response to COVID-19, or at least the low and middle income countries, was based on the kind of systems and capacities that we had helped put in place to fight HIV, TB, and malaria. It was the same labs, it was the same community health workers, and so on. And so we need to invest smartly in those components of the health system, but doing it with a very deliberate multi-pathogen perspective so that we're not just narrowly focused on any particular disease, but we're providing the equipment and training and so on so as to enable countries to respond to both the pathogens they face today and those that might threaten from around the corner.
I get it now. And I mean, basically, what we're talking about here are these sort of massive infrastructural issues across the global south, especially the last mile stuff. And where, so I'm guessing you're talking about hospitals, human capital like nurses and doctors, but then you also add to that literacy, sanitation. So these are giant, sort of deep-seated issues in many parts of the world. Which I imagine you've been dealing with as you try to combat malaria and TB. What lessons from that process have you found most applicable to building up sort of strength and resilience in the healthcare system for pandemics or other diseases?
I think I would highlight three lessons. One is that you have to put a very deliberate emphasis on public health and primary health care. It's less about the hospitals actually than it is about the services that touch people in their own communities. And that links to my second point, which is you have to engage communities themselves. If there's one thing we have learned, is that to beat the most formidable infectious diseases, you can't do it to people in communities. You have to empower people in communities to protect themselves. And I think the third lesson that I would draw from this is that you have to be able to respond at speed. When these outbreaks occur, they can occur very rapidly, and time is of the essence. And to be able to respond at speed requires a degree of surge capacity, but it also means that you can't wait until the outbreak hits to build things like trust. Trust is a critical asset so that people actually believe the messages they get given. And so you've got to build that trust, in a sense, before the storm hits so that you can use it when you do have an outbreak.
Now, some of these things that you're describing that one needs to build are soft issues like trust, human issues like communities, community leaders, someone who can convince you to take a vaccine and you would believe that person. Some of it is hard infrastructure, of course, which costs more money. What's your sense if you had to put, a rough ballpark figure of like how much money the world is looking at to sort of try and be more resilient when there is another pandemic?
Well, you've seen various estimates. The G20's high-level panel estimated that, say, $10 billion a year would be required, with about half that going into the health system infrastructure of low and middle income countries, and the balance more on surveillance and on R&D. I think part of the issue here, though, is that if we're to really take an equitable approach to this, and I think we have to, because the reality is that no one is safe until everyone is safe is the dictum, and it's true. If we're going to take a truly equitable approach, it's not just about having equitable access to tools, vaccines, diagnostics, medicines, and so on when a pandemic hits. It's also about having an equitable definition of what counts as a pandemic. There's a little bit of a danger as we have these conversations about pandemic preparedness, is that there's an implicit definition that a pandemic is a big infectious disease that happens to kill people in rich countries, and that we tend to use somewhat different language when people in rich countries feel less threatened. If you think of what happened with HIV/AIDS, for example, it was a pandemic, but now we don't tend to talk about it as a pandemic. It still kills a very large number of people across a large number of countries. It's just it's much less of a threat in rich countries. And so I think it's important that the approach we take to the deadliest infectious diseases is one that counts all lives equally and protects everyone wherever they live from these deadly infectious diseases, and is also designed to ensure that everyone gets the tools they need to be protected from them. And that's true both of the existing diseases as well as the new ones, because the existing ones are frankly old pandemics that we haven't yet finally defeated.
You know, what you say about equity makes so much sense, and it's not only, I guess, to protect the whole world, but also because it's the right thing to do. And to your point of trust, that is how you build trust. And much of the criticism of the handling of this pandemic was that there were issues with equity. There were issues not only with vaccine distribution, but with, you know, the tools that many countries had or didn't have to be able to combat what they were presented with. I hear you on that figure of 10 billion, but that of course seems quite small, right? To deal with the kinds of things we've been discussing.
If you do the contrast between what it would take to protect the world better from these diseases and the potential sort of economic upside or reduced downside risk, it's a no-brainer as an investment.
Yeah.
And to be clear on the 10 billion was the high-level panel's estimate of incremental spend on top of what we are spending already. At the Global Fund, we are spending about $4.5 billion a year fighting HIV, TB, and malaria, and we're looking to increase that to about $6 billion a year through the replenishment, which we're targeting to raise $18 billion.
You know, at last year's G20 summit in Rome, there was a proposal for a financial intermediary fund, an FIF, I think as it's called, that would be spearheaded by the World Bank and the WHO. Tell us a bit about how that would work.
Well, I think the idea of the Financial Intermediary Fund is to mobilize additional resources, so not cannibalize existing development assistance for health resources, such as the kind of resources the Global Fund uses, but additional resources to help countries build better health, more resilient health systems, to increase disease surveillance capabilities, to fill gaps in the system, including by looking at some of the bottlenecks around manufacturing and rapid introduction of new products. I think the critical issue as regards this proposal is that it shouldn't cannibalize existing resources, because to do so, to take money away from efforts to combat diseases that are actually killing people, to build preparedness against diseases that might kill people, seems like a pretty tough proposition. But also that it's done in a way that leverages the capabilities of the institutions that are currently working with countries on their health systems. So the Global Fund is the largest multilateral provider of grants for health systems. So the way the FIF works with existing global health institutions is absolutely critical to make it as efficient and effective as possible.
Peter, if I can ask you to put your old hat on as a banker, someone who ran a major Western bank, you know, or your economist's hat on, where are the hurdles here? Is it that there simply are too many crises around the world and not enough money? Or is it an issue of will and allocation and priorities? Or have the last couple of years shown that we can print more money and deal with problems, especially in the rich world, if we need to? What's your sense of where you stand in that debate?
Well, there's no doubt that the world has quite a lot of crises right now. We're seeing conflict, we're seeing disease, we're seeing climate change-driven extreme weather events. But that's the reality we face. And it's not going to get better just because we would like it to. And so I think we've got to confront that reality. And the richer countries of the world have to recognize that the logic of investing in preparedness is so much more cost effective than trying to deal with disasters like a pandemic when they happen. I mean, the response to COVID was so much more expensive in lives and in money than we would ever have been able to spend in preparing and preventing it happening in the first place. The other thing, though, I think is critical here is that it's really difficult in this realm, in global health as in others, to spend a lot of money over a long time on preventing things happening so that success is that nothing happens. It's just really hard to keep people interested. And so the trick here is to be investing in a way that delivers benefits today in fighting existing diseases while simultaneously making us better prepared for future ones. And that can be done. It's perfectly possible to do it. And so when we talk about things like the fifth or other measures to make us better prepared for the next pandemics, we have to think about how do we do it in a way that maximizes the synergies between investments to fight existing diseases and investments to fight future ones, and delivers every day, because that's how we will ensure that this is a sustained effort, as opposed to something that kind of lasts while the memory of COVID is fresh, but then quickly stagnates afterwards.
Fascinating. Peter Sands, thank you. I wish you luck, because the evidence seems clear that at some point we will indeed have another pandemic amid all these other issues that we have, and we need to be prepared. So thank you.
Thank you, Ravi.
That's it from me, Ravi Agrawal. Lots more ahead today, and I hope you enjoy the rest of FP's Health Forum.
Distinguished guests, we will now take a short break. Please meet us back here at 3:15 to continue the Foreign Policy Global Health Forum. Distinguished guests, please take your seats. The Foreign Policy Global Health Forum programming will begin shortly. If you've joined us in person, please submit your questions at foreignpolicy.com/program. Be sure to include your name and organization with your question. Again, the URL is foreignpolicy.com/program. To those joining us online, please submit your question using the box on your screen. Please take your seats. The program is about to begin. Distinguished guests, the program is about to begin. Please take your seats. Distinguished guests, please take your seats. Foreign Policy's Global Health Forum programming is about to begin. We will begin our afternoon program with Dr. Seth Berkley of Gavi. Please take your seats. The program is about to begin. For a conversation on what we have learned about vaccines in pandemics, please welcome Dr. Seth Berkley, CEO of Gavi, the Vaccine Alliance, and Foreign Policy's Dr. Maisha Alam.
Hello, Dr. Berkley. How are you today?
I'm fine, Maisha. Nice to see you.
Nice to see you too. One of the wonderful things about hosting a hybrid event such as this is that we're able to have distinguished speakers here in Washington, D.C. in person with us, and also luminaries like yourself joining us from the other side of the world. So again, thank you so much for making the time, and I know it's late where you are, so we really appreciate it. You know, we've just come off the first part of our program with an extensive discussion on lessons learned from the COVID-19 pandemic, and vaccines are obviously a major part of that. From your vantage point as the CEO of Gavi, what is your biggest takeaway from the COVID-19 pandemic about the effective and equitable deployment and development of vaccines worldwide?
Well, first of all, I just having heard Peter make the point we're only safe unless we're all safe is absolutely right. It's true for vaccines. And he also made the point that the systems you build inter-pandemic are the ones that are going to be used to deliver during a pandemic. So I agree with both of those. But if I go directly back to your question, I mean, the science was extraordinary. You know, we ended up with a large number of vaccines within the first 327 days after the genome was sequenced and published. And for the first time, the first doses that COVAX was able to deliver were 39 days after the first injection in a high-income country. And we were off to try to move towards a more equitable distribution of vaccines for this pandemic. And, you know, we ended up with lots of problems. Vaccine nationalism, we ended up with problems with export bans, we ended up supply challenges. And I think, you know, for me, the critical issue here is, you know, do we believe that we're only safe unless everybody's safe? Certainly after Delta occurred in India, I think people realized, because, you know, it happened, people looked at horror, and then, of course, they saw those strains circulating around the world in a terrible wave, similar with Omicron. And so I think the challenge is getting the world to understand that in a pandemic, yes, you have to take care of your own countries, but at the same time, you also have to make sure that you're providing vaccines in all parts of the world as quickly as you can. And that's some of the stuff that we have to be working on going forward.
You know, there's so much to unpack there, and let me pick up on one particular theme you highlighted, which is even when there's rapid development and even distribution of vaccines, it doesn't mean that it turns into shots in arms, right? People have to be willing to take the vaccine. And disinformation and misinformation about vaccines is a major issue around the globe. How has Gavi dealt with vaccine hesitancy over the years? And what is your advice to public health experts and other stakeholders on how to correct the record on the efficacy of vaccines?
Well, before we get into vaccine hesitancy, which is an important issue, let's talk a little bit about getting vaccines into arms, because the first part of this was really about making sure there was supply of vaccines equitably. The challenge, for example, today, we have 47% of populations in the lowest 92 lower income countries. That's called the advanced market commitment in our language. 47% of those populations have been vaccinated with 2 doses, and that compares to around 61% globally. So we're not quite at parity, but we're getting there. The challenge is there are countries with poor health systems, and if you look at those in January, there were 34 countries with less than 10% coverage. Today, that's down to 16, but 14 of those 16 countries are fragile. So we need to focus our effort there and work on strengthening those health systems, but not just for COVID vaccines, for routine vaccines, for other health interventions as well. So important to get that turning vaccines into vaccinations. But to get to your question, initially, it was not really a challenge with hesitancy. There was an enormous desire for vaccines in most countries. But one of the challenges we've had with this particular pandemic has been the misinformation in wealthy countries. And that has been a challenge because today we're all connected in one internet, one ecosystem of information. And so when you start having that misinformation, some of which was intentional, spread around the world, it does give pause to people. Traditionally, developing countries actually have less vaccine hesitancy than wealthy countries. The wealthy countries don't remember these diseases, and so they can take them for granted, whereas in the developing world, you see people still sick, still dying, and so we tend to have less problems in developing countries. But with this epidemic, it has been different.
Something that you said just now made me think about the fact that even when a supply is available and it can be distributed, there are enormous challenges in fragile, conflict-affected countries in terms of being able to do that safely, even when there's enormous demand. And so as we think ahead to the next possible viral outbreak, whatever that is, what have you learned from co-creating and leading COVAX about the models of partnership across various sectors that are needed to deal with complex global health crises in especially challenging settings?
Well, first of all, even though the main intervention here was vaccines, and we've certainly seen that globally, as you've heard from many other speakers, you can't work in a global pandemic unless you don't have PPE. You can't understand where the disease is going if you're not doing testing. And obviously, if you have drugs that are available, which came later than vaccines in this case, making those available so you have multiple different interventions are going to be critical. So I think we've learned about the importance of that multi-sector response. I think the other challenge, though, is how you get the health workforce focused and ready to go. And there's been lots of good examples of countries, including some of the poorest, able to show dramatic scale up in vaccination campaigns, using their traditional health workers, using sometimes the military, using police forces, using volunteers. And I think what's important is to learn from each other and try to move forward in as quick a way as we can. Now, the one unusual thing here that we hadn't had experience with before is traditionally vaccines have been used either in just wide age campaigns or in children or in adolescents in the case of cervical cancer HPV vaccines. In this case, we wanted to vaccinate the elderly, the high-risk populations, and of course health workers. And this was an important challenge for many countries because they didn't have systems to reach them. And so one of the things we have to think about is, should we start having a much more active program to look at the full life course of vaccines? After all, populations are aging, vaccines can make a real difference in older populations, and this is something that ought to be explored going forward, and working with other agencies like Peter Sands and the Global Fund, for example, in reaching HIV populations who, of course, may be at increased risk for disease as well.
Again, so much to pick up on, and I'm so excited we can have this conversation. I just want to remind our audience, both here in person as well as virtually, that please do feel free to submit questions, and I'll certainly try my best to incorporate some of those into this conversation. Let's talk a little bit more about COVAX, this incredible global initiative. I'd love to hear from you as a co-creator and leader of it. What do you think has worked well? What do you think has maybe not worked as well or could have worked better? And what does the future of COVAX look like?
So I think the important thing about COVAX is it was the largest global rollout of vaccines in history. And we tried to go as wide as we could because the efficiency of providing vaccines, of course, in a time when you're trying to reach high-risk groups globally, is to try to get them globally. So we built a very large portfolio, currently at 12 vaccines, and we so far have been able to deliver more than 1.5 billion doses to 146 countries. So, this has been a big scale up and movement of vaccines. Of course, we did have challenges, as I mentioned before, due to some of the vaccine nationalism, some of the export bans that existed, some of the other prioritization of countries ahead of lower income countries. And one of the things, of course, we learned, and I think is an important lesson, is that the distribution of vaccine manufacturing could have been better. Africa struggled particularly because they only have one current WHO pre-qualified vaccine manufacturer, which is not producing very large volumes. And so there is now an active push to try to build a larger number of vaccine manufacturing facilities so that one can be ready for the next pandemic going forward. We also worked on trying to create a system for providing doses in humanitarian settings, and that has not moved as quickly as we'd like. For the countries that have used it, it's been very useful, but trying to work through the system of indemnification and liability for humanitarian actors and trying to work through some of the difficult logistical challenges of how you get vaccines into places where you don't have a state, you can't work through governments, is also been a challenge. So I think there are many, many positive lessons and many lessons we can build on going forward. And I think for us, the critical issue is, as Peter said, it is evolutionarily certain we will see more pandemics, and the challenge is only going to be, are we better prepared for them? Certainly the science side, we are. I mean, and when I was asked at the beginning how long it was going to take to have a vaccine, the previous record was 4 years. And I said, well, maybe we can accelerate it to something like 2 years. And instead, it was 327 days. Extraordinary. But we have to make sure that we also have in place the systems to deliver those vaccines and the scale up in manufacturing, which was impressive.
Something that you said that I think is really important to underscore, there's a lot of positive as well as challenging lessons learned. Some of that relates to the development and deployment of vaccines, but some of it also just has to do with understanding what healthcare looks like in really challenging humanitarian settings. And you cited the example of the humanitarian buffer, which hasn't worked maybe as well as we would like in terms of making sure that populations where they cannot rely on a government to provide them, that the international community is able to step in. And you also talked about diversifying the production of vaccines in different parts of the globe. Let me ask you something that's related but distinct. And this is actually a question that's come in from Linda Barnhart, who is with APCO Worldwide here in Washington, D.C. And she asks, what role will global markets play in scaling up and democratizing vaccine R&D, research and development, in the future?
Well, it's an interesting question because the truth is vaccines are quite complex to manufacture and they have a very specialized supply chain. If I want to simplify it, when you make a vaccine, it's like making a living thing. And so you can't just do a chemical test to see if it's pure. You have to be able to bridge back to the original studies. And so most of the process of developing vaccines are the analytics, are the different way to measure this, and so it's quite complex. So you don't want to have thousands of vaccine manufacturers. What you want is a relatively small number. When Gavi started, there were 5 manufacturers we bought from. 4 of the 5 were in wealthy countries. Today, we buy from 18 manufacturers, of which the vast majority are in developing countries. So one wants to expand that number to make sure they're across the world, but not to the point where you end up in a system where the vaccines will be very expensive or not sustainable. And so as new vaccine manufacturing steps up, the critical issue is going to be to create a sustainable vaccine manufacturing facility, providing vaccines that are used every day in routine vaccines so that you can keep the facility going. Maybe also regional vaccines that are important to a region. And then, of course, you want some excess capacity. So when there is another pandemic, you can flip into that, that capacity. And so this is it's not a short-term project, it's a medium to a long-term project, but something that the world needs to do given the inevitability of having more outbreaks.
Building on that, we have another audience question, this time from Kanika at the Center for Global Health Science and Security at Georgetown University, also here in Washington, D.C. And Kanika's question is specifically about the TRIPS waiver. Now, obviously, there's been a lot of debate and discussion and controversy on that. So let me ask you this. At this stage in the COVID-19 pandemic, what are your thoughts on TRIPS and how we can, again, learn from what's happened this time around for that next global health crisis?
Well, I think one of the challenges is that we have to look at what is needed for each challenge. And if you go back to HIV, there is no question that patent issues played a very important role in the small molecules that were critical for being able to treat HIV. And as you know, that led to a lot of very powerful activism, a very strong generic industry, and large-scale availability of those drugs. For vaccines, IP is much less of an issue. The critical issue, for the reasons we just talked about, are that you have know-how transferred. So once you've gone through all the processes and have scaled up a vaccine, there are thousands and thousands of pages of procedures and metrics. It's not that they can't be reproduced, but if they're reproduced from scratch, it takes years of work. And so what you want is an active partnership, and we saw that happen. For example, we did 2 technology transfers, one with AstraZeneca, one with Novavax, to the Serum Institute of India, and they were able to produce vaccines in record times and the volumes of a couple of billion doses because they had the know-how. Is there some intellectual property in there? Absolutely. But Moderna had said, we're not going to protect our intellectual property, and therefore, people are free to use it. But without the know-how, it really doesn't serve a function. So I'm not sure that this battle, which has gone on and I know is very emotional, ultimately is going to lead to more COVID-19 vaccines. I think the critical issue is to put incentives in place, build the facilities that can produce the vaccines, and put incentives in place for companies to work with those manufacturing facilities to get those vaccines out as quickly as possible. And we've seen a lot of that happen during this outbreak. I mean, after all, we went from the world produced about 3.5 billion doses of vaccine a year. On a really bad flu year, maybe it was 5 billion. This year, that volume was still there. We still had those vaccines for routine immunization, and industry scaled up to an additional 12 billion doses. It was a real all hands on deck, an extraordinary effort.
I appreciate you making the distinction between IP issues and certainly patent waivers, which are one concern, but technology transfer, which is another, and those are not interchangeable and both are necessary. And Gavi, of course, works on all kinds of vaccinations, and COVID-19, yes, is the current, perhaps, biggest challenge, but you mentioned at the outset of our conversation the importance of routine vaccinations. So we have a question from Dr. Nida Ali with the Task Force for Global Health in Atlanta. And Dr. Ali asks, can you elaborate on the importance of routine immunization structures co-funded by Gavi used during the COVAX rollout?
Well, first of all, let's talk about those vaccines. So it's critical to make sure that vaccination doesn't reduce. And so initially there was a 30 or 40% reduction in early 2020 as there was lockdown around the world. Luckily, the resilient systems came back, and our estimates are that about 4% of children are now being missed. Now, of course, like Peter said for HIV, this is many years of fighting to get those children covered. And one of the important issues is to make sure we get that coverage back up as soon as possible, because otherwise we risk concurrent epidemics. And by the way, there were 3 Ebola epidemics during this period. We're now seeing 22 active measles outbreaks, cholera outbreaks, and others. So we need to make sure that we continue to work on the routine vaccine side. Otherwise, we're going to overwhelm health systems. But to your question, we believe that you need to reach every child. And prior to COVID, vaccines are the most widely distributed intervention. Routine immunization reaches about 90 to 91% of families. And so that last 9%, the so-called zero dose, represents people who 2/3 are below the poverty line, and also their half of the childhood mortality under 5 is occurring in those communities. So bringing those into the immunization system is great value for money, anti-poverty, and of course, brings in those communities, which is where outbreaks can occur, like the 2015 Ebola outbreak that occurred in a place where there was no health system actively engaged there.
Over the course of our conversation, you have reiterated the point that it's only a matter of time before the next major global outbreak of a virus takes place. And obviously, monkeypox has been at the forefront of media coverage recently. So let me ask you this to close off our conversation. Is this an overreaction reflective of COVID? In your estimation as the head of Gavi, what is the level of risk for a global monkeypox outbreak? What should we know going forward?
Well, of course, monkeypox is not an easily airborne transmitted. It requires close contact, and so it's probably less likely to be to go to large pandemic efforts. But I must say, we were all nervous at the beginning because we couldn't figure out what the transmission pattern was. Now there seems to be some evidence of how that's being transmitted, and common public health efforts can get control of that, although vaccines work, and there are also antivirals that work for this organism. But one of the things this reminds us of is that new agents will appear all the time. There was a recent study that suggested by 2070, there will be 4,000 new crosses from animal into people of viruses due to the changes in the climate and people's interactions with those communities. So the important point here is we have to be prepared going forward.
Wow, that point about climate change and health is so important. And I know we've barely just scratched the surface, but we're out of time. Thank you so much for joining us, and to our audience for questions. Be well, Dr. Berkley, and thank you again.
Thank you.
To discuss ensuring population immunity against influenza post-COVID, please welcome Dave Ross, Vice President of North American Commercial Operations for Seqirus, Dr. Andy Pecos, Professor and Vice Chair of the W. Harry Feinstein Department of Molecular Microbiology and Immunology at Johns Hopkins University's Bloomberg School of Public Health, Dr. Richard Mejigo, Director of the COVID-19 Vaccine Delivery Coordination and Integration for Gavi, the Vaccine Alliance, and the founder of Good Trouble Productions, Rena Nainen.
Hi, everybody. Welcome. So great to be here in person. I know Foreign Policy has done a great job of bringing everyone together this morning. I am grateful to have this panel today because we're going to be looking a little bit at emergency health issues, flu being one of them. Our next few panels will take a look at that. And we're taking a look also at what we're seeing, these indicators right now in the Southern Hemisphere showing the increase of flu very early on, and also looking at the past year, how the flu vaccine has not been administered or accepted by as widely as it has been in years before COVID. So Dave, I want to actually start with you. What do you believe we've learned from COVID that can be applied strategically to what we're seeing with the flu season?
I think there are two things that I'd highlight. One is the public discussion around COVID manufacturing technology. That really surprised me, that when the COVID vaccine started to be discussed, the general public really engaged in the discussion around the different technology platforms and the benefits, pros and cons of those different technology platforms. And when I think about flu, I think that type of learning is really important, because in places like the United States, there's more than one technology platform out there. You have cell manufacturing, you have egg manufacturing, there's use of adjuvant technologies. And I think engaging in those types of discussions about the pros and cons of those different types of technologies, I think will engage the public discussion on flu protection in a way that we've never really discussed it with the public.
I've got a confession to make, and I know this is probably not the right forum to be making this in front of all of you experts, but Andy, I would never get a flu vaccine. In fact, one season, my mother-in-law was so, I know. My mother-in-law took me to Target because she knew I would get a $5 coupon, and that would be enough reason for me to go get the flu vaccine. How are you combating, because we've seen a decline in people getting the flu because they've been at home with COVID, maybe their kids are back at home, they feel like they don't need it. Why should I get that vaccine?
Well, I think it starts with safety. So we know the flu vaccines are an incredibly safe vaccine. And then it goes to the issue of it's a safe way to get the immunity that's going to first and foremost protect you from severe disease. And then it's also going to, limit your case numbers, limit transmission. And all of that factors into protecting primarily those most vulnerable populations, which for influenza are the over 65 population, and also the population that's under, let's say, the age of 5. And so the flu vaccine is the safe way to move towards immunity. People talk about the flu vaccine maybe not being as effective as it could be, but at the end of the day, it does do the job, which is it provides you with immunity, it limits the severe disease, and then if you get an infection on top of that, you're more safe in terms of the ill effects of the infection, and you then benefit from a broader immunity that the infection gives you. A lot of parallels to what we're hearing now with COVID-19 and the vaccination and infection procedures that are going on now.
Are you concerned with how politicized the COVID vaccine was at one point? The fact that people now look at it and say 98% efficacy rate, and you look at the flu, and suddenly people are like, 50, maybe I don't need that.
Yeah, I think one of the things that's important to understand is the COVID vaccines didn't get worse as time went on. The virus got better. The virus got better at infecting us. It got better at transmitting between people. And what was an initial hurdle became a much higher hurdle for the vaccine to work against. And now we're seeing the COVID vaccines working in a similar way as we see with seasonal influenza. And so there's a great opportunity now going forward to try to link those two things together to provide even greater protection to the population before this upcoming winter season.
Yeah, if I could just add to that, I think there was another key learning with COVID that I think if we don't apply to flu, we miss an opportunity. When the COVID vaccines were launched and first introduced, all the trials showed 95, 97% efficacy. The conversation that evolved over time, there were breakthrough cases, there were duration of protection questions about it, and boosters were needed. But the conversation didn't go towards the effectiveness of the vaccine. It went towards the message about the prevention of serious illness and hopefully mortality. And that's a communication platform that I think very much applies, or could apply or should apply to influenza. Because we immediately talk about the breakthrough cases on influenza, but we neglect to talk about the prevention of the serious cases of influenza that the immunization brings
so you feel
about.
That messaging is equally as important.
It's absolutely more, I believe it's more important, because in the interest of public health, that's what, if you have the wrong conversation, it creates an apathy amongst the general population about the need for immunization. They need to know why they're doing it, and if all they're hearing is a message about the lack of effectiveness, then they're not motivated. There's no call to action. But if you're talking about serious disease and the impact on that, I think it motivates in a different way.
It's interesting to hear you say that, Dave. Richard, I want to turn to you. Among all of your experience, you've also spent over 18 years for the World Health Organization in Africa. You understand the divide of the haves versus the have-nots. I want to ask you, what do you believe when you see that divide, particularly with vaccines? How do we bridge that? How do we make a difference when it comes particularly to flu?
Okay, now thank you very much, and good evening, good afternoon. Thanks for the invitation, for inviting Gabby on this conversation. There are many lessons that we can learn from this pandemic, and particularly to your point, what is the divide that we have even seen during this pandemic to access to the vaccines. In the past, we have seen how it took sometime 2 to 3 decades for vaccines that were available in the north had to be made available in the south. And by the way, this is one of the reasons why even the Gavi, the Vaccine Alliance, was created to try to really bridge that gap and access to the vaccine, particularly for low and middle income countries. And this has been quite very unfortunately acute during the COVID-19 pandemic, where the gap between the rich country and the lower and middle income country has really widened up in terms of accessing the vaccine. And it's beyond even vaccine. We saw the same situation with diagnostics. We saw the same situation with therapeutics. And I believe that it will be important that coming out of this pandemic, I think we need absolutely to learn the lesson that we've gone through in terms of equity and equal access to vaccines and other products, so that we can build a world where everybody can have the rights and the access to life-saving tools.
Andy, I want to ask you a little bit. Do you believe that we could see a double whammy, meaning coronavirus isn't fully over yet, right? Could we be dealing with coronavirus and the flu? Is that a concern of yours as we go into this flu season?
It's not only a concern, but we're starting to see hints of that when you look to the Southern Hemisphere, to Australia, to parts of China right now, that are seeing really large increases in influenza cases at a time when they shouldn't be seeing much influenza. So high numbers of cases earlier than you expect. With influenza, that's a sign that there's not enough immunity in the population to keep the virus away. And that's where I think low vaccination rates, in addition to the lack of spread of the virus over the past couple of years, have really increased the number of people that are susceptible to influenza, and that really sets us up for a situation where we'll have people who are susceptible to COVID and to influenza. The severe disease is going to target those same populations, the elderly, the young, and certainly those two things can come together in the winter season. And like I said, we're seeing those signs right now in the Southern Hemisphere.
What concerns you the most, Dave, as we're talking about messaging and getting the word out and trying to get those people who in the past year chose not to get the vaccine and probably might feel, I might not need it this season?
Yeah, I think it's a really important point, and we kind of dodged a bullet 2 years in a row. You know, when the pandemic first happened, there was no COVID vaccine. There was a real big focus on flu immunization because we knew that, you know, most health systems are built around the capacity to deal with the peak of influenza season during the winter. And if the beds were consumed with COVID patients and there was an influx of influenza, that could really put a tremendous burden on the hospital system. Thankfully, for all the mitigation that was put in place, influenza had been kind of held back for 1 and then 2 years. But now that we're seeing this in the Southern Hemisphere, I think it's really important that we're strong about setting objectives for influenza immunization and driving towards them, because it's not just a nice to have. In a lot of ways, influenza immunization is important to prevent the disease and the severity of it for its own sake. But it's also a tool in the COVID battle, because if influenza patients and COVID patients have to compete for hospital beds, that's something that nobody wants.
No, you're absolutely right. I want to ask you, Dave, about this, what we're seeing, these indicators early in the Southern Hemisphere. I remember when I would take my kids to get, the pediatrician would say, get the vaccine in October. That means it'll cover you through the season. Should we be getting the flu vaccine earlier? Is there a concern that it'll peak here and follow that same trend?
Well, it's interesting because what's happening in the Southern Hemisphere is, I don't think there was ever a question, will it return and will there be a severe season? It's just a matter of timing, right? But what was really surprising in the Southern Hemisphere is that the disease started to peak about 2.5 months earlier than a normal flu season. And that change in pattern was unpredicted and it's unusual. Now,
do we know why?
There's only speculation at this point. So the question is, does that Southern Hemisphere disease come into Northern Hemisphere? And if it does it come sooner? Now, typically flu will peak in February and March. So if we see a pattern of it coming earlier in the same way as in the Southern Hemisphere, you're talking about October and November.
Yeah.
So that immunization that normally happens in September, October, and November is actually well timed with
so it's still
that.
okay, is what you're
still,
saying. When
yes.
you would typically get your flu vaccine, carry on.
Yes, absolutely.
I want to ask Richard, I want to turn to you and ask you a little bit about distribution. We know supply chains matter, increasingly apparent under COVID. What has Gavi learned about the situation of getting these vaccines out?
Even before the current pandemic, I think at Gavi we have put, and distribution is one of the really the nerves of any immunization system that needs to deliver vaccine up to the last mile. So we have invested heavily in the past in making sure that country can have the cold chain, but also the supply system that will help to deliver these vaccines up to the last mile. But what we went through this pandemic showed us that we were dealing with a new type of product that were actually requiring a completely different type of equipment that was not used by many countries. The fact that not only the new equipment, but the need to train people how to deploy those distribute vaccines up to the last mile, I think was quite a challenge. So I believe that all the lessons that we have accumulated through this pandemic and the lesson that we have learned through massive investment that we have done in the country actually are going to benefit the routine immunization system, which should and is the bottlenecks actually of immunization program in the country. And some of the vulnerabilities that we saw during this pandemic were definitely linked to how not very well prepared the country were. And I believe that the investment, the new technologies, the processes that have been put in place are going to put us in a situation where rolling out the ambitious Gavi 5.0, for instance, agenda where we want to tackle the zero-dose children to reach all the community that are not served by the health system will help us really to expand the reach and equitably distribute the vaccine in places where we were actually struggling to reach in the past.
It's fascinating to hear the plan that you have outlined there. I want to turn now, we've got some questions coming in online. This one's from Lori Pilcher in Atlanta with HHS. She's asking, Dave, I'm going to toss this to you. Prior to COVID-19, planning for a pandemic primarily focused on influenza. We have therapeutics, tests, and vaccines on hand for the next influenza pandemic, some of which were used for H1N1. Could we have used the prior outbreaks of coronavirus, SARS for instance, to develop base antidotes and vaccines that could have been on hand and used for COVID-19?
You know, I think the discussion around COVID and ultimately how quickly we brought about a vaccine with mRNA actually shows that there was research being done. The platform was there. If that was a new platform that was developed, it would have never come to at that point, it would have never come to the market in that year's time. So the availability of the COVID vaccine was the mobilization, but it was the mobilization around existing technology that was being researched already. So I think it really emphasizes the importance of having different technologies in the works and it being pathogen agnostic, because you're right, most of the conversation has been around influenza pandemic, and in the US and in some other developing countries, there's a lot of pandemic preparedness, but it was all around flu. I think the COVID situation has no doubt changed the perspective from that singular focus on flu as the basis for a pandemic, and now the desires for pathogen agnostic technologies. And I think it also, to the doctor's comment, the distribution system didn't conceive of a cold chain that required a frozen product, and that caused some hiccups in the process. In the US, the seasonal influenza program, in a lot of ways, is a dry run for a pandemic every year.
Wow, I never looked at that.
There's 170 million people every year that in a 4-month period get immunized in a system that provides access in tens of thousands of locations. It's necessary for flu protection, but it was always conceived of by health authorities as also a dry run for the pandemic. So I think that this is a very important pivot point for pandemic preparedness.
And
one more thing to add to that too. I think my laboratory was part of the response to the first SARS-CoV pandemic or epidemic, and while we hadn't done much work on corona, we had the knowledge base. And when in January of 2020, I went and found our old lab notebooks, we found our old procedures and protocols, and we got things up and ready so that when we saw our first case at Johns Hopkins, we immediately were able to take samples into the laboratory. The first 3 cases at Johns Hopkins, we had viruses that we grew out of the patient samples and were able to distribute those for work. So there is it's an example of how we can invest in those resources and eventually have that base of expertise that we can draw on. You never know exactly which the virus is going to emerge. But again, if you have these agnostic technologies, if you have the experience of working with lots of different viruses, you increase the capabilities that you have and the speed in which you can implement those capabilities.
Andy, I want to ask you also about the COVID pandemic, how you think this has affected our preparation for the next flu pandemic. Correct me if I'm wrong, I did some research on this. The swine flu was 2009. Previous one was 1968. Could we predict when the next big flu pandemic could be emerging?
We can't, but as Richard also talked about, there is an approach that you have in terms of what you need to do for a pandemic. Everything we had to do for the COVID-19 pandemic, from diagnosing cases to identifying treatment strategies to vaccine development, the same pipeline, the same protocol is true for influenza. And it's true for any of a number of different viruses that are out there that pose pandemic potential. So we really have to focus on getting that broad expertise on and not losing those capabilities in between outbreaks. My example with SARS-CoV-1 is a good one. We hadn't worked with coronaviruses for 10, 15 years before this. It would have been great if we had some experience on the ground and I didn't have to train people from scratch to be able to launch into this. So we have to find a way to keep these capabilities that were put in place for COVID-19, apply them to other infectious diseases, apply them to other situations, and maintain that capacity so that we are better prepared going forward.
Richard, I want to turn to you with your extensive international experience in dealing in global health. What do you feel you've personally learned over the past few years, and what would your advice be to future White House administrations, a current one perhaps, because we've discovered just how interconnected we all are at this point, no matter what country you come from?
No, absolutely. Maybe before that, let me say a few words to the previous conversation. When we went through in 2009 the swine flu pandemic, I think some of the basic capacity that was put in place at that time, the first PCR machines that were distributed in the country, a surveillance system that were at least strengthened, tend to prove in the long run that it was useful for COVID-19 also pandemic. But I believe that we didn't learn too much about that in terms of really prevention and preparedness for future pandemic. And we could currently see that many countries that when we looked at the Global Health Security Index, the countries that score quite very high, including the United States, many of the European countries actually tend to have been very much overwhelmed by the current pandemic. So moving forward, I believe that we have learned quite many things that we believe we can carry forward. Number one, I think the need for a very strong surveillance system that can really help to have the early detection, confirmation, but also prevention and treatment of cases. I think it is quite very important. And this is something that has been lacking in many countries. Secondly, and we tend to forget that the human face of the response to the pandemic, the training of healthcare workers, the training of laboratory people working in the labs, the training of even community healthcare workers to make sure that they can support and expand the services up to the last mile, I think is quite very critical. Third, I think we have neglected one thing, which is how do we communicate? How do we generate a lasting demand? And this is also relevant to flu, influenza pandemic preparedness. We have seen in many countries in the southern hemisphere that have not yet even introduced the vaccine. When we looked at the latest WHO data, is showing that close to 42% of the countries across the globe, particularly those who are in low middle income, have not even an influenza program in place. So I think these are the fundamental that needs to be put in place so that we can build on those strong system to project for the future. Because again, nobody can be safe if we are not all be prepared and vaccinated and to respond to these type of global threats.
Such a great point. Nobody is safe if we don't protect everyone else around us. Andy, I've got one more question that I'd like to toss your way. You know, Richard made me think about sort of the different things that we know that are just basic that can be done. But are we utilizing our capacity on hand?
I think that's another place where we can do a much, much better job. We've seen with COVID-19 the capacity to make more vaccines, to distribute vaccines, to get vaccines in people's arms. And I think that capability can be applied to a number of other infectious diseases, another number of other vaccines. It's understanding that process, having the tools in place to do it effectively. We should maybe even throw now antivirals into the discussion here too, because that forms yet another part of a pipeline that protects us from severe disease. But to use antivirals effectively, you have to have diagnostics. You have to be able to do testing in a rapid manner. You have to be able to do accurate testing. All these things, there's capacity for. Implementing it is another really important challenge that we even fail, I think, here in the US to do that effectively in influenza season. So there's lots of work to be done. Implementation, though, I think is something that is also not really emphasized a lot that would really make a big impact in terms of our ability to minimize disease severity.
It's really great. Dave, I'll give you the last word, actually. As we're looking sort of at this flu season, there's so many trends that we're watching that could be very different this go-round. What worries you the most, and what gives you the most hope?
Yeah, I think what worries me is that there's a false choice between having to choose between immunizing for COVID and immunizing for flu. I think this past year there were 25 million less people in the US that got immunized against flu. Now it turns out that there was low flu activity, so we were okay there, but it's a gamble. And if disease comes back and we have 25 million less people immunized, and it's a severe season, that could be a real significant consequence for those individuals, but also the health system. So it has a knock-on effect. So that's what keeps me up at night. What gives me hope is that even though there's plenty of work to be done on the capacity side, most people don't realize it, but last year during the traditional flu season, there were over 200, in the US, just as an example, there were 200 million COVID shots that were given and 150 million flu shots that were given. That was 350 million doses of vaccine administered in about a 4-month period. And if you had that conversation before COVID, people would say, you're crazy, you can't get over 180 million people immunized in the flu season. And we just showed that we got 350 million shots administered. So the hope I have is that there's been a tremendous infrastructure that's been built around COVID, and we've got to take advantage of that.
It's fascinating. You guys may realize how much messaging can really affect implementation as well. Dave, Andy, and Richard, I want to thank you all three for joining us.
Thank you.
Joining Rena for a conversation on the rise of the superbugs and tackling antimicrobial resistance, please welcome Kevin Outerson, Executive Director of CarbX, Lori M. Riley, Chief Operating Officer of the Pharmaceutical Research and Manufacturers of America, and Dr. Ralph Sedbrook, Interim Secretariat Lead at the Global AMR R&D Hub.
Welcome. Thank you guys very much for joining us. We're taking a look at superbugs, not something new, but something incredibly important and on the rise. Lori, I want to start with you because you have had extensive experience on Capitol Hill. You've talked to both Republicans and Democrats. Do you think Capitol Hill is aware of the dangers that we're facing with these superbugs?
That's a great question. I think, unfortunately, we still have some education to do. It is thankfully changing, thanks to a group of bicameral, bipartisan members that are looking at legislation that would hopefully provide some of the necessary incentives that would be needed to bring more antibiotics. I think COVID, in many ways, has put a brighter spotlight on this issue. In part because we saw, unfortunately, a number of patients that ended up with secondary infections as a result of COVID, many of which were resistant to antibiotics that currently exist. And so, unfortunately, we're in a worse position today than we were before COVID, which I think has shown many people that there's more to be done here. Unfortunately, unlike COVID, where I think I heard Dave on the last panel mention that there are platform technologies that companies were able to put into use and rapidly get vaccines to market. We don't have those platforms readily available for antibiotics. And currently, there are barriers to getting more antibiotics on the market. One, because it's really risky to bring an antibiotic to market. It's hard. It takes on average from 10 to 20 years to get an antibiotic to market. And unfortunately, most of them that enter clinical trials fail. About 1 in 15 get out on the other side. And then if you are successful, if you're one of those that are successful, there's not really a market because the incentive is not to use them because we don't want more resistance. So we have to deal with both of those issues. We've got to deal with the incentive side, making it able for companies to bring these investments. And then we also have to deal with the demand side and making sure that there's a market there. And again, thankfully, there is some legislation to do that. We'd like to see that get over the finish line. And I know Kevin and others have spent a lot of time working on that, but I'm glad that we're now having the conversation, but the urgency is there. We have, I think 2019, over 1 million people died from resistance to antibiotics. That's more than HIV, AIDS, and malaria. And those numbers, I think, are surprising to people and to me just demonstrate the urgency by which we need to act.
Kevin, I want to turn to you on Lori's point about people understand there's some momentum here. How do you feel COVID has sort of affected our global outlook of antimicrobial resistance, or as we refer to AMR?
I think bacteria, these superbug bacteria, are remarkably bipartisan. They'll kill Republicans, Democrats, Independents. They don't care what your passport looks like, right? And that is a lesson from COVID. And so now we have the opportunity to prevent something that we know is coming. There's no doubt what's happening with bacterial evolution, no doubt. The question is when, and whether we can look around the world and see the data that you just talked about. This amazing study in The Lancet published earlier this year. 1.27 million people are dying now from drug-resistant bacteria. And so this is a global health issue of the first tier that we need to recognize. We have amazing global institutions for other infectious diseases. They've done remarkable things to bend the curve towards zero. We want 0 deaths from tuberculosis, AIDS, HIV, and malaria. 0, right? But they've done some of that work, and now we're recognizing that for bacteria too, we need to get at this job.
You know, they're looking at AMRs as the #1 cause of death potentially by 2050. That number was staggering. Correct me if I'm wrong on that. But I'm just curious about what are the policy regulations that you would like to see implemented at this point?
Well, it was already mentioned, we need to rethink the way that we pay for antibiotics. So if a building is on fire, that's not the moment that we decide, let's think about designing a fire truck or training firefighters. You know, we do that years in advance. We have to have these things ready. And for antibiotics, you know, it takes 10 to 15 years and a lot of money and time. There's a lot of risk. And when they get to market, for excellent reasons, the doctors want to use the older drugs first. And this is great public health. And so we won't want to save them for the rainy day, right? That's great news for everybody except for the company that just invested 10 or 15 years and all of their money in bringing this drug to market. They've only got a few years for their patent, and they need to sell now. And so we need to start buying antibiotics like we buy fire protection, or, you know, or a subscription like we buy Netflix, paying for the accessibility of something, not the actual necessary use, paying for the value to society, not the volume sold. And this is what's done in the Pasteur Act in the US being proposed. It's bipartisan and bicameral. It's what's been implemented already in the United Kingdom and England. And
why do you have such hope in this legislation?
Well, this morning, you know, the G7 released a communique, and you know, it's a long communique. There's a lot in there about the war in Ukraine and climate change and everything else, but there's a paragraph in there about antibiotic-resistant bacteria, and they say that you know, that we need pull incentives. We need that's policy code word for we need new ways to pay for the antibiotics. Instead of paying for them based on volume, let's pay based on the social value. That's what Pasteur Act would do. That's what the United Kingdom subscription model does. And the G7 wants to do this.
I want to turn to Ralph, who's joining us virtually. Ralph, I want to get you into this conversation. What do you believe? You know, Kevin gave us a good insight as to the global policymakers and what they're thinking about, but what do you believe really are the major takeaways that the public health community should be focusing on when it comes to AMRs?
So one thing we really learned from COVID is preparedness. So that is now key buzzword, which is everyone understands. And I think the ongoing pandemic is already there. The antimicrobial resistance is an ongoing pandemic. It's not a silent pandemic anymore. So, and we have really to understand that if we do not have functioning antibiotics, we do not have modern medicine anymore. We can't do chemotherapy, we can't do hip replacements, we can't do cesarean sections. All these routine surgeries are not possible without functioning antibiotics. And like Kevin already said, and now we need 10 to 15 years to develop one antibiotic, and we need probably 10 to 15 new antibiotics within the next 10 years. That means we have to really fill the clinical pipeline for drug development, so that this is a push incentives. And on the other hand, we need something when the drugs are developed that companies get reimbursed for it, but this is, on the other hand, the pull incentives. So we need really both in the moment. And we learned a lot from COVID, so that the awareness is important, and also research is important. To be prepared means that we have to invest in research a lot. Like it was said in the previous sessions, that this platform were in place because we invested in research for a long time, even in basic research. So both comes together, this push funding in basic research and preclinical development, and we need a new pull incentive. And as you might know, we from the Global AMR R&D Hub were really requested by the finance ministers last year to submit a report together with the WHO with recommendations what we suggest in this area of drug development. And we really suggested, next to supporting CAPX and GARP and Secure, that we urge for a new pull incentives. And the G7 is really prepared for it. And in their health ministers' communication from last month, they really said already agreed that they commit that the time to act is now. But now we need really some action. So the US, I think, is quite good on their way with the Pasteur Act. England has this now, his pull incentives. Sweden has a smaller one, is working, but also the other countries in the G7, but all in the G20, have to agree on one pull incentive or a set of pull incentives.
I want to ask a little bit about partnerships in just a moment, but I just want to remind everyone tuning in, whether you are here or attending virtually. If you're attending virtually, feel free to ask any of our experts, submit a question. You can do that with the Ask a Question button. And if you're here with us live, you can do that at foreignpolicy.com/programs. Lori, I want to pivot off of what Ralph was talking about a little bit there and ask you about partnerships. Mm-hmm. We know in the medical world, partnerships matter, both private and public sector. How do you see an ecosystem being created that would work and allow, this buildup to stop?
Absolutely. I think, COVID, that was another great lesson from COVID, is that no one can do this alone, that we absolutely need partnerships with academia, with healthcare professionals, with government, with industry to accomplish things like, in addressing COVID. The same is true with AMR. I think the industry is currently working, and 2 years ago launched something called the AMR Action Fund, also a public-private partnership in conjunction with pharmaceutical companies, with the World Health Organization, the Wellcome Trust, the European Investment Bank. And the goal of that is a $1 billion commitment over the next decade to invest with a goal of bringing 2 to 4 antibiotics to market by 2030. Now that's a steep goal, yes. I would argue, when you look at the past in terms of what has happened and unfortunately not having the kind of success that we want. But that's just a piece of it. I don't think that alone solves the problem, which is why bills like the Pasteur Act are so important, because you've heard everyone here talk about the push and the pull incentives. It's great to fund the research and development, but if at the end of that, there is not a market for them, if you don't change to something like a subscription model like the Pasteur Act would have, then it's hard to sustain that investment. And I think what we've learned is that we don't need just 2 to 4 new antibiotics, we need a pipeline of antibiotics. Because when you look at the numbers, and your 2050 statistic was unfortunately correct, that we could find ourselves at a point in time where routine surgeries, I just had a daughter who had wisdom teeth last week out who needed a course of antibiotics, where things like that present significant risk. It's almost unimaginable when you think about it, but it demonstrates the urgency and I think the absolute imperative of public-private partnerships. We showed with COVID that we can work and we can work in partnership. We absolutely need to do the same here.
Kevin, we've heard Lori talk about this urgency. I don't know that it's translated to the average citizen, that they understand. I mean, this is referred to as the silent pandemic. Mm-hmm. How do you generate that awareness so people are as concerned as they have been about coronavirus as they are with something that will be the #1 cause of death in just a couple of decades?
1.27 million people dying now, but most of those are people that you wouldn't necessarily recognize as dying from, drug-resistant bacteria. Their death certificate will say pneumonia, mm-hmm. or their child, they'll die with sepsis, but no one will even know it by that name in a low-income country. So part of the education difficulty is that this is not a disease that people identify with, in a sense. Cancer has remarkable patient engagement, mm-hmm. walks and ribbons and everything else, and it's not been true historically. In the last few years, the cystic fibrosis community has become very engaged on this issue, partially because we have remarkable new drugs which are extending the life of these people. They're no longer, many of them are not dying in their early 20s. And now the threat is from drug-resistant infections in their lungs. The lungs are working, but the infection is still there. And so Gunnar Esiason, who's a well-known advocate, has CF himself. He says that he's on the last antibiotic that's left. So the new drugs are saving his life, but he could still die from a drug-resistant infection. And so getting those stories out into people's hearts and minds so they understand that this isn't just abstract.
That messaging is important. Dr. Ralph, I've got a question here I want to ask you, piggybacking off of what Kevin was saying here, is what's the role that physicians play in helping control AMRs? They're the ones prescribing the prescriptions, right?
Yeah, yes, of course, and they're doing very often in the wrong way. So therefore, also the COVID helped a little bit to train physicians really, and that there are now more physicians are really have the knowledge at least to distinguish, and that they do not prescribe antibiotics for viral infections, for example, because very often still they prescribe antibiotics for flu, which is can't work. And so we have to do a lot of, let's say, education, not only for the general public, but also for physicians, because a lot of this misuse is really done by uneducated physicians, or in low and middle income countries, even they can buy it over the counter on pharmacies, even without any medical advice. Yeah.
Mm-hmm. It's fascinating to hear you say that. Lori, I want to ask you, is there a way to incentivize the pharmaceutical industry to make them more aware? I see Kevin raising his eyebrow on that. I know it's a crazy question, but I'll let you weigh in, Kevin, after.
Yeah, I think addressing some of these issues is the best incentive to get industry back into the mix. I think for years, unfortunately, the success rate that companies have had in this space has been pretty poor, quite honestly, worse than traditional research and development. We typically say for every one drug entering clinical trial, or for every 10 drugs entering, one will come out successfully. In the antibiotic space, it's 1 in 15, except for the new class. If you're trying to find a new class of antibiotics, it's 1 in 30. Mm-hmm. So the risk is so high. You've had company after company that literally have declared bankruptcy, small biotech companies wanting to get in this space, not being able to be successful. And so part of the goal of the AMR Action Fund was to say, let's have industry, including companies that aren't in and have never been in the antibiotic space, to contribute resources with the goal of identifying some candidate medicines that they think may have a good chance, to fund them, to get them through this valley of death, to hopefully get out the other side. I think if we can create a new mechanism like that to help incentivize, that's step one. But again, unless we deal with the other side of the issue, which is the market side, it's really hard, I think, because quite honestly, if you've gone through a process where you've invested, let's say, $1 billion, you've spent 10 to 15 years to get your product to market, and the goal is to not use the product, right, it's hard to convince people and to risk capital. So you have to deal with both of those issues. And again, I think we're taking steps there, at least on the research and investment side, but we absolutely need to address the market side. Otherwise, it's going to be really, really hard to get companies to do that risk because they've seen all the failures before. Mm-hmm. And this is a public health imperative. I liked the way you said it, that it is a silent pandemic, because I absolutely believe it is, and the time is now to act, because it isn't going to be like COVID where we have a new antibiotic in a year. Mm-hmm. We got extremely lucky based on decades of investment in infrastructure and technology to be able to turn a vaccine and vaccines around as quickly as we could. In the case of COVID, it just is not analogous here. So we need to make these investments now.
Antibiotics, if we started today, it'd be a 5,000-day challenge. Wow. To go from the lab to a new antibiotic. And so I lead CARB-X, $750 million. Thank you to the US government, the German and UK government, the Gates and Wellcome Trust. But without our work, that 5,000 days, we wouldn't have 100 days, or even 327, whatever the number is for the COVID vaccines. we have to invest now to be ready for these things.
So Kevin, what do you believe? I mean, you work on the policy side of this. Yeah. What's the solution here for us to combat this?
Well, I'm an academic, but I also lead CARVAX, and I would completely agree with what you just said. The companies that are taking the risk today are grinding themselves towards bankruptcy. So I looked at the last 9 small public companies that work in antibacterial space. The 9 that succeeded to get to the point in which they got to phase 3 or an approved drug by the FDA. Mm-hmm. So if there's 9 there's 100 behind them that never made it that far, okay? And these 9 had a total of $4.7 billion invested in them by private capital. I didn't even count the government investments, $4.7 billion. And today, the collective worth of all 9 of them is under $650 million. That's the market cap. It's another way of saying that the successful companies their investors are $4.1 billion in the whole.
Wow.
And all of that money that was invested by NIH, $500 million a year in basic research, plus other governments around the world, all of that effort from all these scientists, they're not looking to become billionaires. They're just looking to not go bankrupt. Yeah. These are very inspiring small science teams that need support. We support them at CARVAX to get them to the end of their first human clinical trials. The AMR Action Fund picks up at that moment and will take them through to approval. But unless we change the way that we pay for the antibiotics, it's still a sad story at the end. Here's the success. You want to pop the bottle of champagne, and instead, nobody needs your thing today. So a friend of mine, John Rex, he might be watching, says that imagine if somebody invented the COVID vaccine in 2018, what would the value have been?
Great
Nothing.
Point. What a great point.
Moderna would have gone bankrupt, right?
Yeah.
But at the right time, it's worth a huge amount of money. We need to have these things ready to go on the shelf, proven, effective, preparedness. That's why these BARDA and ASPR support this work, that the largest funder in the world of this preparedness work in antimicrobial resistance.
Yeah, and what we also see is if these SMEs shy away from antibiotic resistance research, we also lose the people who knows how to make antibiotics. And on the other end, we do not get any new talents because students do not go into infectious research if it's not attractive. So the next generation of leaders in the field are also not there. Although we are losing people who are knowing how to do or create antibiotics, and there are no new talents or the future leaders are not there. So we have to make investments attractive in the field, and that's we have to do now, really. So we say in Germany, at least, it's 12 and not 5 to 12. And I also think we do not have a knowledge gap; we have only an implementation gap.
The scientists doing antimicrobial discovery and research work are getting grayer and older and smaller numbers.
So you worry about that?
I worry. He's right. I worry about that. And if we were losing the last person who knew how to speak a language, we would mourn it. Or if the last person who knew how to do calculus, right? We're losing the people who know how to do this, and the new generation is not being replaced because there's so many other exciting fields to go into.
It's fascinating. I hadn't thought of that. Dr. Ralph, I want to get you to weigh in on one more thing. Do you think that COVID has quickened the pace in the rise of AMR, or do you think we've always been on this track?
No, I think COVID has good and bad sides. So the good side was the awareness for infectious research. The bad thing is, if you go to politicians, they have to deal with crisis in the moment. So with the Ukraine and with energy and with COVID. So when I went to the German Parliament, talking to the chair of the health committee, he said, "Yeah, I know all this, but I do not have the money in the moment. If you ask for $500 million a year, that I know it's not much, but it's not there. So we spend the money on other cases. So we have to wait or I have to find the money elsewhere, and that takes too long. So we need really, the G7 committed themselves. Now we have to get the G20 to a kind of commitment, which I can't see in the moment in Indonesia. They are dealing with surveillance only, not with research and development, and also not with pull incentives and innovation. So yeah, I think COVID was not, yeah, so we saw both sides with the corona crisis.
Lori, I want to pick up where Dr. Ralph talked about innovation. Are we seeing enough innovation in this space?
Well, I think we absolutely need more. I mean, I think there's no question, for all the reasons we talked about throughout this panel, is that we're in dire need of more therapies to come on market. And unfortunately, we've seen much more failure than success for all the reasons we've talked about. So we absolutely need more innovation. And I think the way you spur innovation is you provide the right incentives. And this is not unique. I mean, we've had other points in time where there has been an acknowledgement by Congress, for example, where there is not enough innovation. Rare diseases, for example, diseases impacting pediatric populations, where Congress enacted incentives to say, listen, we've got a problem here. And companies, they flock to incentives. And I think that's absolutely what is needed here, is that we don't have the right incentives in place, so we haven't seen the requisite innovation that we need. And if we fix those things, I think we'll have a different paradigm. But we can't wait too long. I think everyone here is in agreement that this is not the case that we can wait till we're at 2040, 2045, where we could be in, it's almost unimaginable where we could be, quite honestly, where people could be dying of routine infections that for years we've taken for granted. And that's what's at risk if we don't get a handle on this.
Kevin, what do you believe the roadmap should be to get a handle on this? What do you believe really could work and make a difference?
Well, we're already doing a lot of things really well. At Carbex, we've looked at 1,100 applications around the world. We've selected 92 companies to fund. We've put more than $400 million out the door. The innovation coming out of university labs, funded a lot of it by people like NIAID, NIH, and their counterparts around the world. Amazing new technology coming, right? What's missing is what you were talking about, is getting it across the finish line so that the company doesn't go bankrupt. Yeah. And so this is a problem we can solve. You know, we've talked about this for more than a decade. I mean, not you and I, but you know, people that nerd out on these issues. Yeah. And there's consensus, really, that the Pasteur Act in the US and subscription model in the G7 is the right way to go to change the way we pay for it. And the cost, I mean, there's not many global collective action problems that we can solve for, you know, $1 billion a year, okay? And this is one that we can solve sustainably forever, you know, in terms of the innovation side with the Pasteur Act. So that's there, you know, the solution is in front of us. I know that, I agree with what you said, Rolf, you know, there's always something that's a bigger problem, right? Ukraine, there'll be something else tomorrow. This will always be lower on the priority list until one day it'll be the hugest thing on the priority list. And then we won't have 5,000 days to wait, right?
Great point.
So in a modest investment, we actually can solve this on a global level, and the consensus is really strong. And I think the price tag is, you know, name another global collective action problem we can solve for that amount of money. There's not one.
Ralph, I want to turn to you because, as Kevin pointed out in the communique from G7, that little paragraph talking about this, I mean, how significant is that? Even if it's a little paragraph, that this was an issue of importance to put out in a communique. President Biden was in the room right now. Talk to you. What would you suggest America does in this movement at this moment?
Sign the Pasteur Act. You can't believe from outside the US, the entire world is looking at you and really waiting for the Pasteur Act, because that would be a really big sign for investors, for pharma industry, but also venture capitalists to invest in AMR, in R&D. So that I can say from Germany, so we are waiting that this it would be really, really big sign to our community. Yeah.
That's great to hear how important that act is. Lori, you mentioned your child getting wisdom teeth pulled out, and I think it's hard to make something like AMR relatable to the average mom or dad at home.
Yeah.
What would you say to that?
That's a great question. I think whether you're a parent or you're caring for a loved one, I lost my mother to ALS, but the reality is she had MRSA. And she lived for 8.5 years, most of that time on a ventilator. And I remember when she lived at home with caregivers, but I remember when she got sent home and the doctor saying, I wouldn't send her home, she's gonna get an infection and likely she's not going to survive the infection at some point. And it was the first time, and I've worked in this industry for 22 years, it was the first time it became real to me that I could lose my mom, not just from ALS, but from some infection that they couldn't treat as a result of being on a ventilator and just being susceptible to more infection. And so I think all of us have experiences, whether it's taking your child for their wisdom teeth, caring for a parent who may be, getting an oncology treatment, an organ transplant. But as Kevin pointed out, when we lose those people, what's on their death certificate is not that they died of MRSA, it's that they succumbed to their illness. And we need to talk about it more. And I think more and more people need to be aware that this is a silent killer, that it exists and more people have it, but we don't talk about it, we don't know about it. And then until it's personal, unfortunately for many of us, we don't think about it. What I worry about is it's gonna get real personal in our lifetime and we won't have done what we could do to deal with it.
Said from somebody on the front lines of all this. Lori, Kevin, and Dr. Ralph, I want to thank you all for raising that red flag on superbugs and why we need to start paying attention. Thank you.
Thank you.
For a conversation on cancer care beyond the pandemic, please welcome Dave Fredrickson, Executive Vice President of the Oncology Business Unit at AstraZeneca, Dr. T. Peter Kingham, Director of the Global Cancer Disparities Initiatives at the Memorial Sloan Kettering Cancer Center, Dr. Gilberto de Lima Lopez Jr., Medical Director for International Programs and Associate Director for Global Oncology at Sylvester Comprehensive Cancer at the University of Miami, and Editor-in-Chief of JCO Global Oncology, and co-founder and CEO of Youthcast Media Group and former USA Today healthcare policy reporter, Jane O'Donnell.
Hi, Dave. Welcome, everybody. It's so great to have everyone here on such a welcome to our virtual guests. I'm so excited to meet you even virtually. We're just going to start right off here. I just want to say quickly, because everything is going to be quick, that this is an issue of great interest to me as a journalist and as somebody who teaches young people of color to do reporting on health disparities, and we've done a fair amount on cancer. Dave, coming to you first, you're live here in the audience. Of course, we all know that COVID has caused disruptions around the world, but I was horrified, to put it mildly, by some of the statistics we talked about the other day on what it's done with cancer care, diagnosis and treatment. We're searching for a vaccine, but for now, where are cancer patients? How is it affecting cancer patients, and what are some of the numbers you've seen?
Well, I think as an important starting point, over the past decade, we've made so much progress against cancer. I think the two doctors that are with us have been leading a lot of the work that we've done in research and in the clinic. And just to put some numbers around that, in the US, we know that from 1991 to 2019, that there was a drop in cancer death rates by north of 30%, 32%. We also know that during 2014 to 2019 in Europe, we saw similar improvements in cancer rates. And the reason for that is improvement in science and technology and awareness and access. And I think these have all been very, very positive things that we, within the field, have been able to make really great progress against. Unfortunately, during the pandemic, what we saw is that across the 6 major cancer types, diagnosis rates, testing rates dropped by as much as 40% versus pre-COVID baseline levels. And this is across colon cancer, lung cancer, breast cancer, prostate cancer. And just to put that into context, we know that when we diagnose cancer late, that the mortality rates are at their worst. The NCI put together an estimate that in breast cancer and colon cancer alone, as a result of misdiagnoses, that there could be as many as 10,000 deaths over the decade that would have otherwise been avoided because they would have been cancers that would have been diagnosed earlier. We know that even a 4-week delay in time to a diagnosis matters for initiating treatment. And this is, it's called stage shift. And so just to speak about what that means is that stage 4 cancer, advanced cancer, is unfortunately where mortality rates are the highest, prognosis is the worst. Stage 1 cancer, which is much earlier stage, much more localized, those are cancers that in many instances there's ability to be able to offer the potential and the intention of cure. And so to have that stage shift is something that's certainly been a challenge within the pandemic. I think that as we then think through this, so, what's the so what? Well, the so what is that we know that it has raised really, I think, the importance that we know that early screening, early diagnosis, navigation towards treatment, and doing all of this with a lens towards how do we deliver this with equity is something that I do really think has been something that I hope will be a silver lining that comes out of this pandemic, that the dialogue is one that we're able to have around this. And I think that we learned a lot from our pandemic response on healthcare system sustainability and the importance of keeping people out of secondary care and keeping people out of hospital systems. I think that cancer is one of the #1 causes of premature mortality across the globe. And if we're able to make meaningful progress in diagnosing early, in treating early, and identifying early, I am confident that it will be a contributor to healthcare system sustainability. And I think that we need to look at cancer through that lens as something that's really contributing in that way. And I think that gets done by focusing locally. We can talk here at a global policy forum about this, but I think at the end of the day, we know healthcare is delivered locally, and this is about national cancer strategies, and that within subnational areas, really understanding what it takes in order to move the needle here.
And we have so many questions and so little time, but this is such an important topic, and these numbers are so shocking, at least to me. Dr. Kingham, if we could just, I wanted to just turn to you if you wanted to add anything, what you've seen in New York and elsewhere. I believe one of you is out of the country right now, but what's your experience right now with seeing this kind of decline?
Yes, I'm actually speaking to you from Nigeria, and what's interesting is during the COVID pandemic, we have seen in the U.S. What is common every day in many healthcare systems in low middle income countries around the world. So I'm a liver and pancreas surgeon in New York. I unfortunately have seen a number of patients who've come in the past 2 or 3 years, well into their disease, mostly because they were afraid of accessing the healthcare system because of COVID. In New York, this was especially brutal to us. But this is really how healthcare systems have unfortunately been existing in low-Saharan Africa. So this, the idea that we need to focus on access, reducing time, actually early diagnosis, probably more important than screening. These are all things that have existed for a long time outside of the US. I think COVID has helped raise our awareness of how important these topics are inside the US, but also around the world.
Dr. Lopez, would you like to add anything, or we can move on to another question? It's totally up to you.
So there's just one quick point that we need to make. COVID also helped us see the inequities that we see within our country. Hispanics and Blacks in this country had much higher mortality based on COVID. And when we really look at cancer care itself, while non-minority patients were able to get into telemedicine very quickly, we saw a lag in Hispanics and Black patients being able to actually access healthcare through telemedicine and other telepresence ways. So I think it's important that we remember that we have a lot to improve within this country as well in terms of equity.
Oh, yes, indeed. And let's just use that as a segue to talk a little more about health equity. And I know there's a move to stop talking about disparities and talk more positively about equity. I do remember a few years ago, the DC Health Commissioner at the time was talking about how there were wards in DC that had some of the highest screening rates, but also record death rates from cancer. So they were getting screened and they were still dying. They weren't getting the treatment at all or quickly enough. So when we talk, Dr. Lopez, about health equity, what are your kind of concrete suggestions for what needs to be done to make sure that these underserved communities get the care that they need?
So we have started the most important thing, which is the conversation. We did not even have these discussions barely 5 years ago. So we are well into having commitment from a number of institutions, government institutions, non-governmental organizations, and industry looking into this issue as something that we need to address. And we're starting to try to address it at every single level. And the one that we work the most as medical oncologists, that we're trying to increase representation in clinical trials as well. So that has been one of our greatest pushes in the last few years. But of course, access to healthcare coverage is extremely important. We have seen a number of people losing coverage because they lost their jobs, and we don't have a safety network in this country that is as good as it could be. So we certainly have to start by making sure everybody has some sort of healthcare coverage, and then we need to start being able to use what we have in terms of resources in the most efficient and effective way. There's a lot that we need to do, especially when you talk about underserved communities in urban and rural areas as well.
I actually wonder if anyone agrees with what a prominent oncologist told me once, that he thought one of the problems was that the doctors who were treating Medicaid patients didn't have the same incentive. I mean, it's awful to say, but there wasn't the financial incentive to really do the follow-up that was necessary and get people in. Do you think that that's one of the problems?
Actually, in many ways, having been able to expand Medicaid coverage has improved care, and there are data presented in recent scientific conferences showing that having been able to expand Medicaid in a number of states has actually helped improve mortality for those patients that became covered because of Medicaid. So having some healthcare coverage is better than having none. But of course, once you have limited coverage, you will not have access to everything that you might have with private insurance. So yes, the incentives do need to be aligned.
Right. If we could talk, I was going to go to Dr. Lopez, but you're in Africa right now, Dr. Kingham, to touch on the very worrying data. So whoever wants to address this can, that there's a new study showing that 2.1 million new cancer cases and 1.4 million cancer-related deaths are expected in Africa by 2040. Which of course would be an enormous challenge for the healthcare system there. What can be done, like from here? What can others in the West do to help address that? Either of you?
Yeah, I think it's a huge problem. There's a big shift from communicable diseases to non-communicable diseases: cancer, diabetes, heart disease. These are diseases often associated with lifestyles that come with high-income countries, like sedentary lifestyle, processed foods, obesity. Sort of the curse of a high-income country is now being deposited in low-middle-income countries where there already are infectious-associated cancers in healthcare systems that are struggling to deal with these. So I think there's a couple of important ideas to think about. So one is, it's very difficult to extrapolate data from the US and other high-income countries and assume that we know this works for cancer and extrapolate these results and apply them in low-middle-income countries. We have seen, and others have seen endlessly, that if research isn't done in the region of interest, oftentimes it's applied inappropriately. So it's foundational things like implementation science, it's redoing studies, it's doing studies on the genetics of cancers in low middle income countries, not assuming that how cancer works in New York is how cancer works in Nigeria. Every time we look at this, we are amazed at how oftentimes the answers are different. The culture's different, the systems are different. And if we don't really support research in trying to figure out all these important questions in low middle income countries, it's hard to see how we're going to help what is becoming a really major growing problem in all these countries.
Jane, can I pick up on
yes,
Doctor's
and I was
comment
going
here?
to you right after that.
And I think it also gets to very much what Dr. Lopez was speaking about. I think that one of the biggest lessons and learnings that I've had in the work that we've been doing to really understand how you move the needle on health equity is a recognition that if you want to build equity into a process, it has to start from as early as possible, i.e., as Dr. Kim is saying, kind of discovery, development, implementation science, the research efforts. And it needs to then carry through from there into the delivery, which is part of the reason why I think that within the United States, the dialogue and conversation around clinical trial diversity is so important. I think that within the US, by having a focus on diversity and ensuring that we're going to communities where we're able to actually drive that diversity, it creates the virtue not only of studying patients that are representative of the communities that then need to be treated, but it's also building the infrastructure, the expertise, the capability in order to ultimately be delivering those therapies in a post-clinical context. And I do think that those lessons are the same in many respects, whether or not we're talking about a region within Africa, a region within China, or a community within Louisiana. And I think that that concept can still apply, and I think that's something that I take away from listening to Dr. Kim's points.
And how about also the importance of partnerships? You were agreeing in the green room with Lori Riley, I believe it was, talking about public-private partnerships. How important are they when we try to address these issues?
I think that this has been one of the most important lessons that's come out of the pandemic period, is to see public-private and private-private and public-public partnerships that are taking place. And I'm confident from the work that I see across the globe, and both doctors could speak to this. I mean, innovation is a team sport. Treating cancer is a team sport. This is about getting radiology, pathology, nurses, medical oncology, surgeons, social workers, all together to be able to actually be delivering this. And that is in and of itself partnership. And again, if we're going to tackle this, this is about bringing together the various people who are able within a community to affect that change to be able to make it happen.
Dr. Lopez, anything you'd want to add to that?
Two things that I like to add. First is the point of investment. We and others showed a few years ago in a paper we published at Nature that low and middle income countries actually spend 100 times less per case basis in control of cancer. So this is a problem that we have. When I started working with cancer control in a global perspective, looking at low and middle income countries, people looked at us like, why are we going to worry about cancer in low and middle income countries if all they have is infectious diseases? And it's clear that with the demographic transition, with most of us living in cities, even in low income countries, we have cancer and other non-communicable diseases as the most important issue we have in public health today. So over the last 10 years, we have seen a shift, and we have seen global international organizations in the United Nations system, as well as in private, showing that we do need to focus on cancer and non-communicable disease in low-income countries. So we have seen that it's a little bit easier for us to make a case today, but we still don't see the levels of investment locally in Africa and Latin America and Southeast Asia and East Asia and South Asia that we need to see for this to improve. So we're still kind of a couple of degrees away of being able to see the amount of investment that we need. And as Dave mentioned, and we have worked together in a number of projects as well as with Peter, we do need partnerships. This is a team sport. We cannot go far. We cannot make a dent in the situation we have today without bringing all stakeholders in a multi-sectorial approach together.
Something that gets back to health equity, but it's more of a question that I'm personally interested in, but it would be, I'm sure, is of great interest to all of you, is the need to diversify the workforce, the doctors, adding more community health workers. I mean, I'm focused on trying to add more diversity to health reporting, but there's so much important work being done around mental health with community health workers. But anybody want to touch on just the need for more people at every level of the healthcare system who look like the people they're treating?
Yeah, absolutely. This is something I see as a clinician treating cancer patients in New York, where the more diverse, both in every aspect of diversity, whether it's gender, race, whatever aspect you want to look at, clearly patients are more comfortable and access the health system easier. And I think this applies globally as well. In Nigeria, we've been making a big push in all our training programs to ensure gender diversity, for example, because we have found that women, especially with breast cancers, cervical cancers, can often struggle to access the healthcare system. So I think it's a very important component of trying to address this growing cancer problem outside of the U.S. globally, but also it's the same thing in New York. And that really has not been something we've stressed up until the last few years, but I think we all realize how important it is.
We have a question from the, if you want to add anything, feel free, or we can go to a question from the audience. Okay. A questioner, Matthew Sherman, is asking, he's with APCO Worldwide, what policy measures are needed to increase equitable access to cancer screening and early diagnosis within the U.S.? Good question, Matthew.
Well, I'll take a crack at a start on this. I mean, I think that first and foremost, we've got, in my opinion, the tools and the technologies to be able to make meaningful improvement in colon, prostate, lung, cervical cancer screenings. Mm-hmm. And I think that a national cancer policy that starts to focus in on some very specific goals, like we want to improve screening and early diagnosis, and it's going to be part of quality metrics, and it's going to be part of expectations that we see for providers to be going through. I think that would make a very material difference. Mm-hmm. I also think that navigation is such an important issue that I hear, and I'd be interested in the two doctors' perspectives on this, but it's one thing to diagnose early, but then you need to make sure that from that place that you're able to then navigate a positive diagnosis into the best pathways from there. And so I think the ability to be able to have that navigation take place, we know it makes a difference. We know that it really drives more coordinated, better care. And it's not something that hospitals get reimbursed for. And It's not something that they're able to actually deploy without it coming out of their own bottom line. And I think that this is something that would make a very real and important difference. I would certainly be interested in what the doctor's thoughts are on
either one of you?
Before I mention navigation, there's one case that I like to make for the screening of lung cancer, especially in the US. So even though we can improve on what we do for cervical cancer, breast cancer, and colon cancer, we already have more than 60% in the country overall of people who qualify for those screenings actually doing that. But when we talk about lung cancer, fewer than 10% of patients who are eligible for lung cancer screening in the United States are actually getting their low dose of radiation CT scan. So we do need to create this awareness about lung cancer screening that's just not quite there yet. And navigation is paramount. There's no large academic National Cancer Institute designated cancer center in the country that doesn't have a navigation project or a navigation program and system. So we do need to extend that to community oncology programs. And as Dave mentioned, we need to have this reimbursed so that more patients can benefit. It's very complex to be a person living with cancer. It's very hard to navigate what your insurance covers, where you should go, what's the ideal type of treatment, who are the professionals that you should see. So it is paramount that we have navigation built into the system.
We have another question from the audience, but I want to get to the some of the talk about partnering on cancer R&D and the Cancer Moonshot program, Europe's Beating Cancer plan. This could be for anyone. So, but how should we measure success from these initiatives, and are they the future of multilateral partnerships to create a unified approach to cancer care?
Yeah, so I'll start on this. I think, partnerships are obviously key. On an individual patient, we partner between surgeons, medical oncologists, radiologists, pathologists, nurses. So at the individual patient level to the global level, partnerships are really key. But I'll say, since this is a global health forum, that I favor what has been called the ground shot approach over the moonshot approach. And what that means is there's some very what appear to be simple methods that we know can work if applied. It's not screening everybody in low middle income countries. It's working on early diagnosis, access to the system. It's financial coverage for healthcare, where most countries are self-pay. So financial toxicity is the #1 reason why a patient can't access the system, and if they do, why they don't stay in the system. And to fix this, with the moonshot, the problem to me is it gives the idea that we need some drastic new technology to land someone on the moon to do this, and that's not the case. And I think then you switch measuring success from what we traditionally do, which is, what is the percentage of patients alive at 5 years, or how many patients recurred, and instead you look at what is success to the patient. What's the patient-reported outcome that the patient says matters to them? Because in the end, that should be the most important outcome. And that's not usually what we look at in the US or globally. We are more commonly now. But I think there's a lot we can take from the US system and these partnerships. But I think we have the opportunity to really revamp how we think about progress in cancer care, especially globally.
If I can, I'm going to quickly add the audience participant, Dr. Dominica Griffin, who works for the Senate, U.S. Senate. She asks, at a fundamental level, what are the respective organizations, your hospitals, pharmaceutical company, doing to partner with marginalized communities?
So one of the really powerful demonstration projects that we've been impressed by is work out of Delaware, back to Dr. Lopez's comments around lung cancer screening, where within Delaware, they've been able to really demonstrate the ability to bring together multiple stakeholders to make a material impact on colorectal cancer screening. Mm-hmm. And they've got measurable equity that's been driven also across race. And I think that this is something that's been a really, really impressive project. And it's about bringing primary care together with medical oncology, together with social workers, together with the payment systems. And we see that model, and we've been working together with multiple partners across the United States to work on, and I think this is what the doctor was speaking to, more grassroots efforts. One of the efforts that's underway is one in rural Appalachia, where lung cancer is certainly an environmental issue of important concern, and working together within the community to understand how can we drive improvements in lung cancer screening there, and bringing together and convening the partners necessary to do it. So that's one example of the kinds of efforts that are underway.
Doctors, either of you have any?
I'd like to mention that we actually need both ground shot and moonshot. It's not quite that we have cured all cancers yet. We do need moonshot. We do need innovation. We need better ways to have multi-cancer detection tests that can use blood tests as a screening. So we do have a lot of things we need to develop. Mm-hmm. And we do have to thank Congress, as the question came from a physician working in the Senate, for continuously improving and increasing funding for research that is the basic research that will change things in the way we prevent, we diagnose cancer early, and we treat it. So we do need both. It's not about either or. It's about both ground shots, so that we use everything that we have already learned to the best of our ability in the most efficient way in our healthcare systems. And it's about the moonshot as well, so that we can develop the technologies that will lead us to cure cancer within our lifetime.
But in Miami, Dr. Lopez, are you working with any of the marginalized communities?
We do. So we believe that representation matters. So our physician body actually represents our community. We do have a number of Hispanic colleagues, and we do see increased numbers of minority members, minority individuals being enrolled in clinical trials based on this relationship with physicians and researchers that actually look like them. We also do have community healthcare workers that come to our marginalized communities and actually not just have their participation, but engage and make sure that we understand what is needed in those communities in terms of cancer prevention. We have programs, for instance, for self-detection of HPV, because members of marginalized communities felt very uncomfortable about having a physician doing an HPV test or a pap smear. And these are programs that have started as research programs that are being incorporated into practice. And those have come from getting to our communities, listening about what they need and what they would care for, and working together to develop new strategies.
Dr. Kingham, you could, if you want, mention a really quick thing in New York, or we could go to the quick round robin that's going to be really positive. What would you prefer?
Yep, I'll just mention one quick thing we're doing, which is partnering with some of the New York City public hospitals to give access to our genetic testing for cancers, because we have found that marginalized populations have less access to genetic testing, and thus to know which genetically driven therapies are available to them. So that's been a way for us to partner to treat patients in the institution where they already are, and try and get them access to personalized care.
Good job. Dave, quickly, what's most positive? What can we end on a positive note about when you look at what are you hopeful about for the future of cancer care? What innovations? 30 seconds.
All right, I'm exceedingly hopeful that we're seeing a convergence of science, technology, data that is allowing us to be able to envision curing cancer in many of its forms. And I think that one of the things that I see is that this implementation science notion of how do we actually deliver that is actually probably the bigger challenge that we're going to face. But I actually think that the science and the technology for cancer in many of its forms, I can see on the horizon opportunity to really believe that we're going to make a material impact against it.
Okay, good job. Dr. Lopez.
We do a lot better today than we did 30 years ago, and we are going to do even better in the next 5 to 10 years. So it's a matter of continuing the investments and making sure that not just we develop new treatments, but we make them available to everybody who needs them.
Terrific. Dr. Kingham?
Yeah, the fact that we're talking about cancer in low middle income countries in a way that we never have, I think is already a success. So great times ahead.
That was good. We're at 0. We made it.
Yes, I saw that.
Thank you so much for joining us from so far and wide and here in person. It's been great to talk to all of you, and I hope to talk again. Thank you.
To discuss how to prepare for the next big threat, please welcome Dr. Hillary H. Carter, Deputy Senior Director for Global Health Security and Biodefense at the National Security Council, Colonel Matthew Hepburn, Senior Advisor at the White House's Office of Science and Technology Policy, Gabe Bankman-Fried, Founder and Director, Guarding Against Pandemics, and Foreign Policy's Pentagon and National Security Reporter, Jack Desch.
Thank you so much, everyone. So as you've probably figured out from our panel, this next session is all about the government. As you know, governments big and small helped fight the pandemic. And now we're going to put some of the leading experts in government and outside on the hot seat to figure out what they're doing to prepare for the next one. What's the game plan? Joining me first, Dr. Carter from the National Security Council, Deputy Senior Director for Global Health and Security. I wanted to ask you, the Biden administration is now in the throes of preparing its new national security strategy. As consumers of this document, people in Washington, what should we be looking for when it comes to pandemic preparedness, perhaps a playbook for the next pandemic?
Yeah, thank you very much for that question, Jack. And it's a real pleasure to be here on this panel with my close colleague and friend, Dr. Matt Hepburn, and also Gabe. So I think I want to make a couple of points in response to this question. I think the first one is, biological threats are enduring. They didn't start with the COVID pandemic, and they won't end with the COVID pandemic. We can look back over the last several years, back to 1918 and the pandemic influenza, and see the impact that biological threats have had. More recently, we've had MERS, SARS, multiple outbreaks of Ebola. And it's not just naturally occurring biological threats, it's also accidental, the potential for accidental threats and the risks that are associated there, and then also the potential for biological warfare. And so with that, I think we have to maintain this focus on biological threats. And so to get more specifically to your question, what are we doing to address these threats? And in the first part of this administration, President Biden tasked us, the National Security Council and the entire US government with a review of all biopreparedness policies. And we're nearing the completion of that review, and we'll look forward to announcing the results of that soon, including a new national biodefense strategy. I think we've talked for a long time about biological threats being national security issues, but we haven't resourced them as national security issues. And the president announced in the fiscal year 23 budget a plan to do that, with a focus on medical countermeasures, infrastructure for public health, basic research, fixing our regulatory or modernizing our regulatory infrastructure, strengthening biosafety and biosecurity, all to transform our capabilities for biodefense, pandemic preparedness, and global health security. And that was an $88 billion request over 5 years. And so not just talking about these issues as national security issues, but also resourcing them as it. So back to you, Jack.
So Dr. Carter, maybe Matt, you can chime in. Sure. Maybe just curious if you have any spoilers for us. I'm the reporter, so I have to ask this question. For that strategy, is this the time we finally get, maybe a biothreat czar? Correct me if I'm reading the org chart wrong, but I don't see it there yet.
Defer to Hillary, because she's not here. So.
Hillary, biothreat czar potentially coming our way in that strategy you were referring to.
Yeah, so what I would say to that is, again, in some of the first announcements that the president made in the first part of this administration was to note that the Assistant to the President for National Security Affairs, or the National Security Advisor, is the federal lead for coordinating, responding to a biological incident. And the charge there is to marshal the full resources of the US government, leveraging the really deep expertise, technical expertise that we have, all the resources that we have across the US government to lead that response and lead the preparedness for a potential response.
And if just to add a little bit to that, and Hillary's response was always perfect. Good to see you, and she's such a great colleague for us to work with. I think one of the big lessons from this pandemic is that we were best as a government when we were a wide and vast government team all working together towards that common goal. And there were a lot of really good examples of that. We had public health response, we had vaccine development, we had experts at NIH really leading that scientific progress. But we had our whole economics team thinking through supply chain and manufacturing, thinking through very sort of the vast, complicated aspects of the response, the State Department working on the global pandemic response. And for me personally, the blend of Health and Human Services and Department of Defense brought together in Operation Warp Speed was just another example of that. So the goal going forward is, yes, we need leadership that can put all of this vast experience and capability together. But we have a playbook now in terms of the current pandemic in terms of how to do that.
Matt, I wanted to refer to that point. You were just talking about Operation Warp Speed, or the operation formerly known as Warp Speed, I suppose, once upon a time. I'm curious, now that we're sort of past the major throes of the pandemic and dealing with the aftermath to a degree, how do you still get Congress and the American public motivated by vaccine development? How do you make it a continued funding priority and plan for the next one?
Yeah, well, and I think that's been really a theme for the day. If we listen to the other panels, how do we motivate for preparedness and how, for the various issues for which we know are going to be future threats? That's our main theme. It's really hard to do. One thing that I think is helpful, though, is remind people that we can succeed. So I think this idea of when we go in and say, oh, it's hopeless and we're just going to get hit with another pandemic and we're going to get with this and we can't solve these problems, and everybody's kind of describing the problem, it's really hard to motivate people. And that's why, going back to kind of the Operation Warp Speed example, not just warp speed, but let's use it as an example. The concept that we can go from identifying a virus to having millions of doses of vaccine, and then as a global community, many vaccines and truly billions of shots in arms in a couple years, it's extraordinary. Like, it's truly, truly extraordinary. And I guess I think we can always talk about fear and get people worried about the next pandemic, but I prefer a message of hope as well. To be able to say, look what we can do when we put our minds, when we put our hearts, when we put our energy together, not just as a domestic community, but really as a global community. Look what we can accomplish. And then while we're saying, okay, we may have some big future threat out there and we have to get ready for it, we can put our energy into the problems that we have right now and use that. So some people don't like it, but I conflate a lot of the issues that we've been talking about in this forum today with pandemic preparedness. Antimicrobial resistance and how we respond is pandemic preparedness in my mind. It's accurate diagnosis. It's using data science. It's driving next generation technology and medical products to fruition. I think going after viral hepatitis viruses, that's cancer moonshot. If you can vaccinate the globe against hepatitis B, if you can test and treat, which we're doing now, for COVID, against hepatitis C, you can eliminate one of the leading causes of liver cancer. So putting the energy together and motivating for that with the understanding that those things are also going to help us, they're the muscle memory and exercises that we can do for pandemic preparedness, then that's how I think we win.
And not to throw the classic Washington ballpark lingo at you, but you walk and chew gum when you're traveling at warp speed, balancing sort of the product safety end of the house.
Absolutely.
With actually developing these things.
Yeah, absolutely. And I think that's, again, what I think was done well was this idea of we need to move quickly, but we will never compromise standards in terms of the quality of the product and the safety. And that's, for example, in the vaccine, that's why the United States government, in partnership with the private sector, did 30,000 volunteer vaccine phase 3 clinical trials. Very large, significant trials that we enrolled quickly, but we never compromised on safety and quality and integrity. And the other part is transparency. I love how our processes, like our FDA advisory committees, continue to meet and you can watch. This idea of transparency going all along that. But again, if we can move quickly and solve really big problems, but still maintain the highest levels of safety and quality, just think about all these problems that we can solve. And what I love to say in these fora and for this audience is that it allows you to kind of ask that question. That's my favorite part, is when people say, well, this is going to take 20 years or this is going to take 8 years. You say, why? Why truly examine all of the process, start to finish, because we have an example where it went a lot faster. And those examples, you can say, well, that's different. It is, of course it is, but there's a lot of similarities to the other problems that are requiring solutions where a lot of people say it's going to take 20 years to solve it.
So I know we don't know what the next one is. Don't say monkeypox. But if you're sort of putting on your prediction hat, could you go from a similar scenario where the world shuts down on March 12th and a year and a half, 2 years later, you have a provable vaccine for the next pandemic?
So the answer is yes. Yeah, absolutely. But next time we got to go faster, right? I mean, there's like, I mean, that's the idea, and there's smarter people than myself, and there's actually international agreement that are talking about what they call a 100-day mission, that the next time around, having vaccine therapeutic products within 100 days. And that's impossible. It's okay, I got that. But if you look at the different steps to be able to achieve that, large-scale decentralized clinical trials with equity in mind, so that we are recruiting, clinical trials are available for all types of people, that's achievable now. rapid scaled manufacturing achievable now. Like there's so much that we can do that puts that together. So I think the next time we're obligated, right? We're obligated to go even faster at the highest standards of safety and quality.
Gabe, I've got a really simple one for you. When you sort of look at the scope of the threats, when you're talking to lawmakers and policymakers in Washington, what's the threat that keeps you up at night when it comes to pandemics?
Well, thanks for the question, and thank you both for appearing on this panel with me. So I run Guarding Against Pandemics. We're an advocacy organization. Spend a lot of my time talking to policymakers, particularly on the Hill. The thing that worries me most, quite frankly, is a much more deadly pandemic than COVID, possibly an engineered one. We know that is, as Hillary mentioned, it's very much in the realm of possibilities, unfortunately. The good news, and to speak about optimism, is a lot of the things that we do to prepare for a COVID-like pandemic are also similar to the things that we do to prepare for some of these scarier pandemics. And it's not rocket science. We know a lot of the interventions that are required to actually prevent these. We've seen the success of warp speed, and we can be even more successful if we do things in advance. And so not only do have we seen what we can achieve with the ambition of something like producing a vaccine in a year, but the scale of the problem actually gets much smaller. It's much easier to do these things if we have the kind of runway, if we start now, instead of waiting for a threat to emerge. And so that's why I'm so optimistic about these threats, but it requires responding quickly and getting policymakers to recognize the danger that we are all facing, which is what we've been spending a couple of years trying to do.
Well, that brings me to two questions for you. What preventive steps should we be taking now as we see COVID-19 perhaps ebbing away to a degree? And you mentioned an engineered pandemic. Bold words. What does that look like to you?
Well, there's far more esteemed national security experts on this panel than myself, so I'll give my, broad-scoped answer, but obviously would love to hear Matt and Hillary's as well. So on the first question, what does prevention look like? What are the things we can do to actually prevent? Warp speed in advance. Produce the research and development with emphasis on development for vaccines, therapeutics, PPE, non-medical countermeasures like PPE, but also built environment upgrades and early detection to be able to identify outbreaks extremely quickly when they emerge and be able to prevent them. And what that really looks like is not that much funding. I mean, Hillary mentioned the historic $88 billion funding request from the administration. This is, less than 1% of the amount of money we've spent on COVID, right? On the scale of how large these problems can be, it's tiny. And that would allow us to produce a lot of the technology necessary to be able to identify outbreaks quickly and respond aggressively and prevent them from spreading. So that's what the interventions look like. In terms of the threats, engineered pandemics, without, of course, getting too specific here, unfortunately, it is not the realm of science fiction to say that it is possible to produce a pretty scary virus. Unfortunately, the technology required to do so is getting cheaper and more readily available to a lot of people across the world, including some pretty bad actors. And we know that bioweapons programs exist. And despite how foolhardy they are as a concept, even for warfare, the possibility to produce something that is as contagious as COVID, but potentially much more lethal, is very real. So I don't know. I would love to hear Matt and Hillary's take, but the threats are there, and we can prevent them.
Fair enough. I wanted to get to our audience in a second, but to that point, I mean, Hillary and Matt would love you to chime in. Is there a threat of an engineered pandemic? And maybe Hillary, this for you. We hear a lot about the chemical weapons threat in Ukraine from Russia. We hear a lot about a potential low-yield nuclear weapons threat. Is there also a biological weapons threat? Because Russia, of course, still has a biological weapons program.
Yeah, so maybe what I'll say first is just picking up on the previous question on potential for an engineered pathogen. So right now, as you all know, as our audience knows, we are seeing an explosion in revolution in biotechnology, and that's a good thing. That's going to allow us to do those things that Matt was just talking about in terms of innovating for vaccines and innovating for cures and doing that faster and at scale. With that also comes risks, and we need to understand those risks. If you have more people using powerful tools, experimenting with biology, there just inherently is going to be more risk. And so we need to understand that and address that. And, to your more specific question, I think we generally do worry about the potential for warfare. And that's something that we watch really closely and that we take steps to do to counter and to mitigate as we are for naturally occurring and these accidental threats.
And is that a threat in Ukraine? Of course, Matt, I'll let you take the other piece of that question, but I'm curious, Hillary, is that a threat that you see in Ukraine from Russia?
Well, I think, there certainly has been a lot of talk about that, and our ambassador in the UN has talked about that. I think, we continue to monitor the situation and continue to watch that very closely.
Matt, anything keeping you up at night?
Well, agree with Hillary on the previous answer. I do want to make a point, though, on the comments about engineered threats and a general comment. You mentioned this is a government panel. And I think what Hillary and I do every day, all day long, is think through what are inherently government functions? What does the United States government should, have to, must do? And then what can we do to enable others as part of a collective pandemic preparedness team? So if we're talking about making sure bad people don't do bad things and that there is some oversight and regulation so that those things can't happen, I think we'd all agree that's inherently a government function, and we should make sure our government does that. I think the American people would want us to make sure that we do that. I think one of our main lessons in this pandemic, and every pandemic, and even in a future scenario where bad guys start a pandemic with an engineered threat and then it's something contagious and it spreads, that the response to that is going to be pretty similar to the response to the COVID pandemic, which is pretty similar to how we should be responding to antimicrobial resistance and seasonal influenza and viral hepatitis, and the list goes on. The fundamental ideas of you need public health, you need to contain and to do surveillance, and we need to do product development, and we need to communicate and make sure that we are not leaving anyone behind in a pandemic response. All of those things are kind of the same. And so the point is the government inherently should do some government things, but I think when we are at our best as a United States government, we're enabling the private sector to innovate, to develop their products, and to bring these miracles to bear, as we saw with COVID vaccines and therapeutics as a good example. But also that we're not saying, okay, we as a United States are going it alone. Wrong answer. A global pandemic requires a global response, and so we do this through partnerships. We learn from other countries. We've seen great examples of transparency in the scientific community, where the entire world has learned from the experience of one country. In terms of their scientific discoveries or in terms of their real-world evidence on how the vaccines are working and sharing that globally. So all of that, I want to leave you with this idea of we spend our time thinking how we can be good partners and how we can enable a global community to respond to pandemics.
We had one question from our virtual audience I wanted to turn to. This is from Patricia Kahn at the State Department. She's asking if there's a plan to coordinate new medical countermeasures at home with our embassies abroad. I was wondering if Hillary or Matt, maybe that's something you guys could field.
Matt, please go ahead.
I think I deferred to you twice, and so now it's my turn. So I guess maybe I'll try. I'm not sure I got the question completely. Let me try and answer. So the concept of us working together as a United States government team is our job. And I, again, go back to the American taxpayers don't understand that we have all these different departments and agencies and silos and stovepipes and all of that other stuff. What they're expecting is that we work as a government team and to protect them, and to use every dollar that they entrust in us for good, in this case, pandemic preparedness. So our relationship with the State Department can and should be incredibly close. And I guess on two levels. The first is, I served 23 years active duty Army, and I became an Army physician because I felt obligated that we should protect those that are serving our nation when they go into harm's way, or to make sure if they get sick, we take good care of them. It's a similar type of obligation for our State Department deployed worldwide. And so we do work with the State Department and deployed military and those that serve our government to make sure that they are protected against infectious diseases, and they have the medical care that they need. But I think maybe the question was more about how does our State Department work as part of our team, and they're a core part of our team. A global pandemic requires a global response. What we clearly see right now is that we need to continue to enable a world to be vaccinated against COVID. And that's a very challenging proposition. The proposition now is not that we don't have enough vaccine. The world is now able to make enough vaccine to vaccinate the world. But just as all of us have seen on a personal level in the United States, this idea of getting shots in arms, especially for those that are most vulnerable against COVID, is an enduring mission. Like, we're not out of this pandemic right now. And so that team is all our different parts of our government, but especially the State Department, working with those individual countries for us to help those countries vaccinate their populations.
Matt, is it the right read that sort of the vaccine diplomacy game of spreading American and allied vaccines around the world is slowing down a bit? And I mean, at this stage in the pandemic, since we're in the NATO week, the G7 week, a lot of allied meetings around the world, is there still a role for allied development of vaccines, information sharing, that sort of thing at this stage?
Yeah, so second part, yes, absolutely, working with our allies and partners. First part is that, one of the things I was really proud of is that the United States donated more vaccine than any other country in the world, and that the policy, as I heard and watched and lived, was that we weren't going to negotiate a vaccine donation for some other gain. That it was, we were donating because it was the right thing to do, and because a global pandemic requires a global response. That's still our posture. The issue now is that we need to partner as a global community, which is on the ground in an individual country. It's also supporting the multilateral institutions like the World Health Organization, so that again, ideally, everyone is vaccinated against COVID, and that's the way that we get out of this pandemic. I would go a little bit further, though, and say it's vaccine diplomacy, but it's really global COVID response diplomacy. It's all those things where we can, it's diagnostics, it's therapeutics, it's vaccine, it's frankly, as a global community, communicating about dispelling the mis and disinformation associated with vaccines, communicating clearly and accurately and transparency that vaccines are protective against COVID, not just in the United States, but as a world community. And I don't think we've lost steam on that part of it. I think that's an enduring mission. I feel like our government is committed to that mission.
Is there a quid pro quo built into China and Russia's vaccine diplomacy?
I actually don't know. In my previous role in Operation Warp Speed, we were really just focused on the product development. We left we got to get these vaccines donated to other folks in our government. But I do vividly remember messaging with our State Department. The public messaging was that we're donating vaccine because it's the right thing to do.
Gabe, I wanted to come back to you. We talked a little bit in the green room about sort of the 6 weeks to stop the spread, if you would, in a future pandemic. What's the right public posture? What's the right national security posture in that situation?
Yeah, I mean, I think as we've seen, once a pandemic is raging, we're faced with incredibly hard choices. There's no great answer. Things like warp speed and other critical tech development are, of course, the right answer for a piece of it. But even if you have the best possible response in the world, once a pandemic is global, especially one like COVID, we're still going to be talking about a lot of deaths, a lot of economic loss, and a lot of damage to the globe and at home. However, if you respond very aggressively, if you respond in the first few weeks, the first month, that's going to depend on the virus and the situation, you can actually contain it. And just think about the trillions of dollars that would have been saved and millions of lives that would have been saved if we had the posture in late 2019, early 2020 to respond incredibly aggressively to COVID-19. If we had done a warp speed in advance, invested in universal coronavirus vaccine development, had them ready to go, antivirals, had early disease detection, to the point about State Department international cooperation, had been working with other countries, including China, to identify outbreaks incredibly early, and had marshaled as a global community, but led by the US, on the idea that these 6 weeks will determine the fate of millions of lives and trillions of dollars, we could have contained COVID. And that's what we can do next time. And that's the holy grail. We still need to be able to respond at scale in the event that this is unsuccessful, but this is the holy grail that we need to be devoting significant resources to. How do we have the posture to respond quickly enough that we can prevent the spread and eradicate the next disease, the next pandemic, before it becomes a pandemic, the way we eradicated smallpox in the 20th century?
And how do you keep the momentum going at this stage when COVID is falling out of the headlines? I mean, are you getting groans when you talk to appropriators on Capitol Hill?
Yes. There's a lot of COVID fatigue right now in DC. I think some of this is about clear communication and differentiation between some of the more ambitious and more targeted preventative work and some of the other work that people are talking about. When people hear COVID, there's a lot of different things that they hear and different things policymakers hear, and they're hearing from constituents about mask mandates or whatever the thing in the news is today. And I think being clear with policymakers on these are targeted surgical interventions to protect US national security and save trillions of dollars and millions of lives. These funding requests have a return on investment in the 100 times or 1,000 times, not the one time, right? We're talking about billions of dollars to save trillions of dollars. Being clear with that communication to cut through some of the noise and identify the areas of strong agreement from everyone. It doesn't matter what part of the ideological spectrum you're on. The last couple of years have been miserable. I think we can all agree on that. It's not been a great time. And if we could have prevented this, if we could have saved the money and lives that we lost during COVID, that is something worth pushing for. That is something worth marshaling ambition for. Yeah. And that's the message we've been trying to deliver on Capitol Hill.
Yes.
I wanted to ask the opposite sort of question, if you would, of the vaccine diplomacy thing, and maybe starting with Dr. Carter. Vaccine propaganda, we saw a lot of it coming out of China and Russia, and maybe Matt, you can chime in too. I'm curious if as part of your playbook for the next pandemic, you're looking at that piece, that's still a concern for the Biden administration and the US government.
Yeah, I would say, more generally, disinformation continues to be a problem on many fronts, misinformation as well. And that's something that, we are understanding and taking action to address and, getting our message out there. So disinformation is something that will continue to be around.
Yeah, and maybe I'll answer the question slightly differently. So totally agree, and we have to figure out how we communicate clearly. It's so discouraging, and yet I think there's opportunity for us to communicate as a society even better about health and about health behaviors. And let me try to explain. So I was recently invited down to North Carolina by the state health officer, and we were talking about this issue and how do you communicate with communities about COVID? And we met in a church and we talked to one of the county health department educators, and her point was, I live in this zip code, I go to this church, I know these people, and and when I communicate with them, it helps with vaccine. The vaccine acceptance rates goes up. And then what she said, which gave me goosebumps, was that, and now what we've actually been able is, like, when we can start talking about COVID and vaccines, it opens the door for us to communicate about health and to communicate about the health issues of that community. And my point in this is that, again, I previously made the point of, we enable the private sector, and what's a government function, what's a private sector function, whereas philanthropy. But I think that type of on-the-ground public health engagement with the community is an inherently public function, and we have to resource that. And what I hope we can make the case of is that that is pandemic preparedness for the worse than COVID scenario. But it's like how we get to a healthier community too.
Well, just to that point, and we're about 2 minutes away from the end, but wanted to ask about public-private partnerships. Obviously, that was such a big part of the pandemic response. Is that still full momentum ahead? I mean, is that going to have to be scaled up for the next pandemic, or can that continue until we see another threat?
It needs to happen every day. And it's back to my previous point again, though. It's like our role as a government should be to enable private sector innovation to solve complex problems, because there's a lot of amazing people in America and worldwide who are working right now to solve hard problems. And if we can help them translate that into public good and the good of our society, then we win. I think there is, what that means though as our government is we're looking at things like how can we innovate in the manufacturing process so that if you can make vaccine at the highest quality standard, but make it faster, make it more distributed on a global basis, and make it a lot smaller, so it's in a modular thing and it's this small, and you can make vaccines in a lot of different places. Not only does that help us for pandemic preparedness, it just helps us for vaccination, and the same thing with therapeutic products and everything else. So what we're trying to do is say, is there innovation that we can spark for pandemic preparedness that leads to uptake that can transform the entire industry? And I think we've got a lot of good ideas in that space.
Gabe, something you want to chime in on?
Yeah, we got to fund BARDA. BARDA is one of the agencies that focuses on these public-private partnerships, and they're a lot of the driving force behind Warp Speed. Yep. And partnering with industry and making sure that we harness everything great about industry for the public good. And the money we spent on Warp Speed is maybe the best federal dollars ever invested, and we need to be continuing to fund these agencies and growing their budgets to make sure that they're able to prepare for the next threat too.
Well, I think that's probably a great note to end on. I want to thank the three of you for taking the time today, and we'll move on to the next panel.
Okay, great, thanks.
For a conversation on strengthening governance for future global health security, please welcome Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases and Chief Medical Advisor to the President, and Foreign Policy's Executive Producer of Foreign Policy Live, Tal Alroy.
Hi there, Dr. Fauci. Welcome back to Foreign Policy. It's great to have you back.
Thank you very much. Good to be with you. Thank you for having me.
Thank you so much. I remember the last time that we interviewed you, you told us that you were staying away from the White House Correspondents' Dinner. You said that given your age, you felt it was potentially risky. And unfortunately, just weeks later, you ended up getting COVID yourself. Are you doing any better now?
Well, yes, I am, but I've had an interesting course that I think is becoming more and more typical the more clinical experience we get. I turned positive about 2 weeks ago with very minimal symptoms. When they increased, given my age, I went on Paxlovid for 5 days, and I felt really quite well, just a bit of rhinorrhea and fatigue. And after I finished the 5 days of Paxlovid, I reverted to negative on an antigen test for 3 days in a row. And then on the 4th day, just to be absolutely certain, I tested myself again, and I reverted back to positive by the antigen test. So it was sort of what people are referring to as a Paxlovid rebound. And then over the next day or so, I started to feel really poorly, much worse than in the first go around. So I went back on Paxlovid, and right now I am on my 4th day of a 5-day course of my 2nd course of Paxlovid. And fortunately, I feel reasonably good. I mean, I'm not completely without symptoms, but I certainly don't feel acutely ill.
Good. I'm sorry to hear that you're not 100%, and we're all wishing you a speedy recovery until you are 100%. But speaking of lingering symptoms, how worried are you about long COVID? It seems like such a mystery to most people. Are you able to tell us just how likely it is that somebody is going to get long COVID and how serious it can be?
You know, it really varies, and that's an excellent question that we're trying to sort out. And for that reason, we've put together a very, very large cohort of people to determine the incidence, the prevalence, and the duration of long COVID symptoms. You know, there are multiple reports about long COVID, and they range from anywhere from 5% to up to 30% of the people have lingering, somewhat unexplainable symptoms that last anywhere from weeks to months. So I don't think anyone can give you a definitive percentage of the people who have been infected and who have developed COVID, who then go on to develop long COVID. But it is a real phenomenon. There's no doubt. The range is from 5 to 30+%, and the duration of symptoms ranges from several weeks to multiple months. So we still have a lot to learn, particularly about what the underlying pathogenic mechanisms of long COVID is, because you can't do anything from a therapeutic standpoint until you have at least a minimal understanding of what the pathogenic mechanisms are.
Right. Well, Dr. Fauci, I want to move to a topic that isn't exactly in your department, but since this is your first interview in public since last week's Supreme Court decision to overturn Roe versus Wade, which gave women in the United States the right to have an abortion up until now, I just have to ask you, do you view the ruling as a setback to women's health?
You know, I would prefer not to comment on something that is not within my lane. As you know, I'm very often the target of a lot of nasty things. I can tell you that I have always been very much in favor of a woman's right to choice. I have been for a very long time and still am. Whether or not one can say that it is going to have a negative impact on women's health, I think one needs to look merely at the history of what happened when interruptions of pregnancy, abortions were not allowed, and people went to extent to get it, and that led to some unnecessary morbidity and mortality in women, which I find to be very unfortunate.
Thanks, Dr. Fauci. Back to an area that is specifically under your wheelhouse at the National Institute of Allergy and Infectious Diseases, I want to push us towards our session's title, which is Strengthening Governance for Future Global Health Security. We've seen various countries handle the pandemic in so many different ways with varying results. Broadly, from your own perspective as the public face of the battle against COVID in the United States, what are the main lessons governments can draw from the pandemic, and how do we enforce those lessons?
Well, I think we have a very painful lesson that has played out in our own country that is really unfortunate. And that is, we have been living now over the last 2.5 years through the most horrible experience of a pandemic that we have experienced in well over 100 years, ever since the 1918 influenza pandemic. And if ever there was a time to have the country pulling together in unison against the common enemy, which is the virus, this would have been the time to do that. But unfortunately, we have beset with a great degree of divisiveness in our society, in which the proper implementation of very well tried and true public health practices has been actually put aside because of political differences and ideological differences. The whole idea about the acceptance of vaccination, the whole idea about the acceptance of mitigation, like the wearing of masks and the avoiding of congregate settings indoors, that has been driven for a fair amount by ideological considerations and not by public health considerations. And if ever there's a lesson to be learned for the future, is that when you're in the middle of a historic pandemic that has already killed 1 million Americans, that is not the time to be at odds with each other. It's at a time to be pulling together against the common enemy, which is the virus.
And are you hopeful, Dr. Fauci, that we will overcome that divisiveness that you just spoke about?
Well, I'm a cautious optimist, but my caution is taking over more than my optimism right now, because from what I can see, matters are getting even worse. We are living in an arena of disinformation, misinformation, and what I refer to in several of my recent commencement addresses as a normalization of untruths. And in my commencement addresses over the last month or so, I've practically pleaded with the graduates not to accept a normalization of untruths, but to push back against it. Because once you shrug your shoulders and say it doesn't matter if you say the truth or a lie or a conspiracy theory or a misrepresentation, once you accept that, then truth means nothing and integrity means nothing. And I'm afraid that we're sinking into that in this country, and that's very disturbing.
Agreed. More than 3 billion people are still unvaccinated for COVID-19. If there was another pandemic tomorrow, an engineered one or just a deadlier pandemic, do you think the international community is even remotely ready?
Well, I think we've proven with COVID-19 that we were not, even though we thought we were. I mean, as the only thing that was a success story in this outbreak was the result of the investment in biomedical research, which led to the development and implementation of highly successful and safe vaccines, which have thus far already saved millions of lives. The public health response has been less successful than the scientific response. And I would hope that we use the lessons that were learned of the things that went wrong with the global and the domestic response to this outbreak would be lessons that we heed as we prepare for the inevitability of future outbreaks, which in fact will occur. We don't know when. That could be next year, 5 years from now, or 10 years or more from now. But they will occur the same way as I and my colleagues for decades have been warning about an outbreak of this magnitude.
And we're approximately 2.5 years into this pandemic. Do you think that America has done enough to help the world fight COVID-19? Critics are saying that with 3 billion people still unvaccinated and with the TRIPS waivers not yet implemented, the West just hasn't done all that it could have to help countries around the globe. What's your take here?
Well, first of all, we as a global community need to do more. But I must say, not only because I'm an American, but America has done a lot more than anyone else. I mean, if you look at the amount of vaccines that we've distributed to over 160 countries with an implementation of and promise of at least 1.2 billion doses to be distributed, the $4 billion that we are putting into COVAX, all of those things I think need to be mimicked by other countries. So we have done, I believe, well. We can always do better. I mean, I'm the first one to admit we can do more, but when you look at it comparatively speaking, what we've done compared to the rest of the world for low and middle income countries is really quite substantial. And we continue to do more, and we continue to be a leader in that. So again, it's a call for everyone to do more, but we have done a fair amount.
And specifically on the TRIPS waiver, I want to push you on that. Do you feel like we could be doing more there? Is that holding us back?
Well, I'm not sure what aspect of the TRIPS waiver. I mean, it became very clear that we were in favor of making sure that we don't let patent issues get in the way of making vaccines and drugs available to the developing world.
The last time you were interviewed by Foreign Policy, you criticized China's zero COVID policy quite strongly. And I want to explore that with you just a bit more. The counterpoint is that China has had fewer deaths than most Western countries. Australia, for example, long delayed opening up, and it too had fewer deaths per capita than most European and Western countries. Is there merit then to closing borders?
Well, the criticism I had, and it wasn't a sharp criticism that I had of China, was that they locked down completely. And my criticism was that if you were going to lock down as stringently as they did, you've got to do it with a purpose in mind. And that is to allow you time enough to vaccinate all of your citizens, particularly the vulnerable, which in the case of China, that would be a considerable number of elderly individuals. They have not done that effectively yet. Thank goodness they are beginning to do that now. But my point was, if you lock down only for the sake of locking down, sooner or later, the virus is going to enter or re-enter into your country. And so lockdown might be fine, but make sure you utilize it for a purpose. And the purpose should be to get a very aggressive vaccination campaign to all of the citizens, particularly the vulnerable ones. And that has not been done very effectively thus far. But as I understand, they are starting to do that now, which is good news.
And on that note, which country, in your view, has done the best job, has had the best response to COVID?
I don't want to be doing that because that becomes a soundbite, and I'm really up to my ears in soundbites. So I'm going to stay away from that.
Okay. And as summer travel picks up, do you believe that the US made the right call in dropping COVID testing requirements to come back into the country? And under what circumstances will those requirements be reviewed?
Well, it's a complicated issue because the idea of the testing requirement, remember, was something that was overruled. I believe you're referring to the judge's judgment on that. Is that what you're referring to?
Yes.
Yeah. I mean, the issue of the decision that should be made about the requirement for a public health intervention should be the CDC as the public health agency of the country that should be making that decision. And I believe that the data that the CDC gets at our primary public health should be the thing and the science that drives our decisions. So if the CDC is okay with something based on the data that they've accumulated, then I'm certainly in support of that.
And I have a question from the audience that I want to add in here from Mitchell Warren in New York. You mentioned the critical role of past investments in biomedical research. Your leadership in HIV research was clearly a critical foundation on which to build the COVID research enterprise. Is there a payback for HIV research? And are there COVID lessons that we can translate back to HIV?
You know, it goes both ways. I mean, it's a very beautiful story of science, as a matter of fact. The work that had been done to try and develop a vaccine for HIV relied on structure-based vaccine design to get the right molecular configuration in a stable form of the HIV envelope to induce an optimal response of broadly neutralizing antibodies. We were not yet, and I say yet, been successful in an HIV vaccine, but that elegant science was the bridging and the stepping stone to the use of that same structure-based vaccine design and stabilization of the spike protein in its pre-fusion form, which led to the very highly successful vaccines for COVID. So HIV research over decades has contributed in a profound way to the success of COVID research and vaccine development. On the other side of the coin, it goes both ways because the success of the mRNA platform, which has been proven dramatically in COVID, is now being applied to the use of that platform for an HIV vaccine. We don't have results yet, but there's a lot of optimism and cautious optimism about that. So I think it's just a beautiful example of how efforts in one discipline feeds another and then comes back and feeds it in the opposite direction.
And, you know, Dr. Fauci, many people that I know have gotten COVID recently. I was talking to you about this before we joined, that, and they've never gone to a hospital. Most of them took tests at home, and their numbers aren't counted in the national figures. What do you think is the true number of COVID cases in the US?
I don't think I could give you an accurate number, but I would say it's at least a couple-fold, if not more, than what's reported. I mean, I know that as a fact because so many people that I know personally, as you said, have gotten infected, have been minimally symptomatic, and never reported their antigen positivity to anyone. And there's a lot of people out there. So I would imagine that, you know, it's probably 2 or 3-fold, at least more than what we're seeing.
Wow. And at what point, I think a lot of people want to know this, at what point does natural immunity wear off? And when do you expect another, you know, when should we worry about another spike in death tolls?
You know, that's going to depend on what kind of variants emerge. That's something that really is rather unpredictable. The one thing we do know that you mentioned that's important and true is that immunity against coronaviruses is not long lasting. It is not like measles, where if you get either infected or vaccinated, that you have immunity that lasts for decades and sometimes for lifetime. The same holds true for smallpox and polio. That's just not the case with coronaviruses. The immunity to coronaviruses wanes over a period of months. It doesn't wane very much for protection against severe disease, but it certainly wanes for protection against infection.
Got it. Thank you so much, Dr. Fauci. I just want to say that, you know, we all are hoping that you get better as soon as possible and are back to yourself 100%.
Thank you.
Thank you so much for joining us.
My pleasure. Good to be with you.
For a conversation on strategizing for an equitable future, please welcome Dr. Ala Merabit, United Nations High-Level Commissioner on Health, Employment, and Economic Growth and Health Director for the Bill and Melinda Gates Foundation, and Foreign Policy's Executive Editor, Amelia Lester.
Dr. Merabit, thanks so much for joining us.
Thank you for having me. I'm excited to be here.
I'm really delighted to be sitting with you here today because throughout today's program, many of our sessions have touched on health equity and specifically the needs to highlight the ways that health systems are not ready to meet the needs of the most vulnerable populations in the world. And we have this unique moment now, I think, emerging from the pandemic to fortify these systems to do exactly what they're meant to do, which is provide care. And that's what I'd love to talk to you about today. You're a tireless advocate for women and girls, and I have to begin by talking about what happened last week when the Supreme Court struck down Roe v. Wade and took back a constitutional right for women that had been established for 50 years. How is that decision in the US going to affect access to reproductive health care around the world, do you think?
You know, I think our team is looking at that closely in terms of what the tangible impact is. But I think we can, and to Dr. Fauci's point, we have historical precedent to appreciate. And we know that in the past, certain actions against abortion have often led to empowering autocratic leadership in other parts of the world. They have supported, endorsed, empowered other leaders who would also look at restricting women's reproductive rights. And we've already heard quotes from leadership around the world about how this highlights how reproductive rights are not a health or fundamental right. And I think that alone, that opening up of that debate at a global level is quite concerning. And I would be remiss here, I mean, and I appreciate we'll talk about kind of equitable health across the board, but I think one thing we should appreciate is the importance of women's health, not just as a metric for health access or equity, but the importance of women's health and agency and power as a metric for stability and prosperity of a country. That is critically important. We know that the single greatest indicator for a country to fall into conflict or maintain conflict is not GDP, economic output, et cetera. It's actually the degradation of women's rights. And there's a wonderful book called Sex and World Peace by Valerie Hudson that goes into this in depth. So investments in women's health and in women's reproductive rights are not only investments in health equity, they're not only investments in families, but coming out of this pandemic with all these conversations around inclusive economic growth and stability, they're investments in that. And to be removing that right, I think completely, fundamentally destabilizes our ability as a country, but globally, to really return to a place of normalcy or prosperity.
Yeah, you went to medical school at 15 and you thought you were going to become a surgeon like your dad. And then you graduated medical school the year of the Libyan Revolution. And then by the age of 21 had founded Voice of Libyan Women. Because of your career path, I really can't think of anyone better to talk about this link between healthcare and international security. Can you talk a little bit about why specifically it's so important to protect access to reproductive health care in the context of security? And what is that link between women's empowerment and global security?
You know, I think it's funny because I come from a family of surgeons. My dad is, my older sister is, and they joke that the only real kind of doctor is a surgeon. And so you can imagine how much I disappointed them by going not after surgery, but into global policy. They were like, wait, what? The only thing worse would have been telling them I was going to become an economist, I think. But no, it's interesting because I first got involved with Voice of Libyan Women really looking at women's inclusion in conflict resolution. And what really struck me was that throughout the revolution, women had been frontline in terms of support, in terms of, they seem like little things when we talk about community support, but that's actually how not only conflicts are resolved, but communities thrive. Women are the building blocks of them. We know that. And so I started really looking at the data because in my mind, and I joked with you about this earlier, you will all think I'm very naive, but in my mind, I wasn't leaving medicine for a long time. I just assumed people didn't know the data about women's rights. So I was going to tell them, I was going to solve all the problems, and I was going to go back to being a doctor in 5 years tops. And here I am 15 years later, like, what is happening? But I started looking at the data, especially around conflict resolution, and one thing stuck out to me the most, and that was that 90% of conflicts reemerge within 5 years. And they are 35% more likely to last peace treaties to last 15 years, if only one difference, and that is the inclusion of women at the agenda setting phase. And for me, that was like, but for me, that was remarkable. It really was. It was, why are we invest billions of dollars. Conflict is the most costly. We invest billions of dollars in peace processes. And yet, if we're just having it reemerge within 5 years, why are we not making this one change? And a huge part of it, I think the reason and we can look at it from multiple spaces, right? If in order to have women engaged at the conflict resolution setting, you're talking about the importance of girls' education and the recognition that when girls are educated, they're more likely to space out their children, marry later, have less children, vaccinate those children, have economic return in their communities. Women reinvest 90% of their income in their community, as opposed to men who reinvest 30 to 40%.
What are they doing with the other 60?
You're asking me. No. But it's this domino effect of, if we're really talking about elevating and amplifying the agency of women, we have to start talking about what we're doing before they even get to those positions to be able to hold power. And for me, that's girls' education, and that's women's reproductive rights. If you are telling a young girl at any age, we want you to be politically engaged, economically empowered. We want all of these things from you, but you are also telling her you do not have ownership or right or power over your most fundamental piece of yourself, your own body. Then I think it's so hypocritic. That's where it starts. And so an investment in women's reproductive rights, we know empirically, we know anecdotally, is one of the strongest driving factors for women's power and agency, and ultimately for security.
And let me flip that around a little. You mentioned at the start that there's a link between preventing women's access to reproductive health care and the rise of autocratic regimes. Why is that? What's going on with that link?
It's been interesting. Over the past 2 years, a lot of studies have been happening over what we're calling the silent pandemic, which has been the degradation of women's rights. And there has been a surge in, violently misogynistic rhetoric. There has been a surge in the reversal of rights that have been hard won by women. And a huge part of it is, and this is going to sound very critical, and I don't mean it to, but is that one side organizes at a community level and defines itself very much in black and white. It is either for or against something fundamentally, and that is actually empowering to people that agree with that. There is no gray area. They know exactly what they're fighting for. They know exactly what they're getting. And that has been a very effective mobilizing tool politically. And on one side of that, it is that women's rights have led to a degradation of family values. It has reduced the rights for men. And that rhetoric has been very empowering.
And is that something that was observed in Libya with the rise of Gaddafi?
Not quite. I mean, it's interesting that not quite. Gaddafi had he was, I think even by the West, seen as somewhat empowering for women because he claimed their role in military. I think what you did see with Gaddafi and what you see with many autocratic regimes, and I would argue many countries where there is where there is distrust of the political system, is you see people naturally step away from politically engaging. And that happened a lot with young women who were like, I don't want to get involved in this. And we're seeing that across the board, I think.
I'm curious about, and maybe this is something that you've been working on with the Bill and Melinda Gates Foundation, which I'd love to talk to you about as well, but have you seen a model anywhere in the world where girls, I'm going to rephrase that, a model where sex education is being taught correctly to both girls and boys?
I am not sure I would have that answer for you. I don't.
Is that an area that you're looking into at the Gates Foundation?
It isn't. It isn't. I think at the foundation there is a fundamental belief in the importance of a woman's right to choose and a woman's right to define her life on her own terms, and a recognition that a huge way in which we can ensure that is through maternal and child nutrition and through family planning support. We don't necessarily look at sex education. And I just remembering back when I was a kid, I was raised in Saskatoon, Saskatchewan, and I would argue my sex education, experience is probably not one that should be in books. And I would say the same for even my medical school, when we were talking about sex education in medical school. And so I don't know if there is a country that is doing it effectively. I do think there's a conversation we need to have about, especially in the debate of the last week, how much we hold men accountable for this conversation as well. The onus has been on women to speak up. It has been and very frankly, women's reproductive rights benefits men. When we see, if you look at kind of the biggest negation of women's rights, we notice that in those societies, men are likely to actually pass away sooner as well. We see that men are less likely to be as prosperous. We see that men are less likely to be as educated. Women's reproductive rights benefits men as much as women, and they should be fighting for it as much, they should be speaking about it as much, and they should be speaking about their experiences and how they have benefited from it. And that is something that I think is really critical.
As we move towards the end of this session, I'm going to throw a really big question at you, as compared to the previous questions I've asked you, which is, what do you think about the idea of health and wellness and whether there's a singular global definition of those terms? Or does each country have its own definition? And if so, how do you promote health across borders?
That's a very good question. I don't think there's a singular definition. And the reason I say that is because I don't think there's a singular definition even in families. Remember, I was telling my mom I was taking a self-care day. And she's had 11 kids, and she looked at me, she's like, a what now? What is a self-care day? You just choose to not do things? And I was like, no, Mom, I'm gonna have a bubble bath? I don't know. No, but I don't think there is a single definition. I think we need to, And I think this comes honestly to the question of community leadership and ownership. I think one thing we tend to do often in the international community, and having felt this as a community advocate and activist at my start, is we parachute into situations and we try to like solve it. We say, hey, this worked in country X, so it'll work in country Y. And we sit and we strategize and we think, and sometimes we'll consult the local community. And I think one way for us to come to an understanding of what health means to communities is to have community leaders at that table, defining it, architecting strategies, architecting policies. It is the difference between us having really innovative health solutions and innovative health solutions that actually have impact in community. And that's one of the things I hope this pandemic has taught us. It is one thing for us to do research and development. It's one thing for us to assess and understand a complex health reality. It is a fundamentally different thing for communities to actually access those innovations, access those therapeutics, access that care. And in order to do that, there has to be trust. And community leaders have that trust. They've been doing this work for a long time. So I would argue, I'm not sure we need a global definition for health, but we need to begin to respect and appreciate the importance of local definitions for health and of community leaders. We don't need to reinvent the wheel and become the communicator in communities. I think the most effective way we can, dispel misinformation and advance health equity is by actually going to people that live there, stay there, are sustainable leaders in that community and say, how can we work with you? How can we be in service of you? How can we work together to advance these priorities? But as long as we, I think, continue to look for, we don't have a global definition for anything. And so, I think it would be foreign to do that for health. I think we need to meet in the same way we want to meet governments where they are. We need to meet people where they are.
In our remaining minute or so, I want to ask you about that concept of trust, and maybe an appropriate way of sort of drawing a conclusion to this forum is to recenter the role of healthcare workers and how you've been to medical school, you've practiced medicine, and your husband continues to practice medicine. How can healthcare workers around the world better develop that trust in their communities, do you think? Does it start at medical school?
I think, that's an excellent question because a lot of them aren't even medical, they don't go to medical school. The vast majority of community healthcare workers don't, right?
Great point.
So we're looking at, midwife associations, we're looking at community healthcare workers, we're looking at these, and to lead into the importance of women's health, 70 to 80% of which are women in some of the most complex environments dealing with some of the most rampant diseases. And so I think a huge part of it is recognizing that it is a cycle. And if we're going to invest in healthcare workforce, we have to appreciate the gendered realities there, but we also have to appreciate that everybody, none of us would show up to work if we did not feel safe. I personally would not, right? And I think we have to be fair to the fact that if people are putting, in many cases around the world, their lives in danger, then we need to show up as a global health community and say, okay, what can we do to actually help? And for women, that is a particularly important point. So I think a huge part of it comes down to what are we investing in healthcare workers? What policies are we actually putting into place to protect them, to support them, to reinforce them? And ultimately, in the same way that we talk about investing in women's reproductive rights, in the same way that we're talking about investing in infectious disease R&D, I think regardless of what policies we pass or resources we put in, without healthcare workers, none of it goes anywhere. And so that should be where we put a lot of our energy. That's our front line of defense, if you will.
And thank you for that important corrective to my question. Of course, healthcare workers come in all different shapes and sizes and are not just doctors. So thank you for that.
As a doctor, it was very difficult for me to admit that.
And I think that's a great note for us to end on the role of healthcare workers and at this Global Health Forum generally. So thank you so much for sitting down with us today, Dr.
Thank you for having me.
Thank you for joining us today for the inaugural Foreign Policy Global Health Forum. Thank you to our strategic sponsors, Guarding Against Pandemic and Pharma, and our supporting sponsors, AstraZeneca, the Global Fund, IntraHealth, and Seqirus. Video from today's event will be available in the next 24 hours. Thank you.